investasi. Live-in by Mandiri menjadi yang pertama membantumu. Mencari rumah sesuai impian tanpa harus keluar rumah. Hanya dengan selangkah menuju rumah. Dan impianmu akan terwujud untuk bangun jadi rumah yang kamu mau. Lebih dari transaksi harian hingga hunian, inovasi Beyond Banking kami menghadirkan hiburan hingga lifestyle untuk menjauhkanmu dari rasa jenuh dan bosan. Bahkan membawamu merasakan pengalaman lebih menyenangkan. Kami berinovasi lebih jauh. Jauh menghargai semua yang kamu lakukan. Hargai lebih, mengembalikannya dalam bentuk yang berharga. Live-in Beyond Super App, inovasinya tak hanya sampai di sini. Kami terus berinovasi dan memberikan pengalaman baru perbankan masa depan yang lebih jauh lagi. Temukan masa depan perbankanmu di Live-in by Mandiri Beyond Super App.
Kaki langit menuntun pengembaraan kami pada sebuah tempat yang dijuluki Benua Etam. Menurut bahasa Kutai, Benua Etam bermakna tempat tinggal kami, tempat kami berasal, dan tempat kami memulai peradaban. Benua Etam merupakan metamorfosa dari sejarah kegemilangan kerajaan Kutai yang penuh misteri. Dari sejarah ini, lahirlah 3 kabupaten kota yang memiliki kekayaan alam yang mempesona, yaitu Bontang, Kutai Timur, dan Kutai Kartanegara. Kekayaan alam dan pertambangan yang berlimpah ruah membuat ketiga kabupaten kota ini tumbuh dan mekar pesat di berbagai sektor. Namun stunting masih menjadi salah satu masalah yang harus segera diatasi. Sebanyak 468 mahasiswa Poltekkes Kemenkes Kaltim yang merupakan calon tenaga kesehatan dari 5 jurusan yang berbeda, yaitu keperawatan, kebidanan, teknologi laboratorium medis, gizi dan promkes, bersatu padu untuk terjun mengemban tugas yang diberikan oleh institusi. Mereka mencoba menggali masalah dan memaksimalkan potensi yang ada untuk menurunkan angka kejadian stunting serta meningkatkan kesehatan warga sekitar. Dari sinilah perjalanan awal pengabdian mereka pada negeri tercinta ini dimulai. Berpegangan pada alur KKN-TIPE, kami melakukan perjalanan untuk mendapatkan data di puskesmas. Setelah data tercatat dengan baik dan lengkap, kemudian kami segera melakukan proses validasi langsung kepada warga. Tentunya ada banyak kendala yang kami hadapi saat berinteraksi secara langsung dengan warga, sehingga berbagai macam metode pendekatan pun dilakukan, agar warga menerima kami dengan tangan terbuka. Proses inilah yang menggiring kami untuk menciptakan suatu inovasi. Sebagai langkah awal, kami melakukan penyuluhan guna mengenalkan stunting kepada warga. Kemudian kami gali potensi sumber daya hayati yang ada untuk menciptakan makanan sehat sebagai tambahan makanan bagi anggota keluarga. Setelah itu kami mempromosikan makanan sehat tersebut agar warga dapat membuatnya dengan mudah. Akhir dari kegiatan ini, kami melakukan lokakarya mini. Kami mempresentasikan semua pencapaian yang telah kami dapatkan selama KKNT IPE ini berlangsung. Terima kasih kami ucapkan kepada semua pihak yang telah membantu kami. Ada banyak sekali pengalaman hidup yang kami dapatkan. Sebab setiap proses yang kami lalui akan terpatri dalam hati dan ingatan. Sebagai bekal saat kami menjadi tenaga kesehatan yang seutuhnya nanti. KKNT IPE Poltekkes Kemenkes Kaltim tahun 2023.
Assalamualaikum warahmatullahi wabarakatuh. Saya Dr. Erianida, Kepala Puskesmas Muara Muntai. Dalam hal ini mengucapkan terima kasih yang sebesar-besarnya kepada Poltekkes Kemenkes Kaltim dengan adanya KKN adik-adik dari mahasiswa dari Poltekkes Kaltim. Yang pertama-tama mungkin yang bisa saya sampaikan adalah kami sangat bersyukur dengan adanya mereka, karena selama ini kami belum pernah menerima anak-anak atau adik-adik untuk ber-KKN di puskesmas kami. Jadi ini merupakan hal yang baru bagi kami. Mereka cukup sangat membantu kegiatan-kegiatan kami, baik itu di dalam gedung maupun di luar gedung. Harapannya nanti ke depannya ada lagi hal-hal seperti ini, kegiatan-kegiatan seperti ini yang merupakan bentuk kerjasama antara Kemenkes Kaltim dan Dinas Kesehatan, khususnya Puskesmas Muara Muntai, dalam mengirimkan adik-adik atau anak-anak dari Poltekkes Kemenkes Kaltim untuk magang atau ber-KKN di kecamatan kami. Mungkin itu saja yang bisa saya sampaikan. Saya akhiri. Assalamualaikum warahmatullahi wabarakatuh.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Saya Nasidi Sarjana Perawatan, Kepala UPTD Puskesmas Tabang. Alhamdulillah dengan adanya KKN terpadu dari mahasiswa Poltekkes Kemenkes Kalimantan Timur, kami merasa mendapat kehormatan puskesmas kami yang terletak di daerah terpencil ini di Kabupaten Kutai Kartanegara bisa menjadi lahan prakteknya mahasiswa Poltekkes Kemenkes Kalimantan Timur ya. Kami merasa senang karena mereka-mereka dari mahasiswa Poltekkes Kemenkes Kalimantan Timur tentu membawa ilmu-ilmu yang masih fresh, sesuai dengan standar akademisi, yaitu bisa merefresh pengetahuan kami, menjadi masukan kami untuk staf puskesmas Tabang ya, yang insya Allah itu akan menjadi tambahan ilmu bagi kami. Dan untuk pesan, semoga untuk kedepannya, tahun-tahun berikutnya puskesmas kami tetap dijadikan oleh Poltekkes Kemenkes Kaltim sebagai lahan KKN-nya mahasiswa dari Poltekkes Kemenkes Kaltim ya. Harapannya mahasiswanya juga akan ditambah lebih banyak lagi, dan juga tentunya waktunya kalau boleh diperpanjang lagi. Mungkin itu saja, tidak perlu panjang lebar. Semoga ini bermanfaat. Wassalamualaikum warahmatullahi wabarakatuh.
Selamat pagi, salam sejahtera bagi kita semua. Perkenalkan, saya Desi Kristiana Dewi, SKM dari Puskesmas Kecamatan Tabang, dan saya selaku TPG atau tenaga pelaksana gizi di Puskesmas Kecamatan Tabang. Nah, di sini saya ditunjuk sebagai pembimbing lapangan dari mahasiswa KKNT IPE Poltekkes Kemenkes Kaltim tahun 2023. Saya merasakan manfaat yang luar biasa dari kedatangan adik-adik mahasiswa ini dalam melakukan kegiatan KKN di Puskesmas Kecamatan Tabang. Selain mereka melakukan proses memperoleh data dan pembelajaran selanjutnya, mereka juga ikut terlibat dalam proses dunia kerja, di mana mereka merasakan suatu proses yang berbeda ketika di kampus dan di dunia kerja. Nah, di sini saya menilai bahwa mahasiswa memiliki keaktifan yang baik, terlebih khusus mereka memberikan inovasi yang sangat berguna bagi masyarakat. Setelah mereka memperoleh data, mereka memberikan inovasi-inovasi yang bisa bermanfaat untuk masyarakat. Di sini kita berbicara tentang stunting. Kemarin adik-adik mahasiswa sudah melakukan validasi data dan mereka lanjut kepada proses inovasi yang berguna. Apresiasi kepada adik-adik mahasiswa karena mereka memiliki motivasi yang baik ketika mereka terjun ke masyarakat. Nah, itu yang kita sangat harapkan, terlebih untuk kedepannya nanti. Pesan untuk adik-adik mahasiswa, mereka saya harapkan untuk bisa lebih banyak belajar lagi, terutama mereka harus menambah wawasan mereka dalam berinteraksi dengan masyarakat, karena ketika kita turun ke masyarakat, kita harus memperhatikan cara komunikasi kita serta cara kita memperlakukan masyarakat atau
Good morning, ladies and gentlemen. My name is Harahedna Chalula, and it is wonderful and precious for me to be your Master of Ceremony today in this virtual conference on November 21st of 2024. In our big event, the 4th East Borneo Health International Conference and the 4th International Conference on Lactation Management. In this beautiful moment, I would like to welcome all the participants in the virtual conference by Zoom meeting and live streaming on our YouTube channel. Requested to all participants in the Zoom meeting, please turn off the microphones and activate the camera during the activity. We have also sent a virtual background so that it can be used properly. And we would like to greet our incredible speakers. It is truly an honor to have you here. The Honorable Director of Health Polytechnic Ministry of Health, East Kalimantan, Mr. Dr. Management Haji Supriyadibe, Bachelor of Nursing, Master of Nursing. The honorable keynote speakers in this virtual conference are Ms. Melissa Cole, Master of Science, International Board, Certified Lactation Consultant from United States of America, Professor Dr. Muhammad Afzal Mahmud from Australia, Professor Dr. Azrina Binti Afzal from Malaysia, Ms. Melanie T. Reboldera, registered nurse, Doctor of Nursing Science from Philippines, Mr. Hengki Isahwan Ahmad Mulyadi Lai, PhD from Malaysia, Dr. Amina Toha, Bachelor of Public Health, Master of Public Health from Indonesia, Dr. Nusari Abdul Syukur, Bachelor of Applied Science, Master of Midwife from Indonesia, the Honorable Deputy Director of Health Polytechnic of East Kalimantan, 1st, 2nd, and 3rd, also along with all of the staff, the Honorable Head of Education Center, Head of Division and Subdivision from Health Polytechnic of East Kalimantan, the Honorable Head of Departments and Study Program of Health Polytechnic of East Kalimantan, the Honorable Lecturers and Educational Personnel, as well as all the webinar participants that we are proud of. Assalamualaikum warahmatullahi wabarakatuh. All praise and gratitude belong to Allah Subhanahu wa Ta'ala, who has been giving us guidance, happiness, and healthiness for us to hold our 4th East Borneo Health International Conference and the 4th International Conference on the Lactation Management. The theme of today's international conference is Integration of Health Transformation for Management and Prevention Strategies of Non-Communicable Diseases. All participants can see this conference via Zoom meeting and live YouTube streaming. This webinar is organized by Health Polytechnic of East Kalimantan with more than 1,000 registered participants and support by one of our sponsorship from Bank Mandiri. Ladies and gentlemen, let's begin our webinar by reciting the Basmalah. Bismillahirrahmanirrahim. Next is a dance performance by UKM Tari of Health Polytechnic of East Kalimantan. The Hornbill Dance, or commonly called the Enggang Dance, is a dance of the Dayak Kenyah tribe of East Kalimantan. The Hornbill Dance is a mandatory dance in every traditional ceremony of the Dayak Kenyah tribe. The Hornbill Dance depicts the daily life of the Hornbill, which is usually performed by young women of the Dayak Kenyah tribe. I repeat, the audience is asked to take a perfect seating position. Audience are asked to sit back and relax. In order to have our seminar run conducively, let us invite Mr. Nurse Badar, Master of Health, to lead us in prayers. To Mr. Badar, the time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Let us pray to Allah Subhanahu wa Ta'ala, the God Almighty. Allow me to read this prayer as Muslim, and the others can be adjust yourself according to your religion each other. To begin this prayer, let's read Ummul Quran Al-Fatiha. A'udhu billahi minasyaitanir rajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Ar-Rahmanir Rahim. Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Amin ya rabbal alamin. Alhamdulillahi rabbil alamin. Hamdan syakirin, hamdan na'imin, hamdan yuwafi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamd kama yanbaghi li jalalik wajhikal karim wa 'azimi sultanik. Allahumma salli ala sayyidina Muhammadin fil awwalin wal akhirin. Wasallim ala hadzal nabiyil karim wa ala alihi wa ashabihi ajma'in. Allahumma antas salam wa minkas salam wa ilaika ya'udus salam fahayyina rabbana bis salam وأدخلنا الجنة دار السلام تبارك ربنا وتعالى يا ذا الجلال والإكرام. اللهم افتح لنا أبواب الخير، أبواب البركة، أبواب النعمة، أبواب الرحمة، أبواب السلامة، أبواب الصحة، أبواب العافية، أبواب القوة، أبواب العلم، أبواب الرزق، أبواب الجنة برحمتك يا أرحم الراحمين. اللهم إنا نسألك الهدى والتقى والعفاف والغنى، ونسألك علما نافعا وعملا متقبلا ورزقا حلالا طيبا. اللهم إنا نسألك سلامة في ديننا وعافية في جسدنا وسيادة في علمنا وبركة في رزقنا وتوبة قبل الموت ورحمة عند الموت ومغفرة بعد الموت. اللهم حوين علينا في شكرات الموت والنجاة من النار والعفو عند الحساب. ربنا زدنا علما وارزقنا فهما واحلل عقدة من لساننا يفقه قولا. اللهم ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. وصلى الله على سيدنا محمد. سبحان ربك رب العزة عما يصفون wassalamun alal mursalin walhamdulillahi rabbil alamin. That's all. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Next, we would like to invite our Director of Health Polytechnic of East Kalimantan, Mr. Dr. Management Haji Supriyadi Bey, Bachelor of Nursing, Master of Nursing, to deliver a welcome speech. To the Honorable Mr. Supriyadi, the time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah wa ala alihi wa sahbihi wa man walah, amma ba'du. The Honorable, the Deputy Director in Health Polytechnic of East Kalimantan, the Honorable, all the speaker, the Honorable, the Head of Study Program in Health Polytechnic of East Kalimantan, the Honorable, Director of Hospital in the Province of East Kalimantan, the Honorable, Rector and Director of all health education institution in the province of East Kalimantan, the Honorable, the Head of Professional Association and Organization, and all participants of international seminar who have participated in this international seminar through Zoom. At first, let us thank to God Allah Subhanahu wa Ta'ala who give us the healthy so we can gather in this place. Moreover, let us praise salawat and greeting to Prophet Muhammad sallallahu alaihi wasallam. Allahumma salli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. Ladies and gentlemen, Today, we live in a world of convenience in meeting and gaining knowledge through cyberspace. Even today, we are able to connect between countries and nations through international seminar using Zoom application. The main theme of today's international seminar is about integration of health transformation for management and prevention strategies of non-communicable diseases. Ladies and gentlemen, following the COVID-19 crisis through 2020 to 2021, World Health Organization data showed that 74% of death per year were caused by non-communicable disease, which include heart disease, stroke, cancer, diabetes, and chronic lung disease. Therefore, the Minister of Health of the Republic of Indonesia has initiated a transformation in the health sector, consisting of the transformation of primary care, transformation of the referral services, transformation of health security system, transformation of health financing system, transformation of health human resources, and transformation of health technology for reducing and preventing the case of non-communicable disease. Primary care transformation is key focus of the health transformation, aiming to enhance preventive and promotional activities, improve health screening, and increase primary care capacity. A non-communicable disease program has been launched to prevent illness and manage risk factor. Collaboration with government, Fort Health Office, Health Polytechnic, TNI, Polri, and stakeholder is essential for achieving the target. The program aims to prevent obesity, hypertension, diabetes, cervical cancer, breast cancer, and sensory disorder. By 2022, the non-communicable disease program aims to target 94 million people aged less than 15 years with 31 million people achieving 33% of the target. Indonesia's health transformation also aims to improve the quality and equity of health services in all areas, with focus on specialized service for the four most common diseases: heart disease, stroke, cancer, and kidney disease. The Ministry of Health has set a target of providing health services for this disease in 514 districts and cities. The health resilience system transformation aims to increase the resilience of the pharmaceutical and medical device sector by producing routine vaccine, top 10 drug and top 10 medical devices, and strengthening emergency response resilience through artificial intelligence-based surveillance and crisis preparedness exercises. The health financing system transformation focus on providing easy and equal access to health services, especially for the underprivileged. The regulation aims to ensure ability, adequacy, sustainability, fair allocation, and effective utilization. Ladies and gentlemen, the transformation of health human resources aims to ensure equitable distribution of health worker across Indonesia, including in daerah perbatasan dan negara lain, daerah kepulauan terpencil dan terluar. The Health Ministry's priority program aims to increase the percentage of regional hospital with specialist doctor from the target 80%, which has been achieved to 73%, and improve the competence of human resources by improving nine priority of one non-communicable disease from the target of 20,000 people and has been achieved to 44,000 people. Indonesia Health Technology Transformation launched on August 2022, focus on using information technology and biotechnology to identify potential disease early and provide precision medicine. The Biomedical and Genome Science Initiative use genetic information technology from human and pathogens or whole genome sequencing to improve disease detection and treatment. Non-research centers are involved in biomedical and genome science initiative focus on disease like cancer, infectious disease, stroke, diabetes, and psoriasis. Ladies and gentlemen, the main theme of today's international seminar is integration of health transformation for management and prevention strategies, non-communicable disease. Therefore, we are invite several speakers who are truly competent in their field. The first, Professor Dr. Azrina Azlan from Selangor, Malaysia. Second, Melanie Reboldera, registered nurse from Philippines. Third, Dr. Hengki Isahwan Ahmad Mulyadilai, PhD from Malaysia. Fourth, Professor Dr. Muhammad Afzal Mahmud from Australia. Fifth, Melissa Cole from America. Sixth, Dr. Aminah Toha from Polytechnic of East Kalimantan. And seventh, Dr. Nursari Abdul Syukur from Polytechnic of East Kalimantan. Through this seminar, we hope that it can improve our knowledge about the effort that we can do optimize the management of health transformation in Indonesia, especially for reducing and preventing the case of non-communicable disease. We are very grateful to the participants who have enthusiastically participated in this seminar. I also thank to all speakers who have spared their time to share their knowledge to us. And thank you to all deputy directors, the head of division and the head of study program in Health Polytechnic of East Kalimantan, and the committee for organizing this seminar. I hope that this seminar will provide many benefits, especially in updating information about the management of health transformation for preventing and controlling the non-communicable disease for all of us. Amin ya Rabbal Alamin. By hoping for the blessing of Almighty Allah, I officially open this seminar. Success for Health Polytechnic of East Kalimantan, and thank you for today. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to the Director of Health Polytechnic of East Kalimantan, Mr. Dr. Management Haji Supriyadi Bey, Bachelor of Nursing, Master of Nursing, for officially beginning our international conference. Next, we have a short break to show the profile video of our sponsor, Bank Mandiri, and display student activity video of Poltekkes Kemenkes Kalimantan Timur.
Seringnya kita melihat masa depan kejauhan, padahal masa depan itu ada di depan mata kita. Inovasi yang terdepan, tercepat, meninggalkan yang lainnya. Inovasi itu ada di HP kamu, di aplikasi kami. Living by Mandiri, inovasi Beyond Super App, yang mengedepankan semua kebutuhan. Dari kebutuhan transaksi harian hingga hunian. Bersama ratusan fitur inovatif, buat kamu santai menjelajah kemana saja. Inovasi tinggal tap-tap kami, memudahkan perjalanan tanpa batasan. Dan saat akhirnya menemukan barang yang kamu inginkan, bayar dengan praktis. Meski terpisah jarak dan waktu, inovasi solusi pasti valuta asing kami menjauhkanmu dari rasa asing saat transaksi pakai mata uang asing. Dalam satu aplikasi, kami mudahkan langkahmu berinvestasi. Living by Mandiri menjadi yang pertama membantumu mencari rumah sesuai impian tanpa harus keluar rumah. Hanya dengan selangkah menuju rumah, dan impianmu akan terwujud untuk bangun jadi rumah yang kamu mau. Lebih dari transaksi harian hingga hunian, inovasi Beyond Banking kami menghadirkan hiburan hingga lifestyle untuk menjauhkanmu dari rasa jenuh dan bosan. Bahkan membawamu merasakan pengalaman lebih menyenangkan. Kami berinovasi lebih jauh menghargai semua yang kamu lakukan. Hargai lebih, mengembalikannya dalam bentuk yang berharga. Living Beyond Super App, inovasinya tak hanya sampai di sini. Kami terus berinovasi dan memberikan pengalaman baru perbankan masa depan yang lebih jauh lagi. Temukan masa depan perbankan di Living by Mandiri Beyond Super App.
Kaki langit menuntun pengembaraan kami pada sebuah tempat yang dijuluki benua etam. Menurut bahasa Kutai, benua etam bermakna tempat tinggal kami, tempat kami berasal, dan tempat kami memulai peradaban. Benua etam merupakan metamorfosa dari sejarah kegemilangan kerajaan Kutai yang penuh misteri. Dari sejarah ini, lahirlah 3 kabupaten kota yang memiliki kekayaan alam yang mempesona, yaitu Bontang, Kutai Timur, dan Kutai Kartanegara. Kekayaan alam dan pertambangan yang berlimpah ruah membuat ketiga kabupaten kota ini tumbuh dan mekar pesat di berbagai sektor. Namun stunting masih menjadi salah satu masalah yang harus segera diatasi. Sebanyak 468 mahasiswa Poltekkes Kemenkes Kaltim yang merupakan calon tenaga kesehatan dari 5 jurusan yang berbeda, yaitu keperawatan, kebidanan, teknologi laboratorium medis, gizi dan promkes, bersatu padu terjun membantu tugas yang diberikan oleh institusi. Mereka mencoba menggali masalah dan memaksimalkan potensi yang ada untuk menurunkan angka kejadian stunting serta meningkatkan kesehatan warga sekitar. Dari sinilah perjalanan awal pengabdian mereka pada negeri tercinta ini dimulai. Berpegangan pada alur KKN-IPE, kami melakukan perjalanan untuk mendapatkan data di puskesmas. Setelah data tercatat dengan baik dan lengkap, kemudian kami segera melakukan proses validasi langsung kepada warga. Tentunya ada banyak kendala yang kami hadapi saat berinteraksi secara langsung dengan warga, sehingga berbagai macam metode pendekatan pun dilakukan agar warga menerima kami dengan tangan terbuka. Proses inilah yang mengiringi kami untuk menciptakan suatu inovasi. Sebagai langkah awal, kami melakukan penyuluhan guna mengenalkan stunting kepada warga. Kemudian menggali potensi sumber daya hayati yang ada untuk menciptakan makanan sehat sebagai tambahan makanan bagi anggota keluarga. Setelah itu kami mempromosikan makanan sehat tersebut agar warga dapat membuatnya dengan mudah. Akhir dari kegiatan ini, kami melakukan lokakarya mini. Kami mempresentasikan semua pencapaian yang telah kami dapatkan selama KKN TIPE ini berlangsung. Terima kasih kami ucapkan kepada semua pihak yang telah membantu kami. Ada banyak sekali pengalaman hidup yang kami dapatkan. Sebab setiap proses yang kami lalui akan terpatri dalam hati dan ingatan. Sebagai bekal saat kami menjadi tenaga kesehatan yang seutuhnya nanti. KKN TIPE Poltekkes Kemenkes Kaltim tahun 2023.
Now, to all participants, our next agenda is presentation from our keynote speakers. But before our speakers give the presentation, I would like to say for all participants, you have to make sure your microphone is mute and your camera is on so we can focus on our keynote speakers. The questions will be answered after all the keynotes has presented their presentation. Before asking the question, the participant could write the question in our comment section on Zoom or our YouTube chat section. The first session of panel presentation today are by Ms. Melissa Cole, Master of Science, International Board Certified Lactation Consultant from United States of America, Professor Dr. Muhammad Afzal Mahmud from Australia, Professor Dr. Azrina Binti Aslan from Malaysia, and Ms. Melanie T. Reboldera, Registered Nurse, Doctor of Nursing Science from Philippines. And now, let us welcome our moderator, Dr. Dwi Prihatin Era, Bachelor of Nursing, Master of Nursing, Specialist of Medical Surgical of Nursing. To Dr. Era, the time is yours.
Okay, thank you Hera for the wonderful introduction, and now we are going to the heart of our event, and it is the presentations by our distinguished speakers. They will share their expertise and insights, and hopefully that we could implement the knowledge into the field of healthcare in East Kalimantan, Indonesia. The particular focus on this program is lactation management and diabetes mellitus, and all the speakers will share to us their knowledge that undoubtedly broaden our understanding of these important health issues. And now we go to our first speaker. She is Melissa Cole, Master of Science. Is Melissa already here? Melissa? Hi, Melissa. Am I audible, Melissa?
Yes, but can you hear me okay now? Oh,
Hi.
hello everybody.
Hi.
Hello from Portland, Oregon, United States. Hello.
Hello. Okay, audience. Melissa's goal is an expert in lactation and therapeutic herbalism with some research in the field of lactation. Thank you, Melissa, for being here with us. And it seems that because of the time difference between us, that I have to greet you with good evening.
Yes, it is dinner time here, and I think breakfast time for everyone there. But it's an honor to be here with everybody. Thank you.
It's ours. It is glad for us to know that you look in a good condition, and also us here in Samarinda, in East Kalimantan in Indonesia. And it is been our honor, yeah, truly our confidence that in this era that we can effectively and efficiently share knowledge and get valuable opportunities each other, of course for us to listen to the knowledge from an expert like you. And we hope that your experience as a permanent academic expert in the science of lactation management could be insightful for us. And without further ado, Melissa, I would like to welcome you to start your presentation. And please allow us to remind that your time is 60 minutes. Thank you, Melissa.
Okay.
And please
Thank
welcome
you for the
Melissa
beautiful, warm welcome. I'm going to share my slides now.
Thank you.
And let me know if there's any technical issues. Okay, one moment, please. Okay, hopefully everybody can see and hear everything, and I will go ahead and get started about this very important topic, this international conference on health transformation and prevention of non-communicable diseases. This is important information for all of us around the globe, right? We all have human babies, human parents that deserve our support. I would like to discuss human milk as prevention for allergic and gastrointestinal diseases, common infant digestive concerns, and useful support. We know globally there is a rise of GI disorders, things like irritable bowel, food allergy, intolerances, reflux, other issues that babies and even through the lifespan adults continue to deal with, and how can breastfeeding and human milk be an important part of preventing these diseases. Okay. So, a few of our learning objectives for today include describing the basic enteric nervous system. This is a part of our anatomy, and I will describe it in detail, and the role that human milk plays in furthering develop this anatomical system. We'll discuss normal and abnormal digestive patterns. This is maybe a challenging talk for first thing in the morning, discussing digestion, but we'll do our best. And identifying health benefits of human milk. Thank you. Okay. First, I just like to share with my colleagues around the globe. This is a picture of my office, and actually I'm sitting in the same office, and these are my 3 children. 2 of them are going to college and working, and my last one is still in high school. So they all have received human milk through their life, but not anymore. Okay, so what is a healthy gut? What do we think about healthy digestion? I like the term from this researcher, Stefan saying gut health is having good digestion and absorbing our nutrients, having absence of GI illness, normal and stable intestinal microbiota. So good bacteria, fungus that helps our gut, it should be there. Effective immune status. Most of our immune system is in our gut, and we'll talk about that, leading to a state of well-being. So let me take you on a little tour of the development of the digestive system so we can have a good understanding of many aspects. So starting in the mouth, our digestion begins in our mouth, not our stomach. Babies have ample lingual lipase, right? This is a salivary amylase, lingual lipase that help them break down milk. They do not have many enzymes yet in the liver or pancreas yet. They're still developing, so they rely a lot on their salivary enzymes. The esophagus, okay, the tube right from our mouth that connects to our stomach, it starts small, but it is doubling from age 0 to age 3. So there is so much digestive growth these babies are doing. In addition, the esophagus has a lot of nerves that help move our food down with control. Now we go from the esophagus to the top of the stomach, the lower esophageal sphincter. This is important, especially for babies, because they often have low esophageal tone, meaning it's easy for the food to come back up. So this is easy for babies to kind of have some milk in their stomach and spit up. For some babies, this is not a problem. For other babies, it creates a lot of feeding discomfort and issues with digestion and absorption. Now we move from the esophageal sphincter to the stomach itself. Okay, so many of you, I think, are health students, health professionals, so this is maybe not new information, but bear with me. When a baby is full term, about 40 weeks, right? Their stomach capacity is maybe 20-30 milliliter maximum. This is even with it stretched. They also do not have relaxation of these muscles until they're about 3 days old. So that is why our newborn babies, they need 5 milliliter, 10 milliliter, 15 milliliter. They need small feedings, right? They don't need a big bottle of formula yet, right? They need small amounts of human milk. By around day 3, the stomach is more relaxed and they can take more food and push food through. Human milk stays in the stomach about 1 hour and then it is emptied out. So this means babies, they want small amounts of milk, but very frequently. Okay. The next point, hydrochloric acid, right? Our stomach acid. When babies are born at birth, the acidity, the pH of this acid, is a little bit higher because we want them to digest and kill any bad pathogens. Some evidence says babies born early or with a cesarean delivery maybe have higher pH to their stomach acid, but the evidence is mixed. We do know when there's chronic stress, so think about a baby in the neonatal intensive care unit or born with maybe some problems, they can have decreased acid and other deficiencies that impact their digestion. So this is why we want to really be mindful of how we are supporting birthing mothers, how we are keeping the stress down and giving them ample support in these early days, because it also matters for their long-term digestive health. Okay, we are moving through to the small intestine. This is a big part of our digestion. We have a lot of enzymes, especially from the pancreas, that are breaking down fats and proteins. I love that some of my other colleagues will be speaking about diabetes and other metabolic issues, because all of this is important, right? How we feed babies can also set them up for metabolic success. Right, in the small intestine, there are what we call villi, so little finger protrusions that help bring the food into the bloodstream, the nutrients into the bloodstream. There's a lot of lymphoid cells that help develop our immune system. So when we think we get sick, we think our nose, our throat, our ears, but much of our immune system is actually in our digestive tract. Okay, moving further to the colon. The colon takes more fluid and nutrients and absorbs it into the body. It also makes some of our essential fatty acids. That's very important. And this is something I think is interesting. Over 70% of our immune system is here, our gut-associated lymphoid tissue. So it's important not only for digestive health, but for chronic autoimmune conditions. So the whole point of this conference to really explore how we can help prevent non-communicable diseases. I think a lot of that can start in our gut and reducing inflammation and the autoimmune disease process by supporting and encouraging healthy lactation. Okay, now this is where I get very excited. Excuse me. I like talking about the enteric nervous system. You'll see in my slides ENS. The enteric nervous system is part of our gut that is really the lining of our GI tract. When a parent is pregnant, about 8 to 12 weeks in a pregnancy, this is when the embryos beginning to develop their enteric nervous system. So very early in a pregnancy, this is why the parent's diet, stress, medication, things like alcohol or smoking or other lifestyle habits can impact the developing embryo's digestive tract even at this young age. All right, there's millions of neurons, and these do a lot of different jobs. They control how food is moving through the stomach and the intestines. They help release enzymes to break down our foods. And they're also detecting nutrients and fluid to absorb. So this enteric nervous system is the lining of our entire GI tract, and it is so important. It produces the majority, more than 30 neurotransmitters, 90% of our serotonin, 50% of our dopamine. So when we hear gastroneurobiology, we're thinking the gut-brain connection is so important. The health of our stomach and our gut is also connected to the health of our brain. So when I talk about lactation in human milk and gut development, it's everything. Physical health, mental health. It's a big part of how we become who we are. Now, as this enteric nervous system is developing in the baby's GI tract, it is very sensitive. It's a sensitive body system. It's sensitive to things in our environment, chemicals, sensitive to the parent's health, both the father and the mother's health, to stress. And it does a lot of work. Inside the gut, we have lots of good and some bad bacteria, good fungus. We have different things that are growing that actually communicate a lot of things to our brain through the enteric nervous system. It helps us sleep better, supports immune function, memory, mood, prevents autoimmune and inflammatory diseases in many cases. So we want to be mindful about stress and inflammation during the development of this enteric nervous system. Okay, so that was our little tour through the gut. Now, the most important years of developing our gastrointestinal health is the first 2 years. So conception through 2 years of age is the most important time of digestive health development. This is when we have factors from, you can see in the slide, the pink circle, nutrition, the microbiome, so the bacteria that's present in our stomach, and the epigenome, so genetic factors from the parents or things in our environment that have epigenetic changes that can occur. So when we're thinking about digestive health, the maternal and perinatal factors that matter are the health of the parents, the father, the mother. How is their health? How is their gut health? That will translate to their child. Okay? Things like nutritional status, right? This is why it's so important we are working to relieve hunger and improve nutrition around the globe. Vitamin D. Mode of delivery, is the baby born vaginally, cesarean? This changes the kind of bacteria that colonizes their gut. Skin-to-skin contact, right? The baby being skin to skin with the parent's chest helps them share common bacteria that's good. And then what food the baby is eating. Do they have breast milk, formula, combination? This really changes their gut and the development of the enteric nervous system. So first 2 years are very critical for GI support. Okay, so some of my favorite things are talking about how human milk is really a public health mission, right? The more babies we can get human milk to, the better off we will have global health. So in human milk, there are many factors, there are many parts of human milk, components of human milk that impact directly to the digestive system. So human milk, so the baby drinks the human milk. It then makes neurons in their gut have better motility, move food through more, release more enzymes, improve neurotransmitter production. So this is very different than if a baby does not get human milk. It increases how neurons grow, and it increases how these cells support and move in the GI tract. One thing that is my favorite fact is that no baby's gut will be as good as it possibly can be if human milk does not touch the gut, because it does increase more neuron development. So especially our babies in the NICU, our babies that are born very prematurely or with health conditions. Human milk is medicine for these babies, and it further develops their GI health. Okay, a few more things about how amazing human milk is. Human milk helps grow biofilm that lines the gut. So we know we have sort of mucus and coatings that protect the gut. Human milk makes this grow even better. It helps develop IgA, and that's important for the gut lining and our immune system. Human milk has good bacteria and food for bacteria to grow in the stomach. Right. And human milk is also part of the baby's developing immune system. When the mother is exposed to some illness, some virus, some pathogen, and her baby's mouth touches her chest, her body starts to make antibodies customized for the baby. This is why the parent and the baby are so connected to each other. They are always helping develop the baby's immune system through the parent's environment and the baby's mouth, through the mammary-associated lymphoid tissue. Right? Isn't nature so amazing? Okay. So let's talk about some babies that have problems. Now, I don't know if this is true for Indonesia, but this is a US-based study, and it looked at babies ages 0 to 6 months. And they found that half of the babies had some type of functional gastrointestinal disorder. Functional meaning the baby didn't have to be in the hospital or have a surgery. So they're functional, they're doing okay, but they have issues with regurgitation and reflux, so spitting up. Colic, so a baby that's crying so much, mostly because their stomach hurts, but they're crying and crying. Constipation, the baby who is not having a normal bowel movement easily and regularly. Or the opposite side, diarrhea, the baby who is having too loose, watery stools. Another term on this list, dyschezia, This means the baby has a normal bowel movement, but has a lot of pain and animation, and they're very uncomfortable. And then, of course, vomiting. So I think that's very sad that half of babies born, at least in the United States, this is not a global study, might have one or more of these digestive problems. And I think it's sad because it also means we might see that as adults they struggle with unhealthy digestion, which can segue into other types of autoimmune issues stemming from poor gut health. All right. What are some other things that these functional gastrointestinal diseases might cause? Certainly we can see parents become anxious and worried about their child. Is my baby okay? We can have short and long-term health consequences for a baby who is always feeling pain and discomfort. We might find the family stops breastfeeding because they're worried the breast milk is hurting their baby's stomach, or they're not sure their baby's getting enough food. So we might have families stop giving human milk because they're worried it's hurting their baby's stomach, which is not based in science. And we might have families that have to go to the doctor a lot, which is a burden on healthcare from both the government and the family standpoint, because it can be very expensive to have many medical visits. Right. So what causes these digestive problems for babies? Certainly it can be physiological. They can be premature. They can have poor motility, so the food is not moving through the stomach and the guts easily. We will talk about that. Dysbiosis, so good and bad bacteria is not balanced. Maybe there's some issues with food allergy or sensitivity. We'll talk about that a little bit. Behavioral. So many of us know if we feel stress or anxiety, our stomach can hurt, right? Maybe we have some stress-related stomach issues. So can babies. So babies who are dealing with a difficult temperament, or there is increased parental anxiety in the home, those babies can demonstrate increased digestive issues. And of course, we talked about environmental issues before, the parent's health, parent's nutrition, environmental factors, how the baby was born, what they're eating. There's many causes, but I think around the globe, we have an increase in the number of babies who are dealing with some digestive discomfort. That also could possibly be an indicator for later life health issues. So I love everyone here today. I think there's more than 900 participants committed to improving public health and hopefully thinking about the benefits of lactation support, because human milk can really be a medicine for these babies and prevent future disease. All right, so sorry for early in the morning discussing gut health, but I want to talk a little bit about what's normal and not normal. So babies, by the time they are about 30 weeks in pregnancy, they should have the ability to move things through their digestive tract, to be able to swallow amniotic fluid and excrete it. So babies by 30 weeks of development should be able to have digestive tracts that have motility and move food through. Now, we also know babies that are getting human milk as opposed to formula might have more copious bowel movements in a healthy way. So up to 25 to 78% of newborns 0 to 3 months should have bowel movements 3, 4 plus times a day. The researchers in a few of these studies listed below found about 15 to 42% of babies have bowel movements about twice per day, and then 6 to 31% one time a day or less. But what you can tell is that babies receiving human milk should have good motility to work food through with ease, comfort, and regularity. This is one 2018 study. I'll just compare it quickly for you. They looked at 40 exclusive breastfeeding babies and 13 exclusively formula-fed babies. And what the numbers show is that at 1 month, the babies receiving breast milk, breastfed babies, were having much more regular bowel movements, 4.9, so about 5 or more, give or take a couple of bowel movements, compared to the formula-fed babies that were having about half that. Okay, so that's telling us even if the volume of food is the same number of milliliters per baby, give or take, we might see slower motility, maybe some increased inflammation, and some other factors that might go into why human milk-fed babies have more regular bowel movements than formula-fed babies. And I also want to comment, as a clinician, and you could see I was working today, I work with many babies that absolutely need formula as a food. We do not want to make formula seem like the enemy. We want to have a safe food when we do not have enough human milk. But I just want to highlight the point of this talk in showing the human baby's body is designed for human milk, and we will see better outcomes with digestive health, enteric nervous system development when a baby is able to receive human milk. I'm also very aware that we have babies who might not be able to receive human milk, so we support them the best we can, and we try to optimize their digestive health the best we can as well. Okay, so we're going to talk just a little bit about diapers, about spitting up. We're going to look at 2 case studies quickly before we wrap up this particular talk. So a few topics about gut motility and bowel movements. When a baby is not having enough defecation or bowel movements, we want to make sure that they're getting enough food, right? Making sure the baby's not hungry. After that, many times if they are not having regular motility, they might have poor gastrocolic reflexes or impaired motility that we'll talk about in a moment. Babies that have excessive mucus in their stool, there's often something causing some increased inflammation, some increased intestinal inflammation especially. Older babies, it could be a virus or teething. But this is why we can be good clinicians and health professionals when we are listening to what parents tell us. Maybe we are able to visually see a bowel movement sample, or we're seeing a newborn that we're working with, so we can help families get the best care they need. Blood in the stool. Babies that have some inflammation, increased stress can cause some internal bleeding. We can have swallowed maternal blood if the baby has been breastfeeding and they swallow some blood. But we want to be mindful if there is excessive bleeding, obviously they need to see a medical doctor promptly. But some babies simply have microscopic bleeding that is usually due to irritation, inflammation, often secondary to a protein intolerance. Green bowel movements are usually indicative of rapid elimination, meaning something is irritating, so they're moving it quickly through the GI tract. Could be also due to viruses or teething, okay, or food intolerance, but this is where we're trying to be very good detectives. All right, the last 3 are a little bit more medically important. A baby that has oily bowel movements appearance, so it looks like grease or oil. This could indicate a lack of pancreatic enzymes, a pancreatic blockage or issue, even cystic fibrosis. So we always want these children to be medically checked out. For a newborn, having gray or white bowel movements would possibly be a bile obstruction, and we would want for them to also see a doctor. And certainly a baby that has never passed a bowel movement would be a medical emergency, as they may have some true nerve issues through their colon. So we want to be mindful about all types of digestive health, and sometimes talking about, these things that are important in working with newborns is part of helping us screen who might be dealing with more digestive issues. Okay, I want to talk about motility. So we talked about the enteric nervous system and food being moved through the digestive tract. This is important because we want waste to be eliminated, right? We want to have good bacteria, and we don't want to have waste just sitting in the stomach and the intestines. So how can we support babies who are not having good motility? Certainly we can try to help give them as much human milk as possible and help set their parents up with healthy lifestyle options that can also translate to good gut health those first 2 years of life. But some things we can do to support motility on a practical level. So I have my baby doll here. You can see this picture. We can do manual massage techniques like clockwise stomach massage, right? It's also important for babies to spend time on their stomach when they're doing some playtime, tummy time on their stomach. That also supports good motility. Right, we'll talk a little bit about probiotics and good bacteria. So we want to help babies sort of move food through having good motility. Right, you can see this mother and baby in the corner doing some tummy time. So the mom is laying on the floor, the baby's on the floor, and they're talking to each other. But this is excellent, not just bonding time. The baby is getting pressure on their stomach. They are being able to move, lift their head, which is also important for muscles of feeding. So having some time where the baby is on their stomach safely, right, is also very useful for gut motility. Other things that can be useful in supporting the vagal nerve. So for those of you who are health professionals or health students, hopefully you remember your cranial nerves, and our vagus nerve is one of our longest nerves, right? It's our longest cranial nerve that really innervates everything from the larynx, the esophagus, the digestive tract, all the way to the pelvis. And things that support this nerve have been shown in adult populations to help with adult GI issues like irritable bowel syndrome or disorders. And so with babies, we also think we can maybe try some of these ideas. Things like singing, humming, it's more the vibration, the that really kind of vibrates the vagal nerve. Being outside or brief exposure to cool air. Movement, right? Dancing with your baby, massaging your baby, just getting hands on, lots of pressure points, the tummy massage can actually be very helpful when babies are dealing with some discomfort. Skin to skin, especially with a newborn baby, having the baby with no clothes, just a diaper, right, on the parent's bare chest can be very helpful. And the tummy time, like I show in that picture. And I also want to mention probiotics. So there was one study that looked at the pH of fecal matter from babies. So the pH in bowel movements, the acidity from 1926 to 2017 has changed significantly. And the researchers think maybe this is because we have antibiotic resistant bacteria, we have changes in the good-bad bacteria balance. But this is a big deal. This is, I think, one of the reasons globally we are seeing environmental factors, nutritional factors, baby feeding factors change our gut development and our gut health, and also lead individuals more susceptible to autoimmune issues. So some bacteria that's important. Bifidobacteria is the most common bacteria found in healthy babies. Okay. Lactobacillus reuteri. Okay. This has been shown to help reduce E. coli and reduce crying for babies having colic with digestive pain. And GG rhamnose, or Lactobacillus rhamnose GG. There has some good evidence reducing ectopic dermatitis, like eczema, and also gut health. So I'm not sure in Indonesia if you are able to find probiotic therapy at pharmacies or other places. Maybe we can discuss that in Q&A. But for babies, often we can administer a liquid drop or a little powder in a bottle or on a finger. and this can help improve some gut health issues for some babies and also for adults. Okay. All right, so we talked a little bit about bowel movements. Now I want to talk a little bit about food allergy. So around the world, there's an increase in food allergies, okay? And in fact, up to 10% of babies may indeed deal with food allergies. Excuse me. For children who have a parent with a food allergy, 70% of those children may develop an allergy themselves. So when we think much of this has to do with environmental factors that are really increasing our body's acceptance of whether, food is something our body recognizes as food, or if it is seeing it as a foreign invader. Okay. So just to give you a little map, this is very basic. There's certainly more to food allergies. But the top list, IgE-mediated allergies, are the kind of allergies that send people to the hospital, right? So it's immediate. It's usually histamine controlled. We'll often see, hives, vomiting, hypersensitivity. In babies, we usually see more of the second one, IgG-mediated sensitivities. It's often more delayed. They're usually dealing with more irritability, crying, fussiness, skin issues like rashes or other dermatological issues. And it's less immediate than the IgE reaction. And then certainly some individuals have more of an autoimmune, like celiac disease, for example, which is not exactly an allergy, but more of an autoimmune condition. So I want to really focus on this middle group, these IgE-mediated reactions. We're seeing more and more around the globe, and human milk can certainly be one of the ways we can battle this pandemic of allergic disease. Okay. So how does a baby become sensitive when they're just drinking milk, right? They're not eating food yet. They're just getting human milk, let's say. So what happens is that a baby can be exposed to different things when they're still in utero, when the parent is pregnant, that can make them more sensitive to developing allergies. So the parent's diet, parents' exposure to tobacco smoke, alcohol, medications can impact this developing baby's GI system. Vitamin D, we talked about. Early introduction of solid foods. So, when a baby is maybe 5, 6 months, they're getting ready for solids. Babies are not ready when they are 1, 2, 3 months to be having things other than human milk or formula if needed, as that can really cause their system to have increased sensitivity. So when a parent has a sensitive baby and their baby is breastfeeding or getting breast milk, we have to think, how does that happen through breast milk? How our milk is made is our milk is made from our bloodstream. So a parent, if a parent is eating some food, it can go into their gut. Those food proteins, particles then pass through, you can see this little graphic here, pass through the gut junctions into the bloodstream. And then the breast milk is made from maternal blood. And so if there's some poor digestion or other issues on the parent side especially, where they're not breaking down foods as completely, or if an infant is sensitive to something, this is how different proteins especially can get into human milk and babies can be reactive. So some of the top allergies, cow milk, eggs, fish, peanuts, tree nuts as well, like almond, cashew, wheat, soy. These are some of the main things that are global allergies. Right. Some things to look for. We want to look for baby's skin, right? Usually baby's skin is soft and clear. Babies that get a lot of redness, especially around their eyes or around their their anus, or they have a lot of dry, rough skin, that can be a sign that they are getting sensitized to a food, protein, or other triggers. If they are having bowel movement issues, reflux, crying a lot, this could indicate they are dealing with some digestive concerns. Sleep, babies do wake up a lot, but if they're waking with pain, with gas, this could also indicate they're struggling with some digestive concerns. Okay? Certainly if they're not growing well or absorbing nutrients well. And then on the very severe end, chronic wheezing, congestion would be a medical emergency. We typically do not see that happen in babies, as it tends to develop over time where there's increased sensitization. But these are some things we want to look for if you work with newborns. So I'll show you a few pictures. This first picture, you can see, under the baby's eyes, a lot of dark swelling. And this can be a sign that there's some blood pooling and congestion, sometimes due to food allergies. This bottom picture, where we see the lines, we call these lines Denny-Morgan lines, and they also can indicate some atopic dermatitis and in conjunction to some food sensitivities and allergies. All right. You can see the baby's picture on the bottom. Her face is clear, and then this picture here where her face is red. This is a few minutes after she was eating, and she was rubbing her face. It was very itchy, and she was really struggling with something her mother was eating. I think for this baby, we determined it was eggs causing her to have some reactivity. Okay, other pictures of skin. You can see this baby's face, big rash, okay, some red spots. These can be some indicators that the baby is sensitive to something in the parental diet or their diet. Okay. I'm curious to know, maybe some of your colleagues can put it in the chat, how much food allergy or digestive issues you're seeing in babies in East Borneo or in your communities in Indonesia. I would say it's quite an epidemic in many areas of the world, and I'm curious what is happening in your communities. Okay. For the sake of time, I'm not going to talk deeply about allergy testing. You can always connect with me later if you have questions. This is a picture of a baby's back, so the baby's backside, where we do an allergy test called skin prick testing. And it can be one way to determine if a baby is having a true allergy or just a sensitivity. But it can be hard to find doctors that will test babies much under 1 year or 2 years of age. Okay. So a couple of things that can be useful, because we talked about the motility, doing massage, tummy time, singing. What can we do when a baby is potentially developing an allergy? We can counsel the family. We can ask about family history of allergies or digestive concerns. We can consider probiotic therapy. Even the World Health Organization says this can be a beneficial strategy for a pregnant person or beyond. Right? In terms of guessing what food a baby is reacting to, sometimes I will have a parent make a little journal or log of what they're eating, and then how is their baby's day going? What are they noticing with bowel movement, skin, sleep? Usually it's not, spicy food or garlic or something. Usually it's a boring protein like cow's milk, soy, nuts, even things like sesame. So if we are suspecting a baby may have an issue, we want to be careful that we are counseling the mother or the parent so that they're getting enough to eat. We don't want them to be hungry. We want to be supportive and making sure they're getting enough nutrition. There's also some evidence around a parent using an enzyme, a digestive enzyme, with their major meals. Okay. We may consider allergy testing if the reactions are severe, and I want to save time to show you 2 case studies. Okay. Optimizing vitamin D. Probably not a problem in Indonesia where you maybe have way more sunshine. Where I live, it's very dark, cold, rainy, and a lack of vitamin D can be a big issue for immune system and many aspects of health. Okay. Right. Okay, I want to be mindful of the time. We know that many babies, so we talked about allergies, we talked about bowel movements. Lastly, before we look at 2 cases quickly, spit up. Many babies are spitting up, but they're very happy, right? They're not crying, they're not rejecting food. But up to 10 to 20% of babies could have some reflux that is causing true pain and issues. Reflux can happen for many reasons. They can have poor esophageal tone, so the food is just coming up easily. Up to 50+% could be mediated by a food allergy or sensitivity. Okay? They might have delayed emptying, meaning they are not having regular bowel movements, and so there's increased pressure. So we want to be mindful. There's many reasons reflux happens. We want to help educate parents, okay, on how to position and feed their babies appropriately. We want to explore oral function, making sure the baby is swallowing and sucking okay. I really only save medication for times where there is actual physical damage or feeding aversions happening. There are risks and benefits to medications, and we can talk about those in question and answer if you have questions. Okay. I want to get here. Here's where I'd like to have 2 minutes, and then we'll end our talk. Okay. So I want to give you 2 real cases on real babies, my patients, that had some digestive health issues. Okay, the first baby, he had genetic issues at birth. So his doctor thought maybe his feeding problems are because his mouth and his suck are not working well. So the family came to me to observe the feeding, assess the baby's anatomy, and the baby is mostly drinking from a bottle, but he does like to breastfeed. Because of his genetic issues, the family doesn't really know how much milk he drinks from mom, so they do some at breastfeeding and some bottle feeding pumped milk or formula. The family's saying the baby is crying. He's crying and crying with feedings, and he's very distressed. So we decide to assess the baby. The baby's anatomy and sucking function are fine. He was able to breastfeed fine. But because he needed some formula, because he did not have enough human milk from his mother, she gave him a bottle of formula. So right, she's formula feeding, she's giving him some formula. And then a little bit of the formula got on his face. Just a little bit got on his cheek. And here's now why we know this baby was crying. Can you see this baby's cheek? It's red. It's irritated. This was immediately after the formula touched his face, and he scratched, and it was painful. And so we were able to recognize, oh, he does not have an anatomical problem with feeding. In fact, he is fussing and he's crying because also his insides, right, his GI tract are probably inflamed and swollen because he seems to have a sensitivity or allergy to the ingredients in that particular formula. So we're able to help this mother build her milk supply more, make more milk, and change the formula type so this baby could be more comfortable. Okay, and one last case study. A baby came to see me. He is 6 months old. He is getting only human milk from his mother, about 28 to 30 ounces a day, so like 700 to 1,000 milliliters a day. So good amount of milk. However, he is diagnosed failure to thrive. He's not growing. He is having normal pees and bowel movements. He is on Prevacid for reflux, so he's on a reflux medication. Sorry. He has seen ear, nose, throat doctor, gastroenterologist, allergist. He's seen many doctors. And the baby still will not grow. So the parent is not eating eggs because her first child had an egg sensitivity. And so she wants my help and to help her baby grow and develop. Okay. This baby has a lot of rashes on his skin. We'll look at a picture in 1 minute. His skin is very rashy. And it seems that he's sensitive to something in his mother's diet. So the mother, I believe she was from India. She made a list of the food she's eating. And she noted every day she had some dosas or like wheat bread, that the baby's skin got worse. So we decided to eliminate gluten, and then the baby started on some probiotics and some other support. Within 2 weeks, this baby grew significantly and his skin cleared. So that's how much a difference making a dietary change and supporting gut health. I'll show you a picture of this baby. So before, you can see his skin is very bad, very irritated. He's thin, he's not growing well. This is 2 weeks after we assessed the parent's diet, supported some gut health with probiotics. He's drinking human milk too. And he was able to grow and thrive by having better nutrient absorption. Okay. So I want to end this keynote on an important factor. Human milk is medicine. It is food. It helps develop our digestive system, which is the basis for preventing many autoimmune and allergic diseases. I look forward to hearing the colleagues talk about diabetes and other autoimmune conditions and the role of lactation. The health of the parent and the infant are always combined and very important. And all of us can do our best to protect and promote healthy breastfeeding because it is a global health imperative for lifelong wellness. And I thank you. If anyone has follow-up questions, you can send it to your group organizer or reach out. I appreciate you having me here. It's been quite an honor. I will stop now for any Q&A. Thank you.
Thank you, Melissa. Thank you, Melissa. Thank you for a very detailed and clear explanation about the topic, and I'm sure that all the audiences have the same opinion as I do. And as we see that we have some questions collected by our committee, and we will share it for you. But first of all, we welcome those who raised hand to ask you directly. We have Christina. We have Christina here. Christina, will you open the camera and also your microphone and ask to Melissa, please?
Okay, thank you for the opportunity. Good morning, ma'am. I want to ask you about my own experience before, about my baby's case.
Okay.
My baby was hospitalized for 20 days when she was 8 months because of renal infection, and she got full antibiotic.
Okay.
Now on, she was 23 months. 23 months. She can eat more than a quarter of fruits. When she got more than it, she will get a obstipation or can be diarrhea sometimes.
Yes.
And I feel like my baby is hard to get weight gained. I don't know why. Yeah. I am scared if she can be stunting. You know that it. Yeah. And my questions are: did the antibiotic affect my baby's digestive?
Okay.
If they did, how to repair my baby's digestive? Because I heard so many suggestions to give my baby multivitamin which contains temulawak. Did you know about temulawak before?
Okay.
Temulawak is herbs in Indonesia.
Yes.
It can be heal the digestive of people, but I don't know what the effect of the baby before.
Sure.
So, yes. Then I give my baby multivitamin, but I thought that why my baby still get a low of gain and there is no increase significant, because I give more multivitamin, but it didn't work. I don't know
Yeah.
why. Can
So
you?
great question.
Mhm.
Yes, early antibiotic therapy, of course, if a baby is sick, we need to give them medicine or antibiotics, of course. But yes, it absolutely can change the bacteria balance of the stomach. So also, I work deeply with herbs and plant medicine. I don't know the name of that herb, so you will have to email me or message me so I can look it up more. But two things. You may find some relief in getting some probiotic therapy, so some of the good bacteria back, if that's something you can find in your country. Then the healing of the gut lining and helping absorption. So sometimes there are some herbs or supplements or amino acid like L-glutamine that helps the intestinal lining. And there could be some other food or irritant still bothering your child where they're not absorbing fully. And so then I look at things like, can we increase some essential fatty acids or fish oil or some other things for absorption? Some kid, like the last baby you saw in the case, he was very reactive to gluten and he was not absorbing. So I don't want to say, oh, your child has a gluten problem or something, but it's good to maybe think about replacing the probiotics from the antibiotic therapy. Thinking about something healing. I don't know that herb, but there are many herbs and plants that can be soothing for the stomach and the digestive lining. And then if there's still not good absorption, thinking is there still something that's irritating that we maybe need to address. And I know it's hard. We all want our babies to have the best health possible. I thank you for sharing your personal story. Yeah, thank you.
Okay.
Yes.
Ma'am, is that permanent or it can be changed?
Say it one more time.
Is that will be permanent in my diseases babies?
Our bodies are amazing, right? We can heal from so many things. We're healing and growing, and that's what we do is we keep hope for continued healing. And so, we will find that the body is always repairing itself. So stay hopeful and feel free to reach out if you need some more ideas.
Okay, thank you,
Yeah,
ma'am, for your
of course.
suggestion.
Thanks for being here.
Okay. Thank you, Christina, for the question, and also Melissa for the answer.
Yeah.
Kamati, please. Do you have any questions from our audience? Ya, apakah panitia memiliki pertanyaan? List pertanyaan dari audiens. Silakan ditampilkan. Okay. Melissa, we have some questions here written by our committee, and will you please answer the questions? Thank you.
Yes. So for babies that are allergic to breast milk, does that mean their GI does not develop? This I want to really clarify. Babies are never allergic to breast milk. They are allergic to something in the milk. So only few babies that maybe have some genetic issues like galactosemia or some more rare newborn disorder cannot drink human milk. So I want to be very clear. It's not an allergy to the milk. It's usually something the mother is eating that gets to the milk, like cow's milk, chicken eggs, wheat, nuts, things like that. So I want to be very clear that the breast milk is not the allergy. But babies who develop an allergy, yes, their gut did not develop the very same way. That can be due to parental health, something in the environment, parental medication, how the baby was born. Like I said, the bacteria can change with mode of birth, the first foods the baby received early on. So babies are not allergic to breast milk, but they can develop an allergy because of the way their gut developed, which is why we want to encourage breast milk as much as possible to avoid those allergies in some. So even breastfed babies can develop an allergy, but it is more likely in a formula-fed baby. Okay. Two, what are the short-term, long-term complications that may occur due to untreated digestive disorder? Great. So we have many teenagers, adults, grandparents that are developing, GI disorders, autoimmune issues that can have a gastrointestinal origin, mood concerns that can also have a gut-brain axis connection. So starting with good digestive health can be a foundation for many aspects of health, our immune system. So for later in life, for adults, we see many people who are struggling with bloating, gas, poor weight gain, absorption, reflux. So when we see this in babies, ideally we want to take note so we can help them develop, just like Christina was asking, develop the best they can so they can hopefully avoid some of the long-term digestive issues some adults deal with.
Okay,
Thank
thank you
you.
for the answer, Melissa, and I hope that those who ask, kepada mereka yang bertanya, semoga jawaban dari Melissa cukup menjelaskan. And Melissa, we have still one or another question.
Wonderful.
Yeah, please. From Aziza. Please, Aziza.
She needs her microphone on.
Aziza, will you please open the microphone?
There.
Okay. Good morning and greetings to Miss Melissa Cole. First of all, let me introduce myself. I am Kia Fani, one of the students of the Health Polytechnic of Ministry of Health East Kalimantan. And my question to Miss Melissa is, it was previously stated that digestive health is also influenced by inheritance factors. How do genetics and the environment interact in shaping digestive health? That's my question. Thank you.
Wonderful. Yes. This is one of the most fascinating things thinking about genetic health and epigenetic health, because our gut health is not just our parents, it's our grandparents, grandparents that led through nutritional abundance or deficiencies in terms of what foods we had available through history. What chemicals or environments are we exposed to that is having some epigenetic change in our developing gut health and health of our whole body? So it's not as simple as the baby is born, feed the baby breast milk, everything will be perfect. We have this health that spans through many generations. And so that's why we're hoping now, can we make a difference in our future generations by being mindful of healthy nutrition, avoiding pesticides and toxins when we are able to, supporting healthy nutrition, reducing, antibiotic resistant bacteria strains. So it's very true that our current health is much based on our past generations. Hopefully we can change that for future generations for a positive. But I'm very fascinated by things in our environment and through our family genetics and our environmental genetics that can change certain aspects of health, turning certain genes on or off. I hope that makes sense. It's a very good question.
Okay, thank you for the answer, Melissa. And
Thank you, Aziza.
we have come to an end of your presentation. We would like to say thank you, and also we would like to we would like to hand over the event certificate as a speaker to you.
Thank you.
Yeah.
I'm very honored.
Ya, thank you. Panitia, tolong disiapkan. Apakah sudah ada sertifikatnya? Apakah sudah ada? Yeah, and this is the certificate, the event for you, Melissa Cole. And thank you for your participation, and we would like to say that it's been our honor to have you here, and cannot wait for the next event to invite you as our speaker. Okay, thank you.
Thank you, everybody. Thank you so much.
Okay.
Have a wonderful conference.
Yes, thank you. Baik, Bapak dan Ibu, para audiens, thank you for all my colleagues, my respectful colleagues, and also audience, pada seluruh audiens pada acara pagi ini yang masih ada. Untuk selanjutnya kita kembali akan menghadirkan second speaker, Profesor Muhammad Afzal Mahmud from Australia. Is Professor Mahmud already here? Good morning, Profesor Mahmud.
Good morning, selamat pagi.
Selamat pagi, Pak Mahmud. Apa kabar?
Baik sekali, dan Anda?
Yes. Terima kasih, kami juga baik-baik saja di sini. Alhamdulillah, ladies and gentlemen, our respectful audiences, telah bergabung bersama kita Profesor Muhammad Afzal Mahmud. Beliau merupakan pakar yang sudah sangat terkenal ya di Kalimantan Timur, karena beliau menjadi konsultan bagi Dinas Kesehatan Provinsi Kalimantan Timur yang memberikan banyak sekali masukan, banyak sekali memberikan insight kepada kita di dalam meningkatkan quality of our health care di Kalimantan Timur, Indonesia. And now Professor Afzal Mahmud join us this morning to have a presentation yang akan meningkatkan pengetahuan kita kembali tentang kesehatan maternal and child, dan kami memiliki waktu 60 menit, Profesor, untuk Anda, for you to bring your presentation.
Thank you very much, and
silakan.
Thank you to the Polytechnic, Ministry of Health, and all of you, the team organizing this, for giving me this opportunity and honor to talk to all the wonderful people in Indonesia. I believe they are not only from Kaltim, but I believe probably from around Indonesia as well.
Yes.
Yeah, okay, excellent. So do you hear me loud and clear?
Yes, we can hear you loud and clear.
Okay, excellent. And I heard Dr. Malisa's talk, very interesting topic, and great that you are promoting lactation and breastfeeding.
Thank you.
My conversation chat will be around another important issue, which is, I believe, not on our radar at the moment. And we are not paying as much attention as we need to pay to that. And that is about the non-communicable diseases as concomitant illnesses during pregnancy. So may I share my slides?
Yes, you may. Please.
Yeah, thank you. So do you see my slide now?
Yes, we can see that.
So let me put on my power to my laptop, just in case it will work.
Okay.
Now, the topic is integrated healthcare for pregnant women with concomitant, those who during the pregnancy have non-communicable diseases, one or more, and as introduced by the Master of Ceremony, the coordinator. You can call me Afzal. My full name is Muhammad Afzal Mahmood. I'm at the School of Public Health, University of Adelaide, mainly, but I have an appointment with the Alenga in Surabaya, and I am advising Dinas Kesehatan Kaltim for the last many years. I will try to be brief. This slide is about our indigenous people, our Aboriginal people, like you have over there, our Daik people. So we always pay respect to our Aboriginal people because of this land belongs to them, and we are privileged to be on their land. Like I'm in Australia, so my respect for the Australian Aboriginal people. We acknowledge the deep feeling of attachment and relationship of the Ghana people. That's one tribe of Aboriginal, and we value their past, present, and ongoing connection to land and cultural beliefs. So, and I pay respect to your culture as well in Kaltim and wherever you are in Indonesia. I'll be talking a little bit about, very briefly, the extent of maternal health and maternal mortality, and then a little bit about what is happening in terms of the extent and significance of non-communicable diseases, and then a little bit about non-communicable diseases affecting the pregnant women. And then I move on to my main interest, and that is the health system, because I'm a health system specialist. I see that many things we can improve, and that improvement in system can lead to improvement in the outcome. Now, whether that is the lactation feeding for the baby, or whether that is pregnancy outcome, labor and delivery, health system plays a lot of role. And you being the health system, healthcare provider and stakeholders in various capacities like Bidan or Pravat or doctor, you can play your role. So that's number 3, 4 are my main talk today. And within that, what changes we can do. So that's basically, I'll be talking in the next 20, 30 minutes, so I won't be long. So what is a chronic disease? Broadly defined, diseases that are lasting 1 year or more and that require long-term health care intervention. And some examples are, and they could be both infectious and non-infectious chronic diseases, cardiovascular, cancers, mental health issues, diabetes, chronic obstructive pulmonary disease or asthma, and many others. So I haven't mentioned here infectious diseases, but there are many like TB and hepatitis and HIV, etc. Now, there are certain genetic factors and there are certain metabolic factors which then contributes to the presence and severity of these illnesses. I will not go into detail because that is not the topic of today, but just alerting you that there are certain genetic and metabolic factors such as high blood fats, obesity, hypertension. They will create certain metabolic derangements, and that will then affect the cardiovascular or other system in the body, causing those diseases. And there are lifestyle factors as well. For example, unhealthy diets, lack of exercise, smoking, alcohol, and other drugs abuse. So these lifestyle factors, they act on the risk factors such as obesity and lipids, diabetes, blood pressure, and then they lead to diseases. What is happening around the world from 1990 to almost now is that there is an epidemiological transition. What were the diseases causing disability, disease, and death to many? That scene is changing. So you could see that from the 1990s, ischemic heart disease, stroke, and they were at number 4 and 5 in terms of their impact on the overall mortality, morbidity, and disability adjusted life year. Disability adjusted life year, we mean we calculate by looking at how many deaths and how much disability a particular disease causes, because some diseases may be not causing that many deaths, but they cause a lot of disability, for example, mental health. So therefore, you combine these factors and come up with the idea of disability adjusted life here. So if we see ischemic heart disease has gone to number 2, and the stroke from 5 to number 3, and similarly chronic obstructive pulmonary disease, they have gone up from 11 position to the 6th position, and this is a global situation. So if you could look at the some diseases are going down, but like for example cirrhosis has gone down, but these are the main. Have a look at the diabetes, for example, number 20 in 1990s, and where it has gone now. See, number 8. And many of you already in public health and health system, and you know that the lifestyle, particularly our food practices and availability of food, that is causing a sedentary lifestyle, and how much gula we are taking in our tea on a daily basis. All these factors are contributing to this change. And this is important to know because this transition then affects different population groups, including the group of pregnant women. Okay. So coming from global situation to Indonesia's maternal mortality and non-communicable disease, in Indonesia, despite all the good work and extensive healthcare system and access to care by most of the pregnant women now, they attend antenatal care 4, 5, 6, 8 times. Despite that, still we have very high maternal mortality ratio. For every 100,000 conception or live births, there are 177, and compared to 6 or 8 in Australia. So it's a huge difference just across between the two neighbors of Indonesia and Australia. We have this very significant difference, huge difference. And quite a bit of this is due to health system, and particularly the quality of care. And that is important because I'm going to talk later on that what role health system can play in managing and providing care to women who suffer from non-communicable diseases now. Because you could look at the second line on this slide, that about 22%, 1 in 5 maternal deaths are now not due to obstetric causes, but they are due to infections and non-communicable diseases, which are not part of the pregnancy and labor and delivery in the recent past, 10 years or 15 or 20 years ago. Most of the issues were APH, antepartum hemorrhage, postpartum hemorrhage, obstructed labor, then molar pregnancies and all those things. But now we have seen a huge increase in the non-communicable disease related maternal deaths. And I've shown you, as the general population is getting affected by these diabetes going up and stroke and ischemic heart disease, women are part of that larger population, hence they also get affected by these, and when they become pregnant, these diseases then affect them very badly. And they particularly are more bothersome because they increase complication and risk of complication during pregnancy more than the general population. So one of my colleague, Larissa Ryan, she did a PhD about concomitant illnesses in Indonesia, just recently completed under my supervision. So and this study found out that there are now many pregnant women who have issues like mental health, stroke, pulmonary issues, chronic kidney failure or disease, and diabetes during their pregnancy. You will see about 3,600 or even more. These are a lower estimate. And then from 2000, in the 20 years from 2000 to 2019, non-communicable diseases, they have increased at the global level in the whole world by 49% increase. So that's quite a lot of increase, 1.5 times now in the 20. Similarly, during those 30 years in Indonesia, you could see that the diabetes mellitus in pregnancy has grown by almost 60%. Now, these are huge increases, and we need to keep an eye on this. Whether we are Bidan or whether we are Obgyn, we need to get ready to provide support to these women. So compared to 30 years ago or 20 years ago, we see a huge different scenario. So if we train our doctors, if we train our professionals the same way we used to train them 20 years ago, that is not going to work because epidemiological transition has happened. And you could see that the diabetes within this chronic, non-communicable chronic diseases, diabetes mellitus is a major share. 15.5% pregnancies, they suffered, women suffer from diabetes mellitus, many from GDM, and then some from ongoing pre-existing diabetes. So why this is of concern, particularly during pregnancy? Because there are certain physiological changes, not disease, but physiological changes happen during pregnancy that because of which non-communicable diseases such as diabetes, hypertension, they can become more aggravated and can lead to enhanced risk for these women. For example, pregnancy creates a state of insulin resistance. So patients with pre-existing insulin, they may develop GDM, gestational diabetes mellitus. Similarly, hyperdynamic circulation, which happens during the pregnancy, that can lead to physiological hyperlipidemia, fat increase in the body. Low-grade inflammation, which is part of the normal pregnancy, that low-grade inflammation can cause stress on the cardiovascular system, and that can cause endothelial, within the arteries, the endothelial dysfunction, and that may lead to preeclampsia as a systematic or systemic manifestation. So you could see that certain physiological changes like inflammation, hyperdynamic circulation, they can interact with the risk and enhance the impact of chronic diseases on physical and mental health of the women and their babies. Now, that was a little bit focus on non-communicable diseases during pregnancy. So with 57% increase, we need to be aware that this is a mountain of a problem which we need to now address. But let me now shift for a minute on health system and its existing issues. Because if we understand what our system look like, then we can see, okay, if our system is already weak and not strong enough, then how it can manage this newly emerged problem of non-communicable diseases. So our study, we have done a lot of research in East Kalimantan, in Kutai Kartanagara, in Balikpapan, Samarinda. We have done some research in Pasuruan and in Kanujos, in hospitals like Kanojoso and Wahab Sarani and Sutomo Hospital in Surabaya. And though all that research has informed us that this is just a summary. This is not the full picture I'm giving you. This is just a summary that there are certain issues, and those issues I have highlighted in this triangle. That there is an inadequate management of cultural, social, and economic factors. That social determinants addressing the poverty, addressing the food security for the Bumil, have money in the pocket so that they can use the needed services at the time they need it. That is still there for many women. And that is why most of the maternal mortality is still among those women who deliver in class Tiga. It's not that the class Tiga is all poor quality, but I'm alerting that social determinants are still an issue. And those social determinants impact on the food intake as well. And that food intake, inadequate food or fast food, unhealthy food is cheap. So people who suffer from economic disadvantage, they unfortunately have to consume those cheaper, poor diet, and that is one of the factors. And then they may not have opportunities for exercise, and that's another factor. And some other issues such as domestic troubles or violence, sexual gender-based issues. So they impact our socioeconomically disadvantaged communities more. So that this area is still significantly important. But today after saying this, I will focus on some issues within the health system. So within the health system, we found out that there is inadequate communication, and that's a major issue. Communication between provider, Bidan Bumil, Obgyn Bumil, and between Bidan and Obgyn, and between Obgyn and Kalwarga, those communications are suboptimal for various reasons. Skill for communication, how to communicate, the time available for such communication. There are many factors, but issue is that there is inadequate. And because of that, the risks are not well communicated then from provider to patient, meaning Bumil, and between providers. For example, when we are referring someone from our Puskesmas to the Rumah Sakit, then if we are not communicating a risk very well, for example, one of our research in Surabaya informed that many women were arriving at the tertiary hospitals like Wahab Sarani or Kanu Josso or Sitomo Hospital or Anwar, Saiful Anwar Hospital with inadequate information about their condition. For example, if a woman is suffering from hemorrhage and has to travel 2 hours from a Puskesmas to the hospital, if the Puskesmas is able to communicate that this woman has hemorrhage and has lost 1 liter, and on the way during the next 2 hours she will lose another 2 liter, the hospital may be ready. But this information was not reaching and is not reaching. This is an example. Non-facilitated referral is another major issue. Yes, many women are referred, but by a non-facilitated mean, not helping the women knowing when you go to Parikasut hospital, who will be greeting you. When you reach there, what will happen then? How you will reach there? Do you have the car, mobile or not? Do you have the money to go to hospital? Why I am sending you to the hospital? All those issues are not very well managed. Hence, it's just on the chatatam that, look, dear, you go to hospital. That kind of advice does not work. Sometimes women don't go. Sometimes they go with an idea that they are coming back and they will not be needing hospitalization. So that kind of information gaps hurt the system, make it weaker. When they are transferred back from the hospital to the community, then the information also doesn't follow them. the hospital quite often fail to provide the information to the bidan or to the puskesmas that look, we have discharged this patient, we now giving it back to you, help her, you need to do XYZ. That is not happening. Pyramidal referral is one where one needs to go to level A hospital, but end up going to level B or C hospital, and they do not have the needed operation facility or the blood bank, etc. And then they have to go another 3 hours somewhere else, and that poor timeliness causes the disease such as hypertension or eclampsia or hemorrhage due to these increase. And if she's having some sort of a eclamptic shock, then that 2 hour make a lot of difference. So I will summarize this, that absolutely highly important social issue, and we need to look after that, and that are causing people to suffer from obesity, from poorly managed chronic diseases because of lack of money, lack of resources, but then within the health system, poor communication, poor referral, no proper information following the patient. These two slides again say what I've already said, that there is why these communication gaps are there then. And one major factor we noted is the poor coordination between levels of care, between Dinas Kesehatan and management of the hospital, between Kepala Puskesmas and Director Hospital, so there are no systematic links, what we call administrative link, which we can promote the link between the professional. They go hand in hand. We need to have what we call administrative or organizational link, and then those organizational link promote the link between healthcare provider. If Kepala Dinas Kesehatan and the team at Dinkas is not having strong organizational link with the Rumah Sakit, then this will affect the link between bidan and object. So an example, a woman's perspective. So there are gaps because of those things, and the information is poor, referrals are poor, and this is a true example. A woman's perspective, having high blood pressure, lab investigation ordered. But that woman went home and nobody followed up. Onus or the responsibility is on the center or the specialist or the hospital, which is asking for those investigations, that if the results have come and the woman has not come, this is not the fault of the women. We need to somehow have the information relayed back to the women and relayed back to the primary care provider like Bidan in the Puskesmas or Bidan Swasta. Right? Unfortunately, that did not happen because of the gaps I mentioned, and she died due to preeclampsia at home. And I'm showing these bridges with a gap between, because we need to have these bridges between at the professional level and at the organizational level. Between hospital and primary care, this example, a pregnant woman was sent home with a suspected placenta previa. No information for follow-up was provided by hospital to primary care provider. So she suffered hemorrhage during delivery and died over there. And these kind of gaps, they are now impacting the management of diabetes, management of cancers during pregnancy, and management of hypertension during pregnancy and other cardiovascular and heart health issues. Because those diseases require continuity of care, and continuity of care can only happen if these gaps are not there. And one can start the journey from primary care and go all the way to hospital, and then can come back all the way and to the primary care with all specialists, hospitals, cadre, Bidan, Rawat, they all linked very well with each other, providing a care throughout those 10 or more months from preconception to postpartum period. Because these diseases, they are chronic. They are not going to go away with one visit. And I've already mentioned uh, about the inadequate risk communication to pregnant women. So not only they're not talking to each other, the lack of time or lack of appreciation of the importance of communication. For example, if I sit with a woman and inform her how blood pressure or high blood pressure impact the cardiovascular system, it will take 5 minutes during the antenatal care. Or maybe it will take more, that how blood pressure, what is blood pressure, and how it will impact your heart, and how it can lead to preeclampsia, and how preeclampsia can lead to fits and death. If we spend 5 minutes with the woman at the first opportunity when we have found out the increasing pressure, or same for diabetes, they are intelligent people. Everyone is intelligent, uh, and they are wise people. The only issue is that we are not communicating the risk very well to them. Once the risk is communicated and there's a trust uh, between the provider and recipient of care, they will look after themselves very well. They will be your partner in disease management. But that's not happening. And I won't go into detail why that is not happening. Despite, in my view, for example, the first antenatal care for a woman who is having a non-communicable chronic disease should take 40 minutes to 1 hour. But do we give that 1 hour? Probably not. So what are the gaps and inadequate readiness to manage chronic disease? For women with non-communicable diseases who engage, now this is research done by Larissa, one of my PhD students in Kaltim, that if they were engaged with the hospital early during the pregnancy, meaning the risk was identified, the primary care provider referred them, they got in touch with specialist or obgyn, they had a better chance of improved outcome for themselves and for their babies. On the contrary, those women who deliver at hospital because they had a non-communicable disease, chronic disease, but they had not received antenatal care at the hospital or by the specialist, they had lower number of tests done, they and they ended up having C-section quite often. Hello. Yeah, thank you for turning off your mic.
Okay.
There are gaps in terms of inconsistent services and tests such as blood, protein, urea, urine glucose, etc. So we are not conducting those tests which can identify the severity of non-communicable disease. I would say the links. This is the root cause. Inadequate information is another root cause. Delay is another, and inadequate follow-up. And these are even more important for non-communicable disease. So what we need to do? What are the potential solutions? Simple. We do not need Einsteinian science. If we know the problem well, the solutions are very easy. For example, if we know there are fragmented health system, what is the solution? Make that fragmentation, change that fragmentation into integration. If we know that the non-communicable diseases are on the rise, we need to check our obgyn, Bidan, Pravat, whether they are having skills or not, whether they have knowledge about these diseases or not. If not, train them. Okay? Continued medical education, including non-communicable disease. Address their suboptimal skill. Check that and improve that during the CMEs. Because remember, 22% women are now suffering from and dying from non-obstetric reasons during the pregnancy. So we need to focus on that. Integrate where we have primary care, antenatal care, and hospital-based services working together. More information is needed from hospital at the time of discharge, going back to the Puskesmas. Otherwise, people will either not comply, or they will be providing 2 or 3 diverging different opinions to the women, and women will be confused, and Kalwarga will be. Improving early identification, yes, absolutely, and this can only happen if we have the training and if we focus on the skills. And then a referral and transfer system, as I said. So this is nothing new, this slide, but a reflection of what I have already said. If we know the problem, we know the solution. And why it is easier in a way? Because there are opportunities. Many women in Indonesia are already attending the Puskesmas or specialist or hospitals up to 8 times for their antenatal visit. And Indonesian health system is good in that sense that it has many Puskesmas, it has many Ponek hospital, and even they go to the villages with what we call Puskesmas clinic or something like that. But unfortunately, healthcare managers and providers have not yet appreciated this opportunity and have not actualized this opportunity for the changing scenario. Scenario is changing with these new diseases, this emerging chronic diseases. So we need to focus on strengthening our district health systems, and strengthening happens through integration. We need to improve the Dinas Kesehatan's capacity. For example, Bidan coordinator, they need to be trained in non-communicable disease and their risk factors. They then need to train the Bidan coordinator at the Puskesmas. They then need to provide the education to the cadre. And that is how we can improve the education at the community Masharakat level and awareness. And that is where the prevention initiatives will be taken, either by the cadre or by the community themselves, or through the collaborative effort of primary care provider and the communities. So I've used the word integration many times, and I think you know from my examples of the gaps and where the integration is needed. But let's see the integration from 3 facets, 3 sides. One is the integrated care and comprehensive care between the healthcare providers. We need to work as a team, and we need to be comprehensive, that our care, antenatal care now includes good assessment for pre-existing hypertension, pre-existing diabetes mellitus, any risk factors for cardiovascular disease, because if women having some risk due to the pregnancy, that risk can be accentuated and she can develop a full, more severe CVD. So that is one way of looking at integration. Integration at the clinical care level. The other integration is coordination between levels. Puskesmas, hospitals in like level C, level D, frontline hospital, and level A, level B, like district hospital. They need to work in tandem with each other for all these things I mentioned, through effective hotlines, through facilitated referral, through information following the patient, and then following the patient back to the family and primary care. That is second. The third one is the government and private sector. We have many Bidan Swasta and private clinics. Cadre are also private, Dukun are also private. So we need to somehow bring these working together. and improve their understanding that how together we can manage the non-communicable diseases which are killing. So if it's 177 women dying out of every 100,000, so 35 out of that are dying due to the concomitant illnesses, which is a huge number. So what actions? If these are different dimensions and if this is what the focus should be, then actions such as include and emphasize on non-communicable diseases in the existing curriculum at the academy level, at the polytechnic level, at the university level for all health cadre, healthcare, human resource. And then during the continued medical education, when they are employed, still we need to now consider these things. Link, make some organizational, make an effort for continuity of care. And for that, some paradigm shift is needed. We need to see eye to eye. We need to not have a relationship of, oh, this is Obgyn and this is midwife. We need to be some sort of a equality in terms of that we are team. We are incomplete without each other. And that kind of a link not only require organizational shift, it require political shift as well. How we see the Puskesmas compared to hospital. Hospital are considered as powerful places. Puskesmas seen as disempowered. Bidan are working lonely in a village. What kind of a political status she has compared to an Obgyn? We need to promote that togetherness and working as a team rather than working like that in a different way at different levels in a hierarchical way. That won't work. And we need to improve our community-based activity, involve cadre more into these discussions so that we can arrest, and this mountain which I have highlighted, it does not grow bigger and bigger. And within the hospital, again, within the hospital, we need to have teams because Obgyn alone or Bidan alone within the hospital now cannot deal with all the pregnancies and labor and delivery because women are coming with complex issues, and those complex issues require an anesthetist, internist, a maternal-fetal medicine specialist, public health practitioner, intensive care specialist who can provide a better care in the intensive care unit to these women after they have gone through operations, etc. So this is the formula, but I have tried to make a model of the formula, and I will highlight only two areas which are colored green here: coordination and teamwork. I think if we pick on those two words from this model, we can improve our health system a lot. So I will not go into the whole cycle that we need to review and assess our weaknesses in terms of NCD. We need to then develop a local relevance. For example, if in one area there is more diabetes and there's another area where there are more cardiovascular or other problem, every area has to work on their local relevance. Yes, we need feedback from the Ministry of Health. Yes, we need support from them, but our action needs to be locally based according to the local relevance. So this is a system here, but just for the focus, think coordination and think teamwork. And that can enhance the quality of care, that can improve integration, and that can improve the management in terms of effective use of our resources. So I'll stop here. I hope I haven't taken more than half an hour. And we can have some questions if you like. Thank you.
Okay, thank you, Professor Mahmoud, for the presentations. And I believe that our respectful colleagues and also our lovely audiences who is already here, join us in the virtual Zoom. They already have questions to be asked. And do we have any raised hand here? Oke, committee please tampilkan pertanyaan yang bisa dijawab oleh Profesor.
They can ask question in Bahasa and you can translate that if they like to.
Oke, silakan yang ingin bertanya dalam bahasa, akan saya bantu untuk menerjemahkannya. We do have a lot of questions here, Professor, because the topics are very interesting and very insightful. And yes, we have Gaitsa Zahira here. Please, Gaitsa, open your microphone and yes. Gaitsa, please.
Okay, hello, Miss Era. It's been a long time that I see you.
Nice to see you. Nice to hear you.
Okay, and here I have a question. Oh, wait a second. So here I have a question for you. So how do the physiological changes during the pregnancy modulate the pathophysiology of non-communicable disease and creating challenge in diagnosis, treatment, and prevention of complication? And also, how can the evidence-based approach be effectively implemented to optimize maternal and fetal outcomes across diverse socioeconomics and geographic contexts? Okay, that's all my question.
Okay, so that's quite complex question.
Yes.
I think the first part of the solution always is the analysis of the issue. What is my issue? And that is why I always say we first need to understand the problem. Is the problem lack of skills among the staff? Is it some organizational issue that we are not providing our healthcare enough time to be with the woman? For example, if there is a huge rush or many women are being seen by an obgyn during the day, he will not be able to give more than 5 minutes or 10 minutes. And that is not sufficient. So first we need to tease and analyze the problem. I believe our research informed that our system is weakest in terms of the link. Many of our staff actually have very good knowledge. Many of our hospitals now have 5 or 6 obgyn. Some obgyn now have information on maternal fetal medicine as well. I believe this local resource can be linked with the primary care, and those hospital-based senior people can provide guidance to the people in the field. I call it duck and duckling system. Right? So analyze the problem, find out what are the gaps in the knowledge of the primary care provider or knowledge or gap in the knowledge of the hospital people, then find out what resources you have. If there is an obgyn who is very good at it, give them the task to train their own people rather than looking towards Australia or looking towards Jakarta all the time. Quite often we have the solution inside. So do an analysis, provide these trainings, and then if there are issues with the time and organization, manage those issues as well. If there are certain policies, for example, if there's a policy that please generate the money for the hospital by seeing many patients, and if that is kind of policy is there, Belude policy, then your focus will not be on a comprehensive care, but care for many women. So in summary, what I'm saying that it's not difficult, but it requires a systematic approach. Analysis, local identification of opportunities, and using those opportunities for local training and local coordination. Have I answered your question to some extent?
Baik, jadi Profesor Mahmud ingin menyampaikan bahwa dari dalam setiap tempat di mana pasti terdapat gap ya atau kesenjangan yang harusnya dianalisis dulu ya, untuk dicari apa masalahnya, karena terkadang permasalahan yang ada bisa terkait dengan masalah yang berbeda ya, bisa terkait dengan sumber daya manusia atau human resources atau other resources, dan kemudian bisa juga terkait dengan policy atau kebijakan yang ada. Jadi sebetulnya to solve the problems itu membutuhkan pendekatan yang sistematik atau systematic approach.
And may I add one more thing to this? This is a very important question. And I think when we say that there are now another problem on the existing problem, another problem in now we have non-communicable disease as well. Sometimes we keep a focus on that we do not have resources or we do not have the more money. I think if we go into that negative mode, then we will suffer from malaise. Malaise means lethargy, and we will not have initiative. I think we should not fall trap into that trap. We do not have resources. We should look for the opportunity, what we have already. Okay? And then, okay, we have this, we can achieve 80% success or 70% success, but yes, we need a little bit more resource for that, and resource will come. In Parikasat Hospital, for example, or in our Pahud, in Pasuruan, they have been able to change and make the system better without investing more dollars into it or more rupiah.
Okay.
So that is my request to all these 900 good people, that please don't fall trap to this idea we don't have resources. Look for opportunities.
Ya, ya, you're right, Profesor. Jadi Bapak Ibu sekalian, Profesor ingin menekankan bahwa sebenarnya kita terkadang terjebak dalam pikiran bahwa kita tidak memiliki resources ya. Itu yang membuat kita kemudian merasa tidak mampu solve the problem. Padahal menurut Profesor kita harus melihat opportunity yang kita punya. Begitu ya, Profesor?
Thank you. Any other question?
Okay, we still have 2 more questions already listed by our committee, please. Okay, please, Desti, you can open your microphone. Please wait a moment, Prof.
No problem.
Yeah. Okay. Desti, are you still there? Apakah Desti membutuhkan lebih banyak waktu untuk mempersiapkan? Mungkin panitia bisa menampilkan saja dulu. Okay, these are questions for you, Professor.
We look forward to your input regarding the suboptimal skill that you have to contrast already to access integrator. Okay, so one by one, suboptimal skills that can be. So how to? I think maybe the question is that how we can address the issue of suboptimal skills, right? I will go back to my suggestion. Let's take the example of my friends in Balikpapan, say Dr. Aspian. Okay? I mean, you or Pa Trisano. You look for those people who have good skills and try to find out the opportunities whether Balikpapan midwives, Balikpapan Puskesmas can learn from those people. You need to facilitate that learning by the people who have skills for the people who lacking those skills. or similarly, this is what we call duck and duckling
Is this means
system.
just like mentoring? Mentoring?
It's like a mentoring. So we call it a duck and duckling. For example, Pa Bernardus or Pa Prem at Samboja Hospital, they are now like a friend, like a bapak or brother for many midwife in the areas around the hospital, so they can continue working with each other. They learn. He visits those puskismas. He visits those bidan. Bidan can have his WhatsApp number. If they are in difficulty, they can ask question. So this way, rather than having hotel-based trainings, which everyone come and then they forget in 3 days' time, you need to have an ongoing link between the resources who can be used for improving the skills of your staff. Similarly, we have promoted the ideas that primary care staff can have appointment at the hospital. Why not? Give the opportunity to be the coordinator at Puskesmas, bring them to the hospital for 15 days or 3 weeks, and they work with the hospital Bidan, hospital Obgyn. They will develop friendship, they will learn from the seniors, they will go back home, and now they will have more interaction with each other because they know each other, plus they have developed the knowledge. So again, I'm emphasizing that it's not a what you call Einsteinian science. We need to find out simple ways of improving our skills, and we have seen that happening, and anyone working on those ideas, they can do that. I discourage trainings in hotels, and I encourage training at puskismas. I encourage training in hospitals, where where people can see how the patient can be treated, how the patient can be supported. Right. So that's point number one. Point number two: how easy it is for pregnant women with non-community to access integrated. Now, there are two issues here. One, yes, there are certain geographic, financial, or social barriers. Now, whose responsibility it is to help the women deal with those geographic, financial, or social barriers? That is what I call facilitated referral. The person who's sending a woman from Kota Bangil to Tangarong need to understand where this woman will live, or the Swami will live when the woman is in the hospital. So, do they have the money for that? Do they have the mobile to go for that? So, we need to facilitate that. Dinkas or some other ways of addressing that barrier. So it's difficult, but it is achievable. It can be achieved if we work systematically by finding out from the women that, look, what can you afford and what help you need from us. That is the second part. Are there significant geographic financial? Yes, there are, but we can do something about that. Then how it is for the to access integrated care? It's difficult, but again, it depends on the team. If Dukun, Bidan Swasta, Bidan Puskismas, Obgyn specialist and hospital, if they are acting like a team, it's easy. And they can act as a team only if we have promoted their interaction. We need to bring them closer to each other. Unfortunately, we don't do that. Obgyn is or Ibu Obgyn is working in hospital, have no idea what the Bidan, who are the Bidan, 500 Bidan in Puskesmas. So we need to facilitate their interaction, relationship building. If we develop the team, it's easy. The problem is not with the women. Problem is with me. I'm not working as a team. I'm working as a solo practitioner. So it is very easy if we believe in teamwork, and if we can create teamwork, and if we can talk to women and Swami and Kalwarga and see what you can do and what we can do. Let's do it together. You have the mobile, but you do not have the uh, money to live over there. Don't worry. Your family don't need to live there. We will look after the woman when she is in a hospital like that. Okay.
Okay.
So that is my suggestion on this.
Oke, thank you Profesor Mahmud. So, Profesor ingin menyampaikan bahwa suboptimal skills yang dibutuhkan oleh tenaga kesehatan di Indonesia itu sebetulnya tergantung dari kebutuhan dari tiap daerah, karena karakteristik dari tiap daerah dan kebutuhan kesehatan maternal dan anak di tiap daerah berbeda. Yang jelas, kita harus meningkatkan kemampuan yang dibutuhkan bagi peningkatan kesehatan itu bisa dengan cara mentoring atau training yang sometimes harus dibantu untuk difasilitasi agar terlaksana. Karena sebetulnya di Indonesia itu tidak kekurangan resources, hanya saja tadi Profesor menampilkan dalam beberapa slides-nya bahwa terdapat kekurangan lack of coordination and bahkan mungkin itu diawali dengan kurangnya komunikasi yang baik begitu. Baik, Professor, I think we come to an end for your presentation because we have limited time and we have several speakers after you, and we would like to say thank you for your coming here as our guest speaker. And we would like to hand over the certificate from us to you as the speaker of the event. Tolong ibu-ibu panitia untuk ditampilkan.
Thank you for inviting me, and all the best for all the speakers and the audience.
Thank you very much, Professor, and this is the certificate.
Thank you.
Thank you very much.
Thank you very much. Thanks to everyone.
Thank you. Baik, respectful colleagues and also our lovely audiences, we come to the next speaker. We have Professor Azrina. Is Professor already come here?
Yes, I'm here. Yes, I'm here.
Okay.
Thank you.
Thank you, Professor Azrina. Welcome to Poltekkes Kaltim, Health Polytechnic of East Kalimantan, Indonesia. And we would like to say thank you for you become the guest speaker of the event. And without further ado, we would like to welcome you to start your presentation.
All right. Thank you, Madam Chair. And also thank you to Polytechnic Kesihatan Kalimantan Timur for inviting me. So from just now, I saw you have heard about this child, infant, and then followed by maternal. Now we go to nutrition. Yeah. So first of all, I will share my slide. I'm not familiar with this Zoom.
How can we help you?
Share screen, eh?
Yes, share screen.
Share screen, and then
yes, you choose the files that already open in your computer.
I will open first. Okay, you please update me if you can see the.
Yes, we can see your slides in PDF format.
Yes. Okay. So it is now clear.
It is clear.
All right. Okay. So I can start now.
Yes, please. Thank you.
All right. Okay. So Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. First of all, thank you for inviting me. I am so happy to share some of our findings related to nutrition. Specifically, I will be talking about sugar. To this fourth East Borneo Health International Conference. And I am Azrina Azlan from Department of Nutrition, Faculty of Medicine and Health Sciences, UPM. Okay, I hope you all know where is UPM. So we are in Putrajaya, near to Putrajaya, only 10 minutes away, and we are also near to Kuala Lumpur. Right. So just to share with you a good news about UPM. In 2024, recently, based on World University Ranking, we actually have come to a good position as before, and now UPM is ranked 4th in Southeast Asia, ranked 20th in Asia, and ranked 2nd in Malaysia. Yeah. So with this, we are in UPM, we are all very happy, and we welcome any of you who wanted to pursue your study in bachelor, master, and degree in UPM, right? Okay, so go back to my topic of presentation. The title today that I have is Healthier Dietary Sugar for the Prevention of Diabetes Mellitus. Okay, in general, I just want to mention that the presentation is not about promoting the use of sugar, because we know sugar is something that we should limit in our daily intake, right? But we are sharing information on an alternative, an alternative to what the presently available sugar, which is the granulated sugar. Okay, so this is the title, and this is the outline of my presentation. Yeah, so I will start with introduction, methodology, results and discussion, conclusion and references. And for the results and discussion, they are mainly based on our own study lah that we conducted in UPM. Okay. And okay, when we talk about diabetes mellitus, this is very common to everyone. I think everyone knows this, yeah. And this is actually a chronic condition, yeah, and characterized by high blood sugar level. And this is the condition that is affecting many people globally, yeah. And then we also know that there are two main types, yeah, the type 1 and type 2, and they are different because type 1 is due to autoimmune condition where little or no insulin is produced, and type 2 is the condition that develop, yeah, when the body become resistant to insulin or the body does not produce enough, yeah. So globally, when we talk about diabetes, yeah, it is actually causing challenge, yeah, to the world because of the rising cost and also the increase in mortality. Yeah. So just to share with you some data, some data that I check, yeah, world prevalence of diabetes 2000 to 2030, yeah, where it was reported, yeah, based on this information, yeah, in 2021, yeah, the prevalence rate was at 10.5 and predicted to increase to 12.2%. So with time, we see that the prevalence keep increasing, yeah, and of course it will impact the countries and the population as well. Right? So what happened in Southeast Asia? Yeah, similar condition is occurring. Yeah, as you can see in the statistic here, the current prevalence is at 8.8 and projected to increase to 11.3%. So of course there will be a big economic and health impact lah to all the countries in the Southeast Asia, including Malaysia and Indonesia. All right. So first we go to health statistic of Malaysia. This is the closest data that I can get, yeah? And this data is based on our own National Health and Morbidity Survey for Malaysia, and based on data published in 2019, yeah? For Malaysian, we have 1 in every 5 adults, yeah, having diabetes, giving to the a number of 3.1 million of people aged 18 years and above. Yeah? And for the latest National Health and Morbidity Survey 2023, we do not see much improvement, yeah? Because still 1 in every 6 adults in Malaysia have diabetes. Yeah? And this is something that worrying. Yeah? And on top of that, 2 in 5 of the adults do not know that they have diabetes, meaning that they don't go for their checking, yeah. And add on to that, yeah, now also in Malaysia, based on the latest statistic, yeah, that we have this situation of 3+1, yeah, 3+1, in which, yeah, the individual will have combination of diabetes, high blood pressure, hypercholesterolemia, and obesity, yeah. And this is affecting more than half million of the population, yeah. Okay, and also this is 3+1, which is 4, And also, there is also data on these three, which is three disease that occurring, yeah, at the same time among individuals, yeah, which is affecting 2.3 million of the Malaysian people. All right. So you can see based on the previous one is on the uh, uh, diabetes mellitus. Similarly, we can also see increment, yeah, in the overweight and obesity cases, yeah. And this is again based on our national data, NHMS, starting from 2006 to 2011, 2015, 2019, and until now, the percentage, yeah, is increasing all the year, resulting in 1 in every 2 adults. And as we know that overweight and obesity, yeah, they are the risk factor related to diabetes as well. Okay, so why is it happening like that? Because based on the NHMS 2019, we can see that, yeah, the intake of sugar is high. Yeah, the intake of sugar is high, and based on the data, yeah, 1 in 3 drinks, yeah, Malaysian, yeah, 1 in 3 people, they are taking carbonated beverage, yeah, carbonated beverage as part of their daily diet, and beside other dietary factors such as not enough in the intake of fruits and vegetables, as well as going for more of the fast food, yeah, at least 3 days a week. All right. So in terms of the sugar just now, we the carbonated beverage actually is among those called as sugar sweetened beverages, and the amount, yeah, that is taken, yeah, is actually based on the data also from NHMS 2019, and we can see that, yeah, the SSB intake is around 3 teaspoons of sugar daily when the beverage, the SSB, is self-prepared, yeah? And can be up to 6 teaspoons daily, yeah, when the beverage is as carbonated beverage and other carbonated drink, yeah, and also if they are taking the premix drink, which is the 3-in-1, 2-in-1, all right, and the amount of sugar can be up to 3 teaspoons daily, yeah. So when we talk about the range, yeah, the range is from 3 to 6 teaspoon, yeah, and the amount actually can range from 4 to 7.5 gram, yeah, per teaspoon. So you can imagine if 6 teaspoon is taken, yeah, that will contribute a lot lah, yeah. So next we go to Indonesia, and this is the data based on WHO, yeah, that I look for. Similarly, in Indonesia, the country also is showing similar trend in terms of the NCDs, and we can see that diabetes is number 3, yeah, after stroke and ischemic heart disease for both males and females. All right, and the probability of dying from the NCD in Indonesia 2019 is up to 25%, yeah, of the people die before their 70th birthday, yeah, beside other causes of death lah that you can see in the file, yeah. So actually all this statistic is telling us that there is a big economic impact, yeah, in which we can see rise in the healthcare costs, yeah, and this is the healthcare cost that should be taken care by the government, yeah. All right. So what about the sugar intake of Indonesia? Yeah, so this is based on a paper published in Asia Pacific Journal of Clinical Nutrition in 2019 that report on consumption and sources of added sugar in Indonesia. And in this paper, which summarize, yeah, the evidence available from data in Indonesia based on a food balance sheet, household expenditure survey, nutrition survey, published papers, yeah, and some of the unpublished thesis and others, the intake of sugar, yeah, is actually still below 50 gram per day or below 10% of energy, meaning that based on this published information, the intake of sugar for Indonesian is not that high, not exceeding yet the recommended level of WHO. Yeah. However, these studies conclude that this is still insufficient. Yeah. And they propose a nationwide survey should be carried out. Hopefully, if you can, maybe something like our National Health and Mobility Survey lah, yeah, which you can gather much more accurate information, yeah. And also the paper suggested, yeah, for identification of the actual food sources that contribute to the intake of sugar. All right. And similarly, globally, sugar sweetened beverages is also high, yeah, in most countries, yeah, and it is involving those socio-demographic high socio-demographic index area, meaning that mostly those people in the cities, yeah, and town. All right. Okay, so I have this data as well because I have the idea of some of the participants are also staff, yeah, of Ministry of Health. This is data of Malaysia on the prevalence of overweight and obesity among workers in Malaysia. Yeah? And based on this data in Malaysia, yeah, 35 to 72% of workers in various fields were reported of being overweight and obese. And as we all know, this is one of the risk factor related to diabetes. And of course, the study that was conducted in Kuala Lumpur, yeah, for the group of the people, the health condition or the obese and overweight condition is actually related to their lifestyle of being less active. Yeah, 49% being less active, nearly to 45% not getting enough sleep. Yeah, and also skipping breakfast and also skipping lunch. Yeah, so when we skip, yeah, any of the main meals, it will lead to the amount of intake in the following meal will be much higher, yeah, and maybe exceed the amount needed for a day. Yeah. All right. So this is from Chua 2022, yeah, and this is on the descriptive data related to the subjects that were observed. All right. Okay, so this is on comparison in terms of overweight and obesity between Malaysia and Indonesia. And for this data, yeah, based on WHO 2011 and World Population Review 2019, Malaysia is leading lah, yeah, in terms of the overweight and obesity, and we are actually number one still in 2019. Yeah, but Indonesia is I think in a better condition, as you were in fifth position in 2011 and fourth position in 2019. So meaning that you have you can still provide much more preventive measures. Yeah. So now we go to sugar. Sugar in the food products, yeah, in the food that we eat, yeah, actually the main function is to sweeten, yeah. And when we talk about dietary sugar, what is it? It is actually all type of sugars, yeah, that can be found in food, meaning that all the sugars after being digested and then they become available in the bloodstream and being absorbed in the body, yeah? So that is actually the total dietary sugar, and they actually can come from either natural sources or being added into food, yeah. But beside for sweetening effect, yeah, sugar actually is providing many more functions, yeah. And as you can see in this table, yeah, there are many functions of sugar in food. Okay, aeration, boiling point, browning, bulking, and others, as you can see here, because they are added into various food, yeah, that are important in our daily diet. Okay. All right. Okay, so now we will concentrate to refined sugar. Yeah? I hope you know what is refined sugar. Refined sugar is actually the granulated sugar, the white sugar that we use daily. Yeah, and they are actually mainly from the either sugarcane or sugar beet. So these are the sources. And when we look further, the refined sugar is actually mainly sucrose. So sucrose is a kind of disaccharide. Yeah, and this refined sugar, they are usually added into various food products either during food processing, during manufacturing, or during preparation that we conduct at home. Yeah, so these are the two sources of sugar added during processing and preparation that give to the amount of added sugar in our diet daily. Yeah, and as we all know, excessive intake of added sugar, yeah, has been consistently linked with NCDs, yeah, such as obesity, diabetes, type 2 diabetes mellitus, CVD, myocardial infarction, dyspepsia, peptic ulcer, and dental caries. All right. Okay, so studies also have shown that the added sugar actually, yeah, in beverages. Why beverages? Because as you can see, yeah, as compared to the solid food, yeah, the beverages, they tend to be easily added, yeah, and this actually has led to significant obesity and metabolic disturbance in many countries as compared to solid food. Yeah, because when you add sugar into solid food, it will be uh, based on certain weight, yeah, that is planned. But when in terms of the liquid, it is much more easier. Yeah, and for that reason, yeah, the WHO, yeah, has recommend that sugar consumption, yeah, should be below 10% of the total calories per day. Yeah, so meaning that if you are taking 2000 calories per day, yeah, from you wake up until before you go to sleep, yeah, only 10%, meaning that only 200 kilocal, yeah, can be to the maximum that can be contributed by the added sugar, yeah, or should be below 5% for further health benefits, meaning that if we are looking for better health outcome related to sugar intake, then we should reduce it to 5% or less, right? But in order to reduce sugar, it is very challenging. It is a daunting challenging, yeah, because we easily tend to underestimate the amount of added sugar, yeah. And for your information, yeah, most of the packaged food, yeah, most two-thirds of the packaged food, they are rich in added sugar. Why? Because sugar is one of the important preservative, as you saw just now. Yeah, so it also enhance flavor and it also extend the shelf life. Yeah, so in a way, most of the processed food, packaged food, you really have to look at the sugar information. Yeah, and of course the sweets, all the sweets and the soft drinks, yeah, typically contain high level of added sugar, and even in some of the product, yeah, claim as healthier choice. Yeah, I'm not sure in Malaysia, in Indonesia, but in Malaysia we have healthier choice. Yeah, so when you are buying the healthier choice product, be sensitive to look at the label. Yeah, so example of some of the healthier food products such as granola bar, yeah, breakfast cereal and yogurt. Yeah, so we have to really understand what we take. Yeah, and why sugar is that much in the processed food? Because it serves many functions. As I mentioned, extend shelf life, provide the color, yeah, caramelized color, brown color, yeah, and then the flavor formation, caramel flavor, yeah, and also providing bulk and texture to some of the food, and also preservation. Right? So uh, so reducing or eliminating, which serve the when we actually try to reduce, or when we try to omit sugar actually, in food product, what happen? It will cause it will result in less less preference for the intake, yeah, because sugar they serve many function. So in order to replace sugar, yeah, we have to substitute with something, yeah, to fulfill the lost function, yeah, of the sugar, yeah. So example here, let's say you are you are comparing the carbonated beverage with sugar and the diet carbonated beverage. So in the diet carbonated beverage, they have to add CMC, yeah, in order to provide the bulkiness in the mouth. So meaning that it is very challenging actually when we are trying to reduce or eliminate, right? So the choices that we have, yeah, for the reformulated sugar product, lower sugar products, we can always go for the non-caloric. This is the alternative sweetener that we know just now, the high intense sweetener, yeah, or the low calorie sweetener, the sugar alcohol, yeah, so that it can still provide the desired taste profile, which is sweet, yeah. All right, but today, as we all are aware, yeah, quite recently, WHO also has advised, yeah, not to use non-sugar sweetener, yeah, meaning that this is the alternative sweetener lah for weight control, yeah, in their new guideline, because there is a potential risk of other adverse health outcomes such as cancer. So meaning that even though we have an alternative, yeah, but we have to also be careful, yeah, and mindful. All right. So the idea of reducing the sugar intake, yeah, has created awareness, yeah. So that is why now some food industries, they have worked for this alternative healthier sweetener, yeah. And the property of this alternative should be natural, unrefined, or the kind of those less refined, yeah, or the natural ones such as maple syrup, honey, and others, yeah. So these are actually some of the alternative that can provide the nutritional value in the food that we are preparing or we purchase, and at the same time still giving the sweetener, yeah. And for all this, of course, the natural sweetness is the best option lah, yeah, because it is still containing good amount of nutrient, yeah. They have been less processed. Of course, some of those, they are low in GI, yeah, and they also contain phenolic compound and minerals. All right. So before we go to the sugar that I will be sharing with you, I just want to share with you the basic scheme of how actually the refined sugar is processed. Yeah. So it starts from the field, yeah, and then being harvested and undergo all the processes such as crushing, heating, liming, clarification, evaporation, crystallization, and centrifugation, yeah. So at this stage, yeah, centrifugation, this is the stage in which it causes the differences in the making or the production of refined sugar or the less refined sugar, yeah. So for the refined sugar, the granulated sugar that we take every day, the product actually from the raw sugar, it will undergo further the next processes, as you can see here, yeah. Washing, filtering until the solution is clear, yeah. And then the removing the brown color, yeah, removing the minerals, crystallization, and final centrifugation, and you get the sucrose that you have, yeah. But the minimally refined brown sugar, or the LRS, that I will introduce to you is something that is different from this step, yeah, in which the sugar, yeah, this LRS, yeah, less refined sugar, or the minimally refined brown sugar, they are undergoing this special spinning process, yeah, that only separate the molasses, right? Okay, right. Okay, so actually for the sugar, yeah, so there are various type of processed sugar from sugar cane So they can either as centrifuge brown, yeah, or centrifuge brown sugar or the refined sugar. So this is the most common one lah, the easiest one that we buy. This is the one actually from the mostly from the traditional industry, yeah, that the producer made on their own, yeah, and they are called by various names, yeah, according to the country. And this is the centrifuge brown sugar, still coming from the manufacturing process. It's just that differences in the centrifugation and spinning process, and it gives rise to this example of LRS, less refined sugar, and MRBS that I will share with you today. Alright, so the LRS or the MRBS actually, because of the minimal processing, they are able to retain more nutrients, yeah. And our study found that the LRS, yeah, actually as compared to the refined sugar RS, which I will call as RS, has a lower glycemic index, yeah, and also still contain good vitamin and minerals, and also beneficial compound like antioxidant, yeah. So this is the comparison between LRS and the non-centrifuge sugar just now, yeah, the one that is traditionally produced, yeah. So the difference is in the spinning step lah. And for the product that we are testing, it is it has gone the patented process, yeah, which they don't reveal lah. And they are actually, the LRS is still brown but lighter in color, yeah, and with milder flavor, and it has the characteristics of free flowing, not clump. So the processes is unique in which the quality is as if it is the refined sugar. It's just that it is more brown, slightly brown, yeah, lighter color and free flowing. Yeah. So this is the characteristic needed for most of the form of sugar used in the industry. Yeah. And they have made this and suit for industrial application. Okay, so we are actually receiving grant from the company, and we have conducted the study lah. Yeah? We some of those have completed, and some still analyzing. Okay, so and for the LRS, I will call it LRS. This is actually the granulated lighter brown sugar, yeah, containing vitamin, minerals, and phytochemicals, and the characteristics of the phytochemicals, which is the phenolics, is 3 times higher, yeah, than the level available in the refined sugar, yeah. All right, so and we also have tested that the LRS also showed in vitro anti-diabetic activity, yeah, based on the inhibition seen in alpha amylase and alpha glucosidase test, right? Okay, and our study also found that the LRS, yeah, is a low glycemic index sugar. Yeah, I can share the results after this. Yeah, and also at the same time, the LRS also enhance satiety, meaning that it will make you feel full longer. Yeah, so having said this, yeah, so we wonder now, yeah, can we use the LRS, yeah, to substitute the RS, yeah, in helping community, the people, yeah, to control their chronic diseases, especially the diabetic condition. Yeah, so we did this study, yeah, involving animal and human subjects. Yeah, so we want to investigate, yeah, whether the LRS can be the refined sugar alternative, whether they are healthier, yeah, and whether it is suit or not for industrial application and to be applied in a daily consumption. All right. So first of all, we started with a preliminary work, yeah, in which we compare the LRS versus the RS at different doses, yeah, on glucose regulation, and we use animal model, yeah, and in the animal study we compare the healthy and diabetic conditions, and we want to see whether the compound in the LRS will influence and improve selected markers, yeah, of the studied model. Yeah. So in study 1, we have this animal model, yeah, where we are looking at the differences in glycemic response of LRS versus RS, yeah, in healthy and type 1 diabetic condition in rat. Yeah. So this is actually a big study in which we want to understand the mechanism as well. So we have two phases of the study. The first one is the preliminary study. Yeah? So the one that I will share here is the preliminary part, yeah, in which we found the dose, yeah, the best dose, yeah, to be incorporated into the main study, and from the main study we will determine the mechanism involved. Yeah, so I will share with you the results of the preliminary study. And you, in this study, actually we have two groups of rats, the healthy and the diabetic. We feed them with the LRS and the RS, and we varied the level. We varied 5%, 10%, and 14%, yeah, of the sugar exposure, yeah, and we feed the animal through oral gavage, and we monitor the glucose level, yeah, and also we did this acute study of 2 weeks intervention, yeah, of the LRS and RS, yeah. So how does these two study different from the findings of the acute study? Actually, we focus to one unique dose lah, one unique dose that we will do further subacute study lah, for which we apply the metabolomic technique, yeah, beside measuring the biochemical markers and histology, yeah. So this study will give the mechanism involved, yeah. Alright, so in terms of the methodology, of course, the study has been approved by the Animal Ethics UPM. And in the animal study, we are using 3 doses, as I mentioned, the low, medium, and high dose. And for the low dose, is actually 5% lah, the dose as recommended by WHO for further health benefits. Yeah, the medium one is at 10%, and the high dose is actually at 14%. And this was based on a statistic on daily consumption according to American guidelines. So this is actually considered high. All right. So we did 3 studies, small studies. We did the OGTT on healthy rats. Yeah. Why we do this on healthy rats? Because we want to establish a baseline, yeah, on the differences between effect of LRS and RS, and we want to understand the glucose metabolism and insulin sensitivity. Yeah, so you can see here we have the low, medium, and high dose, yeah, of the LRS, and 3 doses of the RS. All right. Okay, and we also do the same study in diabetic rats, yeah, and using the same doses, yeah. And why we have these diabetic rats? Because we want to assess severity of the glucose control in the diabetic condition, right? And next, in the still, yeah, in the preliminary study, we also looking at the acute exposure, yeah, of the different doses of both LRS and RS, so that we can understand how the blood glucose spike, yeah, related to insulin release, and how does the insulin respond. All right. Okay, so now we go to the results. For the first study in healthy rats, you can see, yeah, the LRS, the one with less refined, yeah, at low and medium doses, actually they cause a lower glycemia as compared to RS. Yeah, still glycemia but lower. Yeah, then, and also the at high dose, yeah, the effect of LRS is similar to RS. So meaning that we are very sure that of course, even though the sugar is claimed to contain certain antioxidants and certain vitamin and minerals, a high dose is still not good. All right. Okay, and the results, yeah, we can see here from the figure, we can clearly see that the response of the LRS low, yeah, is much better, yeah, as compared to RS low. All right. Yeah, and you can see at the end point of 180 minutes, it is much lower. Yeah, and also similar trend for the LRS medium. Yeah, so you can see, but not the high dose. All right, and also the LRS low, yeah, the low level, which is at 5%, had the lowest global glucose global response, as you can see here, and it is significant. All right, so this is something that convinced us, yeah. And in the diabetic condition, we can see that the result is as you can see here, yeah. Of course, the green line is much lower. It's much lower. Is much lower for the LRF. Yeah? And of course, of the three, the low and the medium is the best. All right, it's the best. Yeah. And for the incremental area of the LRS low, yeah, so this is LRS low, the incremental area, because we calculate the area under the curve, yeah, it was significantly lower, yeah. So this significant is actually seen, yeah, seen in the area under the curve, yeah, as compared to other groups that we study. All right. For the medium one, LRS medium, we can see minor reduction, yeah, some minor reduction at 2.56%, even in the diabetic rats. All right. So when we expose, yeah, the model to the sugar for 2 weeks acute here, of course we can see, yeah, for the glucose, yeah, it will spike, yeah, and we were not able to see any significant difference, yeah, because of course this is in the diabetic condition, yeah. And for insulin under normal condition, for the normal rats, we can see the trend is as predicted, yeah, in which from the low to medium to high dose, we can see the trend of the insulin release from moderate to higher to substantial, yeah. So this is the normal response lah, yeah. But in the diabetic condition, actually, of course, diabetic condition, we can see we saw not much improvement. It's just that we can see certain trend, yeah, where you can see for the low dose, of course, insufficient insulin, so that in order to bring the sugar level back to normal, yeah. When in the medium dose, of course, the pancreas will struggle, yeah, and this result in hyperglycemia. And for the high dose, of course, it will prolong, yeah, the elevated blood sugar level, yeah. So because this is acute exposure, yeah, so which we cannot conclude much, yeah, okay, but we are able to see some trend lah, yeah. And also again in this lipid profile, yeah, again we are not able to see a very good trend here, yeah, but we can be assured of the dose to be tested further lah, yeah. Just to share with you some of the data, yeah. So what happened when sugar is excessive? Okay, it will not give a good information, yeah, good marker in terms of LDL, TC, and of course TG. Why? Because excess sugar, yeah, excess sugar will cause complex relationship lah between the sugar and HDL, yeah, and also it will alter the LDL particle size, and the composition become more denser, and also the high sugar actually will contribute to higher circulating triglyceride level. All right. Okay, so for the two dose that we think quite appropriate, yeah, we found that, yeah, the benefits, yeah, as seen in the low and the medium dose is actually related to the presence of phenolic, yeah. This is based on our work, in which we saw that, yeah, based on three different extraction technique that we apply, the LRS is containing higher level, much higher level of the phenolics, phenolics as you can see here, syringic, caffeic, p-coumaric and ferulic acid at nearly to 57 microgram per gram of dry weight of sample. Okay, all right. Okay, so this is based on the result of the in vitro work involving alpha amylase and alpha glucosidase inhibitory assay, where we can see that the LRS and BS here is brown sugar. Okay, so these two sugar, they are containing the phenolics, and they are able to show minor and moderate inhibition, in the in vitro condition. So we can say that the bioactive is the one that is responsible, for the potential health benefits lah, in which mainly the bioactive, they are actually the caffeic and the ferulic acid. Okay, and also the LRS is actually is considered as a low GI food ingredient, because we have conducted this study and I will show the results after this. And also due to the higher phenolic content level here, and also the LRS at the same time also rich in minerals, and we have actually measured the minerals, and the type of minerals include selenium, potassium, calcium and chromium. So with the characteristics of phenolics and certain minerals that I mentioned here, the LRS is a potential alternative, or as a healthier option, healthier option that can help to inhibit the glucose digestion, inhibit the glucose absorption, improve the glucose uptake, and also activate the insulin receptor. So these are the earlier postulation lah that we will confirm later from the main study. So we conclude based on the first study that the LRS, the suitable dose is only for low and medium, and integrating LRS, at low and medium dose is actually can be part of the refined sugar replacement. All right. Okay, so the other detail of the study will be revealed later in the main study, in which I don't have yet the data. Alright, so next is from the same sugar, in which we conducted the study in human subjects, and we want to look at the effect of LRS as an alternative sugar as compared to the granulated or the RS sugar in human subjects, and we have got this human ethics clearance from UPM. So we have two studies. First is the GI study. So for sugar usually, or for the high carb food, we have to determine the GI value. So this is when we have a group of healthy subjects, and we randomize them. We start with 27. The final N is 16, and we randomize them to receive either MRBS, RS or BS. So BS is brown sugar, RS is refined sugar, MRBS is the LRS just now. The same name, the same sugar, just that we use two names for the sugar. So we do this study in crossover design, and we analyze the final N, and we did the GI calculation. And based on this study, additional to the GI study, we also have this satiety study that is conducted in another group of healthy individuals, not the same individuals. This is another set of individuals where we want to understand the acute effect of the sugar LRS in comparison with the RS in healthy subjects in terms of the glycemic profile and satiety profile. So we conducted this among students and staff of UPM for 2 weeks, and we collected the data lah. So some of the data such as anthropometric questionnaires, and also we did the VAS score. Alright. So for this second study, we enroll 14 subjects. We did the assessment for eligibility. And finally we include 14 subjects, and we allocate them to either receiving the LRS jelly or the RS jelly. Yeah, and we did this in a crossover design also. And then finally, we were able to analyze the data of the 14 subjects. Yeah. So during the test, actually, we get them be with us half a day. Yeah, and they have to consume the jelly. Consuming the jelly in the first a meal of the day, yeah, and we give them plain water, yeah, and they were with us, and during the half day period they were only allowed to read, walk and sit, and not doing any exercise. So for this human study, we found that, yeah, for the first GI study, it is very clear that the LRS or the MRBS is actually a low GI sugar lah, yeah, as compared to the RS, the sucrose is medium GI, but the brown sugar is actually much better in terms of the GI value, yeah. So this is what we observe, and this is in line with the prediction that we have in mind, yeah. So you can see how the blood sugar level, yeah, how it changed with time over 120 minutes for the studied subjects, yeah. And we also were able to see that the blood glucose response was significant, yeah, between the reference food and the test product. So the test products, we have 3 here. The reference food that we use was this glucose or glucolin. All right, okay. So for the glycemic profiles, we saw that, yeah, LRS cause lower glycemia, yeah, as compared to RS, and this is according to the glucagon level, yeah. And intake of RS and LRS jelly did not significantly different in terms of glucose and insulin level. Same, yeah, similar trend as what we saw in the animal, yeah. But we were able to see changes in terms of the duration, yeah. We can see the trend, yeah, from one point to another, yeah. But interestingly, yeah, LRS jelly actually showed a lower glucose level compared to the RS jelly. This is the form of the jelly that we provide to the subjects lah, yeah. So we prepare the jelly fresh, we using the same formula, it's just that we differentiate in terms of the sugar, and we were able to see this, yeah, lower glucose level, yeah, and it is significant, yeah. So this is the glycemic profiles that I mentioned just now, and the significant here is in the glucagon level lah, yeah. All right. So in terms of the satiety hormone, we also measure the satiety hormone, and we saw that of course differences in the effect of RS and LRS jelly, yeah. The RS jelly did not cause significant difference in the GLP, but we were able to see significant changes, yeah. Okay, we were able to see changes, yeah, changes in terms of the PYY, yeah, even though not significant, yeah, but we can see increment, positive increment across time, in which we conclude that the LRS actually is providing better satiety control as compared to the RS, yeah. All right, and also we can see significant differences for the C peptide, okay. So this is the data that I mentioned just now, yeah. And we also did this visual analog scale or VAS score, and for this we cannot see differences, significant differences in terms of the hunger, fullness, satisfaction, and prospective food consumption, but we were able to see significant, yeah, significant score in terms of the fullness, yeah, a score for fullness and quantity to eat further after that, yeah. After intake of the LRS jelly 2 hours after the consumption, yeah. So we can say that, yeah, the LRS is actually can offer a better satiety profile lah, yeah, to human subjects, healthy human subjects, yeah. So this is the results. Okay. And one thing very interesting, we also were able to see increment, increment in the total antioxidant content in the blood. Comparing between the RS and MRBS or LRS, we were able to see this. We were able to see this increment. So this is something good, meaning that as compared to when you have zero antioxidant in the sweetener. Alright. Okay. So the study, the human study, we can say that the LRS actually has low GI value, which is below 45. But the RS is actually medium. And the LRS is actually better option. Because it may offer certain antioxidant. And also offer better satiety profile. Alright. Okay. Okay. And also the LRS, as I mentioned, has resulted in higher C-peptide level in healthy subjects. And this gives us the idea of better beta cell function offered due to the exposure to that sugar. So this study also the refined sugar, as we all know, high glycemic carbohydrate, which is the RS, it is actually associated with reduction of appetite and food intake. And in contrast, the LRS is much satiating, because it delay the feeling of want to eat, up to 6 hours. Okay, so we can conclude that based on the better glycemic profile, the low GI value, and the improvement in higher antioxidant level in the blood, several mechanism may be involved. It may inhibit glucose digestion, absorption, also improving the glucose uptake and insulin sensitivity, and also regulate certain enzymes. And for your information, one of my PhD student is working on this, and we are yet to finalize what are the pathway as well as the agent or the improvement that we can see at the micro level. Alright. So control all this based on what we have observed from the human study, we can conclude that the control of the digestion of starch, the GI value and the sugar as well, to help to reduce postprandial glycemia, reduce blood sugar, and may promote a lower glycemic effect, and also inhibit the antioxidant and the activity of the free radicals. Okay, so this is the conclusion of the second study, where we can see the potential of the LRS Alright, but further research is recommended. So this study actually finding of the two studies, the animal and the human, actually require further studies need to be done in human subjects. But quite unfortunate, we were not able to continue further to see the long-term effect of the LRS in human, because of the company that stopped the sponsorship.
Excuse me, Professor?
Yes.
Because our time is up. Yes.
Okay. Just I want to include a few minutes more, can? 3 minutes? Okay?
Yes.
Alright. So we did also reformulation study using the same sugar, and we did this in vitro work, and we found that the use of the LRS actually improved the GI value, EGI value, which is very interesting. Some of our published papers and some of the take-home message on the sugar intake. Okay, first you should cut back the sugary drinks, sugary desserts, and must read label. Alright. Okay, go for whole food. Go for whole food and apply the 5 principles of healthy diet. Okay, so the first one is eat a lot of plant food, take adequate protein, minimize all processed food because they tend to have more sugar, and limit set fat, added sugar, and sodium in your diet. And these are 3 healthy tips for sugar. All right. Okay, so actually sugar is very tricky because they have many names. Okay, and make sure your diet is balanced and variety. And also in Malaysia, we apply this quarter half. I think Indonesian is also doing the same. And these are the references for my presentation. So with that, I end my presentation and thank you. All right.
All right. Okay,
Okay.
thank you.
So, any question?
Yes, thank you, Professor Azrina, for the presentation, and I believe that you give us insightful knowledge about the sugar as a healthy diets and how to use it wisely. I think that our audiences also have some questions for you, and here we have one audience who want to ask directly to you, Irham Nur Yasin. Please open your microphone, Irham.
Good morning, Prof.
Yes.
Before I ask question, I would like to introduce myself.
Yes.
My name is Ilham Yasin as a nutrition student at the East Kalimantan Health Polytechnic.
Okay.
Straight to my question, according to your experience, Prof, do social cultures factor influence sugar consumption patterns in society? How do traditions, eating habits, and social status influence the choice of foods and drinks containing sugar?
Can you,
Traditional Indonesian, yes,
Irham, if you think that you want to speak in bahasa also
Bahasa.
can, because I
Um,
cannot get the question.
yes.
If you want to mention
yeah,
in bahasa also can.
Mau bertanya dalam bahasa Indonesia, silakan Arham, because Profesor membolehkan. Silakan.
ya, ya boleh. Uh, Sebentar deh.
Atau
Menurut pengalaman Profesor, apakah faktor sosial budaya mempengaruhi pola konsumsi gula di masyarakat? Bagaimana tradisi kebiasaan makan dan status sosial mempengaruhi pilihan makanan dan minuman yang mengandung gula? Makanan tradisional Indonesia dan Malaysia terkenal mengandung gula yang tinggi.
Is that all, Irham? Is
yes.
that all, Irham? Yes. Okay. Thank
Can
you.
you
Yes.
hear that clearly, Professor?
Okay, yes,
Yeah.
I got it. Okay, thank you so
Thank you.
much, Irham, for the question. Okay, I agree with you. Yeah, we Malaysia and Indonesia, yeah, we tend to have a lot of traditional cakes. Yeah, all the kueh. Yeah, they are all interesting and they are all actually very sweet. Yeah, and they are mainly made of carbohydrate base, made of various kind of flour. Yeah, rice flour, wheat flour. Yeah, and then other flour lah. So this is actually when they are being digested, so they are actually becoming the monomer and still contributed to the total sugar of dietary intake. And because we are so used to all this variety of interesting and tasty food, yeah, this is a way in which can affect lah our health status in terms of the total sugar intake. And frankly, if you take a lot of the carb, yeah, a high carb diet, yeah, or added somehow with the sugar, yeah, the tendency of uh, getting more than 10% of the total calorie is there. Yeah, so I am totally agree with the how the polar of food intake as well as the food choices is affecting. All right.
Okay, thank you, Professor, for the answer. And then, do you have another question? Yes. Please, Desti. Desti Aura, you can open your microphone. Apakah kita kehilangan Desti? Silakan Desti. Silakan dibuka mikrofonnya.
Okay, good morning, Professor. My name is Desti Ranisa. I'm nutrition student of Poltekkes Kaltim, and I have a question for you.
Yes.
Professor, how can we inject communities in developing diabetes prevention programs based on local foods and traditional eating habits? Okay, thank you.
Okay, you asking me how do we improve the communities?
Yes, the
Is it?
question is how to engage the communities in developing
Okay.
diabetes prevention programs, Professor.
All right. Okay. So as for me, okay, frankly, I am from the more of the lab kind of research, yeah. But generally, first for me is important is to do to educate. To educate. First, we have to educate the community so that they are aware of the sugar sources and the carbohydrate sources. So this is one way. And for them at the community level, you are not just talking about carbohydrate and sugar. You have to meet them, you have to show the actual food, and you have to tell them this food is actually this much of sugar, this beverage is this much of sugar, so that they can actually see. And then from there, when if the food is high or very sweet in terms of the sugar content, then we should teach them on how to improve the preparation technique or improve the manufacturing technique lah. So meaning that we can always suggest the alternative for that. So instead of using the granulated sugar, for example, I would suggest that we go for the traditional sugar, those gula merah. You know gula merah, the brown sugar that is traditionally produced.
Yes,
In which because they still contain the molasses, the brown color. They are the sugar that is high in the phenolics and also in terms of the mineral content. Okay, so it must be a proactive kind of approach where you have to be with them to show them examples of the food and also to teach them on how to modify the preparation as well as the type of selection of food. All right, am I answering your question?
Yes, thank you for the clear answer. And then the next is the list of questions who already categorized by our committee, please.
This is three questions. These three questions. Okay, what exactly is meant by healthy dietary sugar?
Oke, pertanyaannya ibu-ibu panitia silahkan. Mohon.
Okay, it's okay. I can read. I can read on my own.
Yes.
Can I straight away answer? Okay. So okay, actually, okay. As we all know, in general, sugar is a chemical. Okay, we must have the idea that sugar is a chemical, and we as a nutritionist, we will never promote sugar because we all the time we want to reduce the sugar intake. Yeah. But now in my study, what I am suggesting is a healthier option. Yeah, healthier option in which we were able to see some of the potential benefits in terms of increasing the antioxidant level in the blood as well as improving the satiety effect. Yeah, so this is what I'm trying to share with you. So, and in terms of the differences between natural sugar and added sugar, okay, so natural sugar is the sugar available in the original food. Yeah, and mostly this sugar, because they are from the natural form, they are still in the intact form and they are at the appropriate level. As compared to added sugar is something that we use the granulated sugar and we add into the processing and the preparation. So usually for the soda beverages, for example, in order to give the certain level of acceptance and sweetness, the amount added usually is high, can be up to 6 to 10 teaspoon. Yeah, and that is actually the example of SSB, sugar sweetened beverages, that is available in the market now. Yeah. So in terms of the recommended daily intake, we should follow the WHO recommendation lah, in which I mentioned it should be less than 10% of the total calorie. So if you calculate that, that is 200 kilocal, and if you divide by 4, it is actually 50 gram 50 50 gram per day, and that is actually the total for the whole day from you start wake up until you go to sleep. So meaning that if you actually have overdose in terms of your sugar intake during lunch or during dinner, you have to ensure that other meal time you should omit out or you should decrease. Okay. Number two, how are the policies developed and developing countries regarding sugar consumption? Okay, basically in Malaysia, we are following the nutritionist and dietitian. We are still following the WHO guideline. It's just that in Malaysia now we have this sugar tax, and this sugar tax is for the manufacturer, in which if they have the initiative to reduce the sugar level in their food products, they can get benefits from this kind of initiative lah from the government. Alright, so this is in a way to ensure the health of the nations. So that is one of the initiative lah. But actually, for your information, there are many more studies that are being conducted in UPM and throughout Malaysia. For example, some of our group in UPM, they are also measuring the level of sugar in the SSB. They go to restaurant, they go to various food outlets. They actually collect the samples and they are analyzing it lah. Yeah. Question number 3. What is the form of education for wider community regarding the use of less refined sugar? Of course, this is the role of the nutritionist and dietitian at the community level lah. Yeah. So the form of education, as I mentioned earlier just now, it should be in the form of showing the examples. You go there, you show the food, you tell them the amount of sugar, the amount of carbohydrate that will change to sugar finally, and you show them the alternative, what are the alternative, and actually after that how to make improvement to the recipe, or you can do the reformulation of the food. Alright, okay, did I answer all the 3 questions? Is that okay?
Okay, thank you. I think all the question are already answered by you. And we come to an end of our presentation, Professor, and allow us to hand over the certificate of speaker of the event to you.
Thank you so much.
Mohon disiapkan, ibu-ibu panitia, sertifikat. Baik.
Thank you so much.
So, kami mengucapkan terima kasih Profesor atas partisipasinya.
Alright.
Thank you Professor for your participation. Okay. My respected colleagues and also my lovely audiences, we come to the 4th speaker of the event, and it is Melanie T. Reboldera, registered nurse, Doctor of Nursing Science, with the title of the presentation is Program Implementation to Prevent NCDs in Community. Do we have Melanie here? Okay. The community confirmed that Miss Melanie is still not in our virtual Zoom. So maybe we can kita bisa menampilkan video profil terlebih dahulu.
Seringnya kita melihat masa depan kejauhan, padahal masa depan itu ada di depan mata kita. Inovasi yang terdepan, tercepat, meninggalkan yang lainnya. Inovasi itu ada di HP kamu, di aplikasi kami. Living by Mandiri, inovasi Beyond Super App, yang mengedepankan semua kebutuhanmu. Dari kebutuhan transaksi harian, hingga hunian. Bersama ratusan fitur inovatif, buat kamu santai menjelajah kemana saja. Inovasi tinggal tap-tap kami, memudahkan perjalanan tanpa batasan. Dan saat akhirnya menemukan barang yang kamu inginkan, bayar dengan praktis. Meski terpisah jarak dan waktu, inovasi solusi pasti valuta asing kami menjauhkanmu dari rasa asing saat transaksi pakai mata uang asing. Dalam satu aplikasi, kami mudahkan langkahmu berinvestasi. Living by Mandiri menjadi yang pertama membantumu mencari rumah sesuai impian tanpa harus keluar rumah, hanya dengan selangkah menuju rumah. Dan impianmu akan terwujud untuk bangun jadi rumah yang kamu mau. Lebih dari transaksi harian hingga hunian, inovasi Beyond Banking kami menghadirkan hiburan hingga lifestyle untuk menjauhkanmu dari rasa jenuh dan bosan. Bahkan membawamu merasakan pengalaman lebih menyenangkan. Kami berinovasi lebih jauh menghargai semua yang kamu lakukan. Hargai lebih, mengembalikannya dalam bentuk yang berharga. Living Beyond Super App, inovasinya tak hanya sampai di sini. Kami terus berinovasi dan memberikan pengalaman baru perbankan masa depan yang lebih jauh lagi. Temukan masa depan perbankanmu di Living by Mandiri Beyond Super App.
Bisa kita mulai? Oh iya, pelaburan ya? Hah? Oh iya. Sorry. Tes. Baik, kita kembali Bapak Ibu, kolega yang terhormat, juga audiens dari seluruh Indonesia yang tergabung dalam acara seminar internasional dari Politeknik Kesehatan Kementerian Kesehatan Kalimantan Timur. Terima kasih kami ucapkan masih bergabung di dalam ruang virtual Zoom untuk sama-sama kita mengikuti pemaparan dari pembicara pakar kita selanjutnya, yaitu Dr. Aminah Toha, Sarjana Kesehatan Masyarakat, Magister Kesehatan. Beliau akan membawakan paparannya yang sangat menarik berjudul The Role of Maternal Care in NCDs Prevention, Lesson from Dayak Kenya Community Practices. Apakah Ibu Dr. Aminah Toha sudah bergabung? Audiens yang kami hormati, kami minta untuk tetap semangat mengikuti seminar ini karena topik yang akan dibawakan oleh Ibu Dr. Aminah Toha adalah topik yang sangat penting dan menarik ya, yang dapat kita implementasikan di dalam praktek pemeliharaan kesehatan ya, masyarakat Kalimantan Timur khususnya dan Indonesia pada umumnya. Baik, nampaknya di layar kita sudah ada Ibu Dr. Aminah Toha. Baik, Ibu, bagaimana kabarnya hari ini? Selamat bergabung Ibu Dr. Aminah Toha. Ya. Oh, suaranya belum terdengar. Baik, kami akan mengatasi masalah teknis. Apakah panitia? Ibu masih mute sepertinya. Mikrofonnya mungkin boleh diklik. Apakah suara saya terdengar, Ibu?
Oh ya?
Baik.
Ya, oke.
Baik, silakan Ibu, kami persilakan untuk memulai pemaparan tentang materi yang sangat bagus ini dan kami berikan waktu 30 menit. Silakan Ibu.
Baik, terima kasih Ibu Dr. Era. Thank you for Dr. Era. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Today we're exploring ini belum slide-nya ya? Bu Era, slide-nya sudah tampil belum?
Ibu sudah tampil, Bu.
Oke. Good afternoon, everyone. Today we are exploring the role of maternal care in preventing non-communicable disease or NCDs with insight from the Dayak Kenya community. My name is Dr. Aminah Toha, and I'll be guiding you through this discussion on maternal care's impact on health and community well-being. Sudah dipanitia? Sorry ya sebelumnya. Oke, baik. Next slide. Ya, bisa dilanjut slide-nya, Bu Era. Ya. Okay, introduction to maternal care. Let's begin by discussing what maternal care means and why it's so essential. maternal care provides a strong foundation for lifelong health, especially when healthy habits are formed during pregnancy and early childhood. Community engagement is also crucial as it helps spread these practices across families and generations. Now that we have a basic understanding of maternal care, let's broaden our view to consider the global challenge of the NCD. Next slide. Global NCD's challenge, as many of us know, non-communicable disease are a significant global health crisis. They are responsible for around 36% of death worldwide, with 17 million people lost each year. The economic impact is staggering, totally 38 trillion dollar cost. To understand the NCD problem better, let's look at the main risk factors contributing to this disease. Next slide. Next slide. Bisa dilanjut slide-nya, Bu? Okay. NCD risk factors. Here we can see some of the leading risk factors: high blood pressure, smoking, high blood sugar, and obesity are among the top risk factor driving this crisis. With this risk factor in mind, we can better appreciate the importance of maternal care in building lifelong healthy habits. Let's dive into that next. Non-communicable disease pose a significant global health burden. Visual representation can actively depict the impact of NCDs. Visual aids such as chart and diagram help to understand complex data and highlight the extent of the NCD problem. Next slide. Next slide, Bu. Okay. This visual representation cases the leading risk factor contributing to non-communicable disease. These factors include unhealthy diets, physical inactivity, tobacco use, and excessive alcohol consumption. Recognizing these factors helps us design effective strategies for preventing and managing NCDs. Next slide. Yeah. Importance of maternal care in public health. Maternal care creates the foundation for children's physical, mental, and emotional development by fostering healthy behaviors early, like balanced diets, regular activity, and stress management. We set up the next generation to be less vulnerable to NCDs. Now that we understand why maternal care is important, let's clarify our main objective for today's discussion. Lanjut. Next. Objective today will aim to explore the relationship between maternal care practice and NCD's prevalence, identify best practice, review as a case study on Dayak Kenya community, and propose policy recommendation for integrating maternal care into public health program. To meet this objective, we first need to define what we mean by maternal care. Let's look at the core concept. Next slide. Maternal care concept. Maternal care involves nurturing and educating children across physical, emotional, social, and cognitive areas. These practices are shaped by cultural, social, and economic context, which can strongly influence approaches to maternal and child health. Now that we understand this concept, let's examine how maternal care impacts health over a lifetime. Next. Maternal care's role in health. Maternal care support children's health by focusing on nutrition, physical activity, and emotional well-being, starting from pregnancy through early childhood. These practices build a strong foundation for health, helping prevent NCDs. Building on this, let's discuss some of the specific nurturing practice emphasis in maternal care. Lanjut. Next slide. Healthy nurturing practices. The Dayak Kenya community emphasize healthy dietary practices, physical activity, mental well-being, and health education, introducing balanced nutrition, encouraging active play, providing emotional support, and teaching disease prevention are central to their approach. Next, we look at how this principle put into practice within the Dayak Kenya community, beginning with their daily habits. Next slide. Next slide. Yeah. Dietary practices in the Dayak Kenya community. The Dayak Kenya mundur dulu Bu, slide-nya kembali ya. Dietary practice ya. Okay. The Dayak Kenya community primarily relies on locally sourced food, including rice, meat, fish, and vegetables. Tempe is a staple protein source, and leaf greens provide essential nutrients. Their diet showcases their independence in food production and adherence to traditional practices. In addition to diet, the Dayak Kenya community has other unique maternal care practices that support health. Let's explore those now. Lanjut Bu. Okay. Case study of Dayak Kenya maternal care practices. The Dayak Kenya community maternal care approach includes nature-based nutrition, traditional healing, and integrated physical activity, the social rituals and communal practices foster resilience, mental health, and strong sense of community. Beyond these specific practices, the Dayak Kenya also draws on local wisdom that promote a holistic view of health. Let's take a closer look. Lanjut, Bu. Next slide. Local wisdom in health. This community deeply understand the connection between human health and natural environment. The practice sustainable resource management, use medical plans, and uphold tradition that promotes ecological balance, their social solidarity, and spiritual belief support a holistic approach to mental, emotional, and physical well-being. Now that we have covered the practice, let's examine the positive health impact associated with them. Yeah, next. Positive health impacts due to their dietary habits, physical activity, and supportive social environment. The Dayak Kenya community enjoys numerous health benefits, including lower obesity and diabetes rates, strong cardiovascular health, a high sense of community, and strong immunity. In summary, the Dayak Kenya community offer valuable insights for broad public health efforts. Let's conclude. Next slide. Closing and thank you. Thank you for your attention. Inclusion. The Dayak Kenya community saw how maternal care practices emphasize balanced diets, physical activity, emotional support, and community can have a profound impact on health and help prevent NCDs. Their holistic approach provides valuable lessons for integrating maternal care into public health initiative. Thank you very much. Yeah.
Okay, thank you, Ibu Dr. Aminah, for your presentation. Ladies and gentlemen, respected colleagues, and also my lovely audiences. Kita masuk pada sesi berikutnya, yaitu sesi tanya jawab, question and answer session. So, we allow you to open your microphone and raise your hand to ask directly to Ibu Dr. Aminah Toha. Silakan kepada audiens, kami persilahkan.
Silakan, bisa berbahasa Indonesia.
Dalam bahasa Indonesia atau bahasa Inggris, Ibu?
Terserah, bahasa Indonesia juga boleh.
Baik. Apakah kita sudah ada pertanyaan? Baik, kita ada satu penanya Ibu nampaknya dari mahasiswa perawat atau calon perawat
Ya.
yang ingin mengetahui lebih lanjut tentang bagaimana budaya kesehatan yang dilakukan oleh masyarakat atau kultur ya Dayak Kenya di dalam mempertahankan kesehatannya. Apakah penanya sudah bisa masuk, sudah bisa join? Kami persilahkan. Baik, kami ingatkan bahwa topik yang sangat menarik dari Ibu Dr. Aminah Toha adalah tentang the role of maternal care. Jadi peran dari perawatan atau pelayanan kesehatan ibu di dalam pencegahan penyakit tidak menular atau PTM. Ya, disarikan dari atau pembelajaran dari praktek komunitas masyarakat Dayak Kenya. Ya, tentunya ini merupakan satu knowledge yang sangat baik yang harus kita rengkuh di dalam satu ilmu baru yang mungkin bermanfaat untuk dapat diterapkan di tempat lain. Jadi ada points of lesson yang dapat kita pelajari untuk dapat diterapkan di tempat yang berbeda, mungkin dengan kultur yang berbeda. Baik, apakah kita sudah ada penanya? Silakan.
Itu tadi pertanyaannya di room chat ya?
Iya. Silakan. Apakah ada?
Atau yang tadi dijawab dulu ya?
Boleh silakan Ibu, ada di room chat ya. Apakah ada di room chat? Oh, belum ada.
Oh ya. Ini ada
silakan,
yang
ada Aziza Giafani, silakan Aziza dibuka mikrofonnya.
Belum dibuka ini.
Silakan Aziza, silakan segera dibuka.
Ya, perkenalkan Ibu, saya Aziza Giafani Norsi dan pertanyaan saya, jelaskan praktik penyembuhan tradisional apa yang diimplementasikan dalam perawatan maternal di komunitas Dayak Kenya dan dampaknya terhadap kesehatan anak. Oke, terima kasih.
Perawatan ini ya, apa tadi? Perawatan dari Dayaknya ya. Oke, sebentar. Jadi ini sebenarnya apa yang saya sampaikan tadi Bu Era ya sudah menjelaskan bahwa mungkin dari praktik komunitas sebenarnya ini adalah hasil dari penelitian saya Bu Era waktu di suku Dayak Kenya ya, karena memang dulu disertasi saya itu terkait dengan pola pengasuhan maternal di suku Dayak Kenya dengan metode kualitatif mixed method ya. Nah, jadi temuan apa yang disampaikan ini sebenarnya memang hasil dari penelitian dan dikawinkan dengan angka-angka yang seperti, karena dulu dasarnya itu adalah kenapa kematian ibu di suku Dayak Kenya itu rendah bahkan tidak ada, dan sampai sekarang hasil laporan dari puskesmas itu ternyata juga kematian ibu tuh sampai sekarang 0 ya. Nah kemudian ibu hamil kek juga itu rendah, dan hasil laporan dari puskesmas juga 2022 dengan 2023 ternyata angka hipertensi dan DM itu hanya berkisar 2% ya, jadi lebih rendah dari beberapa kecamatan di Kutai Kartanegara. Oh ya, lokasi penelitian ini adalah di Kutai Kartanegara ya, khususnya dulu di Kecamatan Tabang yang memang dominan suku Dayak Kenya. Tadi pertanyaannya adalah praktek perawatan ya. Nah, yang dulu yang hasil dari penelitian itu yang saya dapatkan itu adalah kalau untuk perawatan karena ini kemarin memang di samping fokus sebenarnya lebih banyak di bagaimana pengasuhan makan ya atau gizinya, tapi saya juga mendapatkan bahwa kalau untuk perawatan yang ada di suku Dayak Kenya, tapi ini tidak terlalu mendalam sampai ke ini ya, hal-hal yang mungkin penyakit-penyakit yang lebih apa ya. Jadi ini seperti yang saya dapat hari itu, kalau perawatannya itu adalah kalau misalnya anak-anak demam. Ini tadi kan kaitannya dengan anak. Nah, di sana itu mereka punya obat namanya klien ya. Jadi suku Dayak itu ada obat demam yang berupa dari tanaman-tanaman. Jadi kalau anak-anaknya demam itu yang diberikan. Jadi tetapi ini sudah dulu kan hanya tanaman yang ditumbuk ya untuk nanti disimpan di misalnya di dahi gitu ya. Nah, tetapi itu sudah ada yang diolah karena diolah di ini khususnya di Apokayan di Kabupaten Malinau ya, karena asal dari suku Dayak Kenya yang di Kutai Kartanegara yang hari itu saya tempat penelitian itu dari Apokayan dan di Malinau, dan itu sudah dijadikan apa namanya seperti fresh care ya. Nah, jadi itu yang kalau untuk perawatan yang saya dapatkan di suku Dayak Kenya. Itu mungkin deh kalau untuk perawatan anak, dan itu tadi kalau anak-anak demam. Jadi hanya untuk bila anak-anak demam panas itu diberikan ramuan dari tanaman yang ada di dulu di Apokayan banyak, makanya bisa dijadikan fresh care yang diolah ya, jadi seperti fresh care. Kemudian di mana di khususnya di Ritan itu juga sudah ada tanamannya. Ya, itu mungkin deh kalau yang untuk perawatannya. Ya, ya, kasih ya.
Ya, itu pertanyaan yang cukup jelas saya rasa dari Ibu narasumber pada pertanyaan mengenai bagaimana praktek perawatan keluarga ya yang dilakukan oleh masyarakat Dayak Kenya. Mungkin Ibu pertanyaan lanjutan bisa ditunggu sebentar karena sepertinya ada pertanyaan selanjutnya. Apakah ada sudah? Dari panitia, apakah sudah ada pertanyaan untuk speaker kita, Ibu Dr. Aminah Toha? Ya Ibu, nampaknya ini sudah ada 2, tapi terlalu besar tulisannya, mungkin bisa diatur. Ya. Pertanyaan pertama. Bagaimana perubahan gaya hidup pada komunitas Dayak Kenya dapat mempengaruhi praktek parenting tradisional dan tingkat PTM, Ibu?
Ya, baik. Mungkin saya jawab dalam bahasa Indonesia, izin ya.
Silakan.
Ya, jadi ini tadi pertanyaannya adalah bagaimana perubahan ya dari pengobatan praktek pengasuhan ya dari suku Dayak Kenya. Jadi pengasuhan khususnya untuk ibu hamil sampai ke ibu menyusui sebenarnya di masyarakat suku Dayak Kenya itu karena tadi memang berangkat dari kenapa di suku Dayak Kenya itu khususnya di daerah Kecamatan Tabang yang puskesmas Piritan dan Tabang itu rendah, bahkan cenderung tidak ada ternyata mereka itu sangat melindungi ibu hamil ya. Uh, Artinya masyarakat Dayak itu sangat melindungi bukan hanya dari ibu hamilnya saja, tapi kalau kita tadi bicara bahwa memang ibu hamil itu kan kita di kesehatan sangat penting sekali untuk melahirkan nanti SDM yang berkualitas ya, bergizi. Nah, praktek pengasuhannya itu kalau di ibu hamil itu mulai dari misalnya kalau ibu hamil itu keluar itu harus pakai seraung. Seraung itu yang saya pikir kita semua kalau di Kalimantan sudah paham ya. Seraung supaya tidak kena hujan, kemudian tidak kena panas, kemudian dari anjuran-anjuran makan. Sebenarnya di slide saya tadi ada yang baru saya kirim itu sudah ada gambar-gambarnya. Jadi pengasuhan makan itu di sana menariknya adalah mereka itu mulai dari beras kan, beras itu beras ladang yang itu tidak ada pestisidanya, kemudian mereka ada konsumsi pakis. Kalau di sana itu ada paku julut namanya, paku danu, paku pahit. Itu kita kalau di bahasa Indonesia kan pakis ya. Nah, mereka itu ada beberapa jenis ya. Dan itu tumbuh subur di sekitar mereka. Itu ternyata hasil kandungan itu kan zat besinya tinggi ya. Makanya kenapa dulu ibu hamil di sana juga anemia rendah. Nah, di sana itu konsumsinya berupa sayur-sayuran hijau, kemudian mengolah makanan itu juga lebih banyak ke rebus ya, merebus, jarang sekali digoreng atau apalagi dengan santan. Kalaupun dan bumbunya pun itu menggunakan hanya bawang merah dan serai, dan tadi ada di slide saya terakhir itu ada daun, itu namanya daun mekei. Daun mekei ini adalah pengganti penyedap atau pengganti vitsin ya. Dan itu tanaman mekei itu adanya di Kalimantan dan di Sumatera yang setahu saya ya, waktu saya cari itu di mana saja sih ada ini. Jadi itu untuk nutrisinya ya. Jadi untuk pengasuhan makan ibu hamil itu seperti itu. Kemudian nanti pada saat dan ada satu lagi yang menarik, mereka itu ada persiapan kalau untuk melahirkan, ada tilung namanya. Tilung itu ranjang itu dengan posisi miring. Jadi kalau secara ilmiah kita kalau miring itu kan gravitasi ya. Jadi mereka itu ranjangnya miring. Jadi kalau kita gravitasi artinya kan akan membantu turun ya. Nah, jadi itu hal-hal yang mereka punya. Kemudian dari nanti setelah melahirkan itu mereka harus makan bubur banyak, kemudian konsumsi selama 40 hari itu yang harus dikonsumsi dalam waktu 40 hari bubur. Kemudian ada ayam peliwet namanya, itu ayam kampung yang harus dikonsumsi juga. Jadi itu hal-hal perlindungan untuk ibu hamilnya ya. Nah, kemudian selain itu tadi, mereka sebenarnya juga kenapa semakin kuat mereka punya kondisi kesehatan, tadi tidak ada kematian ibu, dan ini beberapa tahun yang terakhir ini bahkan saya dapat data dari Dinas Kesehatan itu di sana juga tidak ada kematian ibu, karena selain tadi memang masih menjaga budaya, itu juga mereka sudah terbuka dengan pelayanan kesehatan. Jadi penelitian saya dulu itu mixed method, memang kualitatif menggali budaya yang mereka punya, karena pertanyaannya adalah Kritan itu jauh dari kota, jauh dari rumah sakit, jauh dari pelayanan kesehatan. Kenapa? Di sana kondisi kesehatan ibu hamilnya lebih bagus. Ya, nah ternyata mereka tadi di samping tetap menjaga budaya itu, mereka juga sudah bisa menerima pelayanan kesehatan yang ada. Ya, jadi sudah terbuka dengan pelayanan yang ada seperti imunisasi, kemudian periksa kesehatan ibu hamil. Mereka sudah menerima hal-hal artinya hal-hal yang terkait dengan pelayanan kesehatan. Jadi seperti itu. Nah, yang memang ada hal yang bagus juga di sana karena di sana kan itu masih ada lembaga adat ya. Lembaga adat, ada pembinaan remaja di setiap ada jadwal ya, kalau nggak salah setiap malam Rabu atau malam Kamis itu remaja dikumpulkan, ada agenda mereka, itu bukan hanya dari tokoh agama yang masuk, tetapi juga dari kesehatan. Jadi mereka sudah ada pembinaan-pembinaan, bukan hanya kebaktian atau di tempat ibadah, tetapi ada khusus untuk pembinaan remaja untuk menjaga warga-warga mereka ya, supaya tadi kalau seperti di kesehatan itu termasuk materi kesehatan reproduksi itu sudah sudah diajarkan. Selanjutnya kalau dia juga punya pesta ya, namanya mecak kundat. Mecak kundat itu adalah pesta panen. Jadi setiap panen mereka berkumpul, semua RT harus datang berpakaian adat dan itu dirayakan, itu kebersamaan mereka. Itu menumbuk padi, makanya di slide itu saya ada foto ya pakai baju adat dan itu dengan di tengah pesta itu semua adalah bukan hanya artinya dari kesehatan ya, tetapi ada dukungan sosial yang bagus di sana, saling menjaga supaya memang warga suku Dayak Kenya itu selalu dalam kondisi sehat dan begitu juga terhadap sosial community-nya ya. Ya mungkin itu ya jawaban dari saya.
Baik, terima kasih Bu Dr. Aminah Toha atas jawabannya yang cukup clear, concise, and memberikan insightful kepada para audiens yang tentunya sangat menyadari bagaimana bahwa kesehatan itu sangat dipengaruhi oleh berbagai faktor. Ibu Dr. Aminah Toha baru saja menyampaikan bahwa kesehatan untuk mencapai kesehatan yang optimal, baik secara individual, secara kelompok maupun masyarakat, terdapat faktor-faktor lain, yaitu seperti budaya, sosial, dan dilengkapi dengan tadi pembicara kedua, Profesor Afzal Mahmud menyampaikan bahwa banyak sekali faktor yang mempengaruhi bagaimana kesehatan itu disampaikan atau diberikan oleh nakes hingga sampai ke maternal and child health. Demikian dari kami pertanyaan-pertanyaan untuk pembicara ketiga yang kita hormati dan kita banggakan, Ibu Dr. Aminah Toha, Magister Kesehatan. Sebagai bentuk penghargaan, salah satunya kami menyampaikan Ibu bahwa ini ada sertifikat pembicara untuk Ibu Dr. Aminah Toha, Magister Kesehatan. Mohon diterima sebagai tanda terima kasih kami.
Ya, terima kasih Bu Hera. Ya.
Terima kasih Bu Aminah. Baik,
Ya,
nampaknya kita sudah melewati atau kita sudah mendengarkan 4 pembicara, 4 speaker for this event, and it would likely to me to end our meeting with me as your moderator, dan saya akan menyerahkan kembali kepada Master of Ceremony yang saya sayangi, Hera Hedona. Silakan Hera.
Yes, thank you so much to Dr. Era for moderating our first session of panel presentation today. Right? The second session of panel presentation today are by Miss Melanie T. Reboldera, Registered Nurse, Doctor of Nursing Science from Philippines. Mr. Hengki Isahwan Ahmad Mulya Dilay, PhD from Malaysia. Dr. Nursari Abdul Syukur, Bachelor of Applied Science, Master of Midwife from Indonesia. And now, let us welcome our moderator, Mr. Abdul Kholik Subairi, Master of Education. To Mr. Holik, the time is yours. Welcome, Mr. Holik.
Hello.
Yes,
Thank you very much for time given to me. Then it is very nice to have this seminar.
Yes.
Okay. Thank you. I think that I'm going to lead this conference as the moderator.
Yes, thank you so much, sir.
Okay.
The time is yours.
All right. Thank you very much. Thank you very much, and good afternoon. Good afternoon, everyone, and good afternoon, ladies and gentlemen. I would say thank you very much for joining this international conference, and then welcome back to our next session, second session for this seminar. Then in this seminar, we are going to have three reviewers or three presenters, and let's get into the first presenter of the second session. It's going to be Miss Melanie. So Miss Melanie, are you here already? Hello, Miss Melanie.
Assalamualaikum, Mr. Yes, sir, I'm here already, Mr. Abdul.
Okay, right. So how are you today?
I'm good, alhamdulillah.
Alhamdulillah, right. Okay. It seems that it's going to be interesting materials that you are going to be presented, yeah? Okay. I think that for the next sessions, it's going to be your time to present these materials. Time is yours. The floor is yours. Thank you.
Okay, thank you so much, Mr. Abdul, sir. So
Good
first of
afternoon.
all, give me a minute to share my presentation. I hope you can see. Is it visible? Is it okay now?
Yes.
Yes, okay. So first of all, I would like to thank Poltekkes Kalimantan Timur for giving me the opportunity to share with you on this conference. The title of my talk is Program Implementation to Prevent NCDs in the Community. For the objective, of course, I'll be discussing a program implementation as strategy in prevention and management of non-communicable diseases. And I'll be talking with the global burden of NCDs, a little bit of HCD, responses to NCDs, and program implementation as a response. So for the burden, NCD kill 41 million people each year, and that is 74% of all deaths globally. And from this 41 million, there's 17 million who dies from NCD before age 70, and which is actually concentrated in low and middle income countries. So additionally, cardiovascular diseases account for most NCD deaths, followed by cancer. We have the chronic respiratory disease and diabetes, including the kidney disease as a complication of diabetes. So these four group of diseases account for over 80% of all premature NCD deaths. And I'm very sure that the other presenters a while ago, the other doctors a while ago, gave you a very specific burden also or overview of NCD. So how about here in the Philippines? In the Philippines, the NCD is also a major public health challenge. There are 5 leading causes of death, including the ischemic heart disease, neoplasms, the cerebrovascular disease, DM, and hypertensive diseases. And the Philippines leads Southeast Asia with the highest number of deaths caused by kidney disease. So really, as you can see from all these percentages, we can say that NCD is really troublesome and burdensome, not only to the people, but also to the economy of each country. So our NCDs, we have actually these NCDs. I'm not going to talk more about this one. Okay, because we know this already, and these are actually the chronic diseases as we know it. People at risk, everybody is already at risk in terms of non-communicable diseases. But there's really an increase now in the number of children who have NCDs. So we have to focus on this one as well. For the risk factors, I'm sure you know this also. So the modifiable behavioral risk factors, we have unhealthy diet, sedentary lifestyle, then others, and you have your metabolic risk factors, increase in blood pressure, and others, also the environmental risk factors. So air pollution, now that is one of the things that we have to consider also, because this could contribute into respiratory disorders, okay? The chronic respiratory disorder. Now, let's focus on how are we going to prevent the non-communicable diseases. In 2013, the World Health Organization actually developed this global action plan, and the vision is to have a world free of avoidable burden of non-communicable diseases. So the idea is no one will have these non-communicable diseases. So how are we going to do that? For the objectives of this plan, to raise the priority accorded to prevention and control of non-communicable diseases. So prevention, we have to prevent before there is occurrence or diagnosis of non-communicable diseases. And it should be in global, regional, and national agenda. So if this is the World Health Organization, it is expected that the other countries should also join in the fight for a fight against these non-communicable diseases. Then next, strengthen national capacity, okay? The ability of the nations or different countries to fight against NCDs, prevent and control the non-communicable diseases. Leadership and governance, this is very important. Okay. Multi-sectoral action, so it's not only the government or the healthcare that should be fighting against non-communicable diseases, but all sectors in the society. So if we have a high prevalence of non-communicable disease, what happens is we are also the cost or the burden to our economy is also very high, because the management of non-communicable diseases is very costly. It's very expensive. So there should be a multi-sectoral action. Next, to reduce modifiable risk factors for non-communicable diseases. This is where we can actually contribute in the prevention and control of these non-communicable diseases. So when we say modifiable risk factors, these are the risk factors that can be changed. So meaning we can do something about these modifiable risk factors. Then to strengthen and orient health systems to address the prevention and control of non-communicable diseases and the underlying social determinants through people-centered primary health care and universal health coverage. So in one of the papers done by World Health Organization, the World Health Organization is actually telling us that primary health care has a very important role towards the prevention and management of our NCDs. Why? Because primary health care is actually in the barangay. So it's with the community, it's with the people. So primary health care is the first, okay, it's the first institution where those sick people, okay, can go for management, and also primary health care has a very important role in terms of the health promotion and later on the prevention of these NCDs. To promote and support national capacity for high-level research and development for prevention and control of non-communicable diseases. So we're talking, or the WHO is talking about high-quality research. So what are the areas of researches for NCDs? So number one could be the screening. Okay, so through our research, we will be able to develop screening tools or devise other screening tools for NCDs. Also, we can do a research in the disease mechanism or on the management of these non-communicable diseases, to monitor the trends and determinants of non-communicable diseases and evaluate progress in their prevention and control. Okay, so those are the objectives of the paper which was circulated by the action plan circulated by the World Health Organization year 2013. And this paper is actually extended now until 2030. It's not only until 2020 anymore, but it's already extended until 2030. So in summary, we have these things under the Global Action Plan: strengthening national capacity and governance, reducing major risk factors, developing and implementing effective legal frameworks. Okay, so our laws should support these programs towards the non-communicable diseases. Orienting health systems towards people-centered care. So the focus should be the people, the universal health coverage. Everybody has the right towards healthcare. Then promoting high-quality research and development. So if we have a global action plan and all the countries are enjoined to do something towards the non-communicable diseases, the Philippines is also one of the countries that implemented a program to prevent and control or manage the non-communicable diseases. So the program in the Philippines is known as the lifestyle-related diseases, and this was established through the Administrative Order 2011-0003, National Policy on Strengthening the Prevention and Control of Chronic Lifestyle-Related Non-Communicable Diseases. So this is implemented and being supervised by the Department of Health here in the Philippines. So there are actually 4 components of the program. Number one, we have the cardiovascular diseases, the diabetes mellitus, cancer, chronic respiratory diseases. And we have 1, 2, 3, 4, 5, 6 policies and laws supporting the implementation of this lifestyle program. So since 2011, the establishment of this program. Then there's another one, AO number 2012-0029. Another one for 2013, that's 005. Then 2015, 0052. 2016, 0001. And we have the last policy and law, which is Administrative Order 0014. So what are the program accomplishments of the lifestyle program by the Department of Health here in the Philippines? They were able to finalize the Philippine Multi-Sectoral Strategic Plan for the Prevention and Control of NCDs, and this is applicable for 2017 to 2025. So again, the key word there is actually multi-sectoral strategic plan. It's not only the healthcare system, okay, that will support or do something on these non-communicable diseases, but the other sectors of the society should also be involved. And the Philippine Package of Essential NCD Intervention for the Integrated Management of Hypertension and Diabetes is being implemented nationwide. So there are two targets here, the hypertension and diabetes. It's a whole package on how they are going to control or manage the hypertension and diabetes. Also, there's a training on diabetes management using insulin for regional offices and LGUs or the local government unit. So here in the Philippines, every region, there's a training, and from that region, it will go down towards the LGUs. So the LGUs, we call it, we have the district hospitals here and the municipal health offices. They have also training related to this diabetes management. Now, specifically the use of insulin. Another accomplishment for this one is the provision of NCD drugs through the medicine access programs, then training on cervical cancer. So now there's also the third NCD, which is the cervical cancer. So using visual inspection, using acetic acid among healthcare workers. And I believe there's also other things that are now being done towards this cervical cancer screening. Okay. NCD indicators are integrated in existing DOH current performance reporting system like Field Health Service Information System and the local government unit scorecard. So in the conference, I was listening a while ago, and they are talking about integration. So this is also one thing that the program is doing here in the Philippines. Then, next one, the DOH support for proposed legislative bills focusing on addressing the harmful effects of alcohol consumption, integrating palliative and hospice care into the healthcare system. So, why alcohol consumption? So, because alcohol consumption is one of the modifiable factors, one of the things where we can do something so that we can prevent the increase in the number of NCDs in our community. So integrating palliative and hospice care. Why? Because mostly the chronic diseases, as we call it, our NCDs are actually related to our elderlies or older adults. So that's the response of the Philippines towards the prevention and management of the non-communicable diseases. Now, we are talking about multi-sectoral management and prevention of NCDs a while ago. So I think I thought of including this in my presentation because, as I mentioned, it's not only the healthcare that should focus on this one. It's not only even the government that should focus on this one, but as part of the totality, the academe should also be aligning our projects towards the prevention and management. So I'm talking about management because we have also the role to manage these diseases. We don't only prevent, and program is not only towards prevention, but also management of our NCDs. So this project is a student project. A group of our student nurses actually did this project in their community. So if we are going to start a project, okay, because since we are in the academe, specifically in the nursing, so we have this related learning experience, as we call it. So we have the duty and we have this community duty. Okay, so as I was saying, this EWAS Double Trouble is actually a project, okay, one of the projects inside a big program in our community. So if I'm not mistaken, there are 10 projects, okay, and I only chose one to really show also that projects can help. A project is a part of a program. It's a big program. So this program or projects could really help in the prevention and control of our non-communicable diseases. So the title of this project is Iwas Double Trouble, Alta-Presyon and Type 2 Diabetes. Agapan, halina't ating simulan. So roughly, this is translated as prevent double in English also, and then trouble. So trouble in English also, that's problem. So prevent double trouble. Alta presyon is hypertension. Then diabetes, of course, diabetes. Agapan, halina't ating simulan. So manage, prevent, let's start. So that's the rough translation of the title of this project. So what's the focus of this project? Comprehensive training and skills enhancement of core group. So when we say core group, these are community people, okay, and could be the barangay health workers, but usually these are the community people who have the potential to help the barangay health workers. Okay, collaboration of student nurses and the local residents. So there was a partnership between the barangay and LGU officials. Okay, so this is also in relation to the allocation of the funds because they need funds to get some blood pressure apparatus or to buy blood pressure apparatus and glucometer kits. So what's the aim? Raise awareness about these health issues and promote the prevention and management of these health conditions, meaning the hypertension and diabetes within the community. So that's the project, okay? One of the projects inside a big program of our students. So there's actually two parts here. We have the planning phase and we have the implementation phase. For the planning, there was a tasking and ocular survey. So they have to assess the community, and then after that, they selected some people who call it core group members. Then these core group members will later on be having a training on how to get blood pressure and others. So orientation on the different duties and responsibilities of the core group members. For the implementation phase, they started with the provision of training. So first, they demonstrated how to get blood pressure and how to get the blood sugar. Okay, but later on, the core group members also started. They practice in getting blood pressure, okay, and also how to get blood sugar. So for this one, they empower both core group members and community residents through education. So aside from the training of this core group, there's also health education of the community people. So we have already mentioned about education. Education is a very good component, okay, in the prevention of our NCDs, skill building and access to resources. So here, this is actually a picture of the activities that the student nurses done. In the upper section, they trained them how to use laptops, because in the near future, there is a plan to use a computer already in the documentation of the vital signs and monitoring of these people in the community. So another one, the next picture below this picture is the practice for taking the blood pressure. And of course, aside from that, there's also the documentation. Okay, so how they are going to document those vital signs, blood pressure, and of course the blood sugar of the patients or the community people. So there's series of training. Then, of course, aside from the practice for taking blood pressure, there's also a practice demonstration and written demonstration on how to get the blood glucose using, of course, the glucometer. And if you're going to look into this particular picture in the right side lower section, they have this booth. So this booth was developed as a site for health education about hypertension and diabetes. So initially, the core group were also trained on how to do the flip charts or the IEC materials, and then later on they were trained on how to do the health education. So this particular place or booth is for that purpose. Okay, so what happened? So what are the results? So let's see if it's effective, if the program is actually effective. So became proficient in using both blood pressure apparatus and glucometer. So now the core group are very good. They know how to use the BP apparatus and glucometer already. And we all know that these two is a must in monitoring those who are maybe pre-diabetes or pre-hypertensive, or even those who have diabetes and hypertensive. So there's an additional 5 BP apparatus set and 4 glucometer set for the use of the core group. And this is in partnership with the local government unit and the barangay. So the government, the governance. So there's already three partners here. The university, of course, then the government, and of course, the BHWs, they are also participating. The community people, okay, the PHC. So utilize logbooks for regular monitoring. They are now using a logbook, but as I mentioned a while ago, hopefully, inshallah, later on, they will be able to have computers so that they can already computerize these documents in the future. Now, they are also capable of conducting health education sessions. So, for our primary prevention, health education using flip charts. So, they are trained how to do this. Okay? Then uh, we cannot stop emphasizing saying that health education is very important towards non-communicable diseases. It's really a must. Okay? Then regular health monitoring sessions were organized. So it's not only an initial checking of the vital signs of these patients or of these clients, but they are now doing regular monitoring sessions. So these are the other pictures. So as you can see on this one, they are writing already using the logbook, documenting the vital signs, the BP, and of course the blood sugar. Okay, now on this particular picture, she's the one who is taking the blood sugar already of one of the community people. And of course, there is a graduation or celebration after all those training and practice that they did. So they also did a turnover of this booth to the core group so that the core group can use this one during their health education for those who have hypertension and diabetes. And also, it's not only for those who have hypertension and diabetes, but to the people as general. Because also, this one is very important for the prevention. Okay? So, this is the flip chart or the IEC materials that they use. It is translated in Tagalog, okay, our national language in Filipino, so that the community people can really understand what they are saying. And for the audience, if ever they are going to use this in health education. So another one, the diabetes IEC material as well. Okay. So I believe this particular project, though it is in just one barangay, is very important. Okay, it's not a big program as the program that was started by the Department of Health. However, since they are focusing on the community, I think this is also very important because our community people should know all these things so that there will be effective prevention and management of these non-communicable diseases. So for my conclusion, if we have program, very good program that are really crafted, okay, if you have a good plan of a particular program, then implement it thoroughly, okay, and this will help in the prevention and management of our NCDs. So I guess that's all for me. Terima kasih. Thank you so much. Shukran. I think it's now time for questions, Mr. Abdul.
Thank you very much for your presentation. I think that this is very insightful presentation. I'm sure that our audience right now, they have learned a lot from you today. Okay, so I think that for the next session, it's going to be question and answer sessions. Then I think audience will ask questions. Please raise your hand, please. Please, audience, if you have some question for Miss from Miss Melanie, yeah, okay.
Okay, so I think these are the questions for me, sir.
Yeah, there are some questions from the audience. It is categorized by the committee. Okay, please, ma'am, you can answer these questions.
Yeah. Okay, so thank you so much for these interesting questions. I will try my best. So what are the primary challenges in raising public awareness about the importance of preventing non-communicable diseases? So number one, I think, is the accessibility. Okay, accessibility. Here in the Philippines, in Indonesia, it's also archipelago, if I'm not mistaken. So there's a collection of different islands and islets. So sometimes it's difficult for the community people to go from one place to another to have information related to this one. And also, not all parts of the Philippines have, there's electricity, yes, but the internet connection is also one of the questions here. Though there's already a plan to increase or to improve the internet connection, because we can say that maybe they can just download or switch the internet, right? However, it's also a problem in other areas. So the accessibility, and also not many nurses or healthcare providers are available for the community. So we lack also nurses, barangay healthcare workers in the community. So that's why it's difficult sometimes to increase the public awareness. If you are only one nurse or one healthcare provider having duty in the community, and the community you're covering is how many thousands, and that will be a problem. So number one, less healthcare workers. We really have less healthcare workers, not only nurses, but barangay healthcare workers. Another one will be the accessibility, because when we are an archipelago, it's hard for them to go to the barangay health stations or primary health care. So transportation problems, that's also included in that one. Okay, so I believe those things.
Okay, right. So you have already answered the question from the audience. You have answered that very clearly. Thank you very much.
Thank you, sir.
More questions?
There's another one, the second one.
Okay. Maybe someone can raise your hand for the next question, please.
Sir Abdul, I think there's another one in the slide. I'm not sure if it's the same question.
Okay, committee, please display the questions. Okay, so question number 2, Ms. Melanie. Okay, so what are the efforts to reduce the main risk factors for NCDs? Maybe the effort that is maybe smoking, alcoholic consumption, lack of physical activities. Maybe that you can mention some of the what we call what's to do to reduce the main risk of NCDs. So it means that to prevent the NCDs.
Yeah. So thank you so much, Mr. Abdu. Sorry, there's no current here for a while. As I was saying, when you say reduce the main risk factors for NCD, number one, I think, is still the health education. So health education about the smoking, what is the impact of smoking towards the health of the people. Then we have also the same for all: smoking, alcohol consumption, and lack of physical exercise. So the impact of smoking and alcohol exercise, and also promotion of our physical activity, promotion of physical activity. And we have to focus on the benefits of this physical activity. That's number one, health education. Another one is since there's already many children who have NCDs, there should be integration of health promotion activities even in the school, in curriculum. Okay, so we have to consider also the school, because now our children, and also even the adolescents, because smoking and alcohol consumption starts during adolescence. So they should be very much aware of these things, and the school can start that one. But of course, from the side of the healthcare, they should also do something. So what else? Maybe they can schedule also regular, I believe now there is, here in the Philippines, we have a calendar, okay? Every month, there's a focus agenda for health promotion, health education activities. And part of that are the NCDs, smoking, alcohol consumption, and there's also physical activity. And even the malls, okay, multi-sectoral, I'm talking about multi-sectoral already. So still, health education, I think, is good. With the combined efforts of the different sectors of the community, government. What's happening in the Philippines is the government already increased the cost of cigarettes and alcohol. There's also ban. So not only the healthcare, not only the academe, we are in academe, but also the government. Okay, so I think all those should be done by all these people to reduce the risk of our NCDs. I
Okay.
think that's my answer,
Thank you.
Sir
Thank you very much.
Abdi.
So it means that it has a lot of efforts to prevent the NCDs and the management. So it must be collaborations.
Collaboration.
Yeah, is that
So
what
that
you
there is
meant?
support.
Yep.
Mhm.
All right then. Okay. I think for these questions already been answered by Miss Melanie. All right. Right now it comes to an end of our presentation. Thank you very much, Miss Melanie. Thank you very much for your kindness joining this international conference that we hold in this campus. Then to as our appreciation to your being keynote speaker in this seminar, we will hand over an electric certificate. So this is the electric certificate for you. Thank you very much for joining us in this conference. We hope that in the next coming, maybe next year conference, that you can also join to our annually international conference. Thank you very much, Miss Melanie.
Thank you so much, Mr. Abdul, sir, and also to Poltekkes Kalimantan Timur. It's my first time to be joining your conference. I'm very happy. Yeah, inshallah, next time we will still have a very good cooperation with my university, St. Paul University, Philippines. Shukran, terima kasih. Salamat.
Waalaikumsalam. Right. Thank you very much, Miss Melanie. For the next coming speaker, it's going to be from Malaysia. It's going to be, the keynote speaker will be Mr. Hengki Isahwan Ahmad Mulyadilai, PhD. Are you already in the Zoom, Mr. Hengki? So Mr. Hengki here, he is a master in degree in health science, and he is also as a bachelor's degree in medical laboratory science.
Seringnya kita melihat masa depan kejauhan, padahal masa depan itu ada di depan mata kita. Inovasi yang terdepan, tercepat, meninggalkan yang lainnya. Inovasi itu ada di HP kamu, di aplikasi kami. Livin by Mandiri, inovasi Beyond Super App, yang mengedepankan semua kebutuhanmu. Dari kebutuhan transaksi harian, hingga hunian. Bersama ratusan fitur inovatif, buat kamu santai menjelajah kemana saja. Inovasi tinggal tap-tap kami, memudahkan perjalanan tanpa batasan. Dan saat akhirnya menemukan barang yang kamu inginkan, bayar dengan praktis. Meski terpisah jarak dan waktu, inovasi solusi pasti valuta asing kami menjauhkanmu dari rasa asing saat transaksi pakai mata uang asing. Dalam satu aplikasi, kami mudahkan langkahmu berinvestasi. Livin by Mandiri menjadi yang pertama membantumu mencari rumah sesuai impian tanpa harus keluar rumah, hanya dengan selangkah menuju rumah. Dan impianmu akan terwujud untuk bangun jadi rumah yang kamu mau. Lebih dari transaksi harian hingga hunian, inovasi Beyond Banking kami menghadirkan hiburan hingga lifestyle untuk menjauhkanmu dari rasa jenuh dan bosan. Bahkan membawamu merasakan pengalaman lebih menyenangkan. Kami berinovasi lebih jauh. Jauh menghargai semua yang kamu lakukan. Hargai lebih, mengembalikannya dalam bentuk yang berharga. Livin Beyond Super App, inovasinya tak hanya sampai di sini. Kami terus berinovasi dan memberikan pengalaman baru perbankan masa depan yang lebih jauh lagi. Temukan masa depan perbankanmu di Livin by Mandiri Beyond Super App. Seringnya kita melihat masa depan kejauhan, padahal masa depan itu
Okay, our next agenda is a presentation from our keynote speaker. That's Mr. Hengki Isahwan. Mr. Hengki Isahwan Ahmad Mulyadilai, PhD. Hello. Good afternoon, sir.
Hello, very good.
Hi.
Hi.
Then it's very nice to meet you.
Yep, very nice.
Yeah,
Thanks so much.
welcome to our international conference. Here we are. Mr. Hengki is a master degree in health science, and then he is also a bachelor degree in medical laboratory science. Yeah, great being with you here in our conference. Then your titles today is the role of organized and 3D cell culture models in understanding non-communicable diseases. All right. Now it is time for you to present your material. Time is yours. Please, it would be maybe that you can present in about 30 minutes. Yeah. So after that, we are going to continue with our question and answer session. Okay, time is yours.
Okay.
Please. Okay.
Okay, sure. Thank you so much. So let me share my screen first. Is everyone can see my screen?
Yes, sir.
Okay, thank you so much. So very good afternoon, everyone. So first of all, Assalamualaikum and a very good afternoon to everyone. So it's a privilege for me to be here to address to the audience basically at the fourth East of the Borneo Health International Conference. We call it as a EBHIC, let's say, not mistake with the short forms. And also in conjunction with the international conference with the lactation management as well. So let me begin by expressing my deepest gratitude to the MH Supriyadi and the organizing committee as well for inviting me as a speaker for today's subject, whereby I deeply passionate about this topic. We call it as a 3D organoid as well. So back then, we are trying to use this 3D organoid. Okay, a little story about that. Okay, I'm using this 3D organoid back then in my study as well when I'm doing my PhD. So I'm focusing on the stem cell. So when we already have a stem cell, so we try to find out what actually we can do with a stem cell. So then come up with another new tools, we call it as a 3D organoid. Okay, so basically we have 2D stem cell. People always do it for the cancer studies. And then we are trying to find out what actually is new with the world of the biomedical. Right? So we come up with a 3D organoid whereby we can use it, and later on we will see what is actually is 3D organoid. Okay, for those people who haven't go through what is 3D organoid, so it's a good time for us to learn about what is 3D organoid. So I'm going to share a little bit regarding to these topics. Okay, and then today I'm going to look at the modern medicine as well, whereby we are particularly trying to look on how can we utilize these organoids on the non-communicable disease. For example, we call it as NCD, okay? And also partly we want to combine with the regenerative medication as well, therapies, especially when we are talking about precision medicines. Now, a lot of people is talking, heading towards the precision medicine. So before you want to have a precise precision medicine, so what is a tool? So we can use the organoid, okay? Basically what I can say is that when I'm working with these organoids, I already have 8 years of experience working with this organoid. Basically, is some things that we can do examinations on the organoids, and we also can use this organoid as a therapeutic as well. So that is the beauty of using this organoid as a studies model. Okay, so a little bit backgrounds about myself. So just now, I think the MC already mentions that I'm more focusing on my bachelor's, studying for bachelor, master. I'm focusing more on biomedical and medical laboratories as well, because my background back then is medical laboratories. So then I try to invent into the biomedical. I'm focusing more on the infection disease. So then when I pursue my PhD in Taiwan, I'm focusing more on the stem cell biology as well, correlated with nanomedicines and the studies of the pharmacology as well. Okay, so my area of expertise, I basically focus more on the stem cell usage and nanomedicines, and even the precision medicine as well, including trying the NGS as well. So that is the modern fields that we are having currently, that we are trying to head towards by using the biomedical field. So this is the overview that I'm going through later on, okay, throughout the whole presentations. Wait. Okay. I need to check, okay. So basically, wait, let me check my slide first. Okay. So I'm going to talk about the first points whereby we are looking at what is non-communicable disease, and I believe that previous speaker have already mentioned a lot regarding to the non-communication disease, whereby they already give the overview on non-communication disease as well. So I just want to give a very brief introductions on what is NCDs. So we know that this NCD basically they provide some of the key characteristics that we can say, we call it as NCD, non-communicable disease, whereby we can look at the key characteristic. The first one, I always look at the lifestyle of the individual, because we know that non-communicable disease, they are not acute, but basically they are more towards the chronic disease, whereby it's a prolongs. Okay, so unlike we always talk about the communicable disease, infection disease, whereby because you get contact with the bacteria or the viruses, but NCD, that's why the keywords that I'm using is a long periods. Okay, they are influenced basically by combinations, a lot of things. It can be either by the genetic or the behavior of your lifestyle as well. And More commonly also people saying because of the environmental factor as well, the one that can cause to non-communicable disease. So over here, I would like to highlight 4 different types of the key characteristic when we talk about non-communicable disease. For example, the first one, always we talk about the lifestyle. Okay, so one of the primary factors that driving this prevalence on the NCD is because of the our habits or lifestyle as well. Okay, for example, like poor dietaries, okay, and then lack of the physical activity as well, and also use of tobacco, like smokers. Okay, so this can increase the risk because now it's already a lot of paper study have been conducted that saying that because of the tobacco or alcohol significantly will increase the risk of the condition, for example, like diabetics, cardiovascular disease, and some of the chronic respiratory disease as well. And if let's say we're looking at non-transmissible disease, okay, the second key factors, basically, as I say, unlike infection disease, but infection disease, we know the causes because of the bacteria or the virus that cause, but NCD, usually it's not contagious. What does it mean not contagious? It's because they are individually, okay? Instead, they are always result from a long-term exposure because you're having a long-term exposure to the risk factors. For example, like just now I mentioned about unhealthy behavior or some of the environmental causes as well. With the long exposure, so they tends to get that particular disease, okay? So currently also we are trying to work out with the public health as well because we want to know if let's say this challenge can be tackled by using vaccinations or antibiotic as well, right? And then the second things that we are the third one is the chronic in the nature, okay, regarding to this NCD, because as I mentioned, NCD usually develops slowly. That's why we call it as a chronic, right? But then they are persist over a long periods of time as well. Frequently, they require a lifelong management. Okay, unlike bacterial infections, I just gave you a treatment by antibiotics, and then tada, the other day the patient is healthy. But for NCD, it's different. You always need to change your lifestyle. Then you have to get the lifelong commitments of the particular medication as well. So that is problems with the NCD. Okay, for example, conditions like Alzheimer. Okay, Alzheimer, or maybe people having chronic obstructive pulmonary disease, COPD. So they are slow progressions, and then it's very challenges for the treatment as well. Okay, and then last but not least, we are looking at the impacts of the across the age group as well. So we always know that NCD associated with the aging populations. When we talk about NCD, eventually we know that people who are getting older, they tend to get a particular disease like heart disease, right? That's why they are impact across the age of the group. So the impact also seems likely if let's say you're looking at the trends, okay, if let's say we do a trend studies currently, it also increase among the younger demographic as well. Back then, we always say that older people would tend to get cardiovascular disease, but current paper also showing that people
Recording in progress.
before age of 30, they were started to have cardiovascular disease as well. Why? As I mentioned just now, because of the lifestyle changes as well. Okay, because of the current lifestyle that we're having, and then the urbanizations that we are living, okay, the style that we're having, and the environmental factors as well. So these a little bits of the lifestyle, a little bits of these urbanizations, and a little bits of the environmental factors, they can contribute to make the agings at a younger stage already started to have this NCD as well, right? So, for example, I think currently also we know that childhood obesity. So we do know that childhood obesity also, they can likely to have this early onset diabetics and hypertension as well when they're getting adult age, right? So we know that this can contribute towards, mainly it's because of the lifestyle. That's why the example of the NCDs that we can look over here, I think in Malaysia we have a lot of
Recording
these cases.
stopped.
Diabetics. So diabetic basically is very high issues that we are trying to tackle as well in Malaysia. So we know that diabetic basically is a metabolic disorder whereby they characterized by a high blood sugar level. So basically this one is like we always talk about the obesity, or the physical activity as well. Okay, and then we talk about the second disease, most famous, what we call as a high mobility as well, cardiovascular disease. So this, for example, like heart attack or stroke and hypertension as well. So they quite collectively account for the large share amounts of the NCDs related mortality and causes death as well, right? So when okay, this disease, another one is like, for example, like Alzheimer, okay, or dementia. Usually this one is more towards what we call as this one is a real aging factors, okay, cause disease. For example, like impair of the memory or the cognitive function as well. So this one is more towards the aging populations, okay. Another one, we can look at the inherited factors. Okay, for example, inherited factors, we have COPD as well and cancer as well. Okay, this one more related towards the genetic factors and environmental factors as well. So that's why you can see each of the disease, it can be divided. Either it's a lifestyle, or is it because of the populations, or is it because of the genetic factors. So but some of the disease whereby they become progress more earlier is because of the inherited combined with environment, combined with the lifestyle as well. So they tends to get more faster in this particular disease as well, right? So for example, like cancer, we do know that cancers a multifactorial disease whereby they causes by abnormal cell growth. So usually it can be influenced a lot of things, as I mentioned. If let's say their parents having the genetic factors, so they will tend to get the genetic and then towards the offspring, that's been towards the children as well. Okay, so we can see this is a few factors of the disease that influence the numbers of the NCDs that we're having as well worldwide. So when we talk about the worldwide number, so we look at the statistic, what is the global impact. So why it became issue is that we do know that this NCD, basically they become a burden as well, okay, on the global health, and they also demonstrate some of the focus for us to having a prevention and treatment as well. So we can see over here in this graph pie charts that you can see the highest numbers of the prevalence is cardiovascular disease, right? So again, cardiovascular disease, they are include some of the things that we call as the heart diseases and even the stroke as well. So factors, we know a lot of factors, high blood pressures, okay, and then the poor diet, lack of the physical activity as well. So this is the mainly causes as well. Again, lifestyle and inheritance and environmental factor as well. Some of the people having tobacco, okay, maybe due to the secondhand smoke as well. So it's massive. Basically, they share the underscore of the urgence for the preventive measurement as well for the public health. That's why the main concern of the public health currently is more towards the cardiovascular disease as well. Okay, and then we also talk about the second higher prevalence that we can see over here is 23% accounted by the cancer. So cancer basically we do raising a prevalence because of the lifestyle, okay, related to the cancer. For example, those are smoker or obesity as well. So we are trying to amplify this target research and personalized treatment as well. So that's why I was saying that cancer currently is a hot topic by using the organoid to do treatments and also partly to do experiments on the medication as well. Okay, so we can see the next one is like respiratory diseases. They accounted almost like 10% out of the disease. For example, like environmental factors and inherited factors, asthma disease, right? And then we also can talk about the diabetics, followed by diabetics. We do know that this is because of the lifestyle changes as well, the one that can lead towards the high numbers of the glucose. So following, what is the challenge that we're having? Okay, as I mentioned just now, we already have the particular disease. We're talking about the NCD. So what are the challenges that we are facing now? As a biomedical field, we do meet some of the challenge. For example, like we have a limitations of the animal model. And then we also have the challenge between the need of using a human specific model. Okay, some study they have animal model, right? Okay, we can induce the diabetic towards the animal model. And we also can induce some of the diseases in the mice model as well. But every time when we induce the particular diseases, to the animal, we're having a problems with the drugs. Okay, the reasons why is because the animals and the humans having a different kind of like we're having a different types of genetics factors as well. So that is the reasons why we need to have a more human specific model. Okay, so this is a challenge that we are facing currently. So for example, like as I mentioned just now, the first note is about the limitations of the animal model. So when we talk about the limitations of the animal model, these are reasons why we have an alternative approach. What is the alternative approach that we can have by using the organoid, for example? Okay, so up to now, I cannot deny that the animal model, for example, like the mice, the rat, they are the cornerstone of the preclinical research for almost a decade. Okay, they provide some of the valuable insight into the basic biological process and also have been the instrumental in developing some of the therapies. However, okay, this model, for example, like animal model, basically they do have a significant limitation as well. Okay, whereby they can impact towards the reliability of the test and then the translations of the test as well. Over here, what I mean translation is that usually when we are trying to do a clinical trial, we translate the particular medication as well. Okay, so we are moving from the in vitro towards the in vivo model. So over here, the key limitations, I have listed down almost 4 of these. The first one we can look is the physiological and the genetic differences. As I mentioned, the anatomy, the metabolics, and the immune response of the animal is significantly different than the humans, right? So, for example, if let's say we're looking at the mice, they are using the Alzheimer research. We do use mice as Alzheimer research as well, but they do not naturally develop the amyloid plaque because we know that Alzheimer currently is because of the amyloid plaque. But what about the animal? We cannot develop it, but we always induce the particular disease. So this makes it quite a challenging model for a full complexities of the human diseases. The second one, because of the lack of human-specific disease mechanism. For example, like NCDs, diabetics, and the cancer, they always involve with what we call the intricate interactions that are unique, quite unique towards the human biology, because humans, for example, they have a microenvironment, okay, whereby we cannot mimic this microenvironment in the animal. Okay, later on we'll talk about the microenvironment. So we cannot mimic these microenvironments in the animal. So that's why we're having a problems to fully replicate in the animal model. Okay, because in humans, we do have our microenvironment itself, so we cannot duplicate the same environment towards the animal model. So it become a limitation as well. Okay, and then as I mentioned just now, poor translations to the clinical trial. Always when we are trying to do any medications, we have to go through the clinical trial. So despite if let's say they're having a success almost like 90% in the animal studies, but when it turned into humans studies, the drugs become fail. Why? Almost of the 90%, if let's say you do a clinical trial studies, okay, you can look at the prevalence or you can look at the trends of the clinical trial. Almost 90% have been failed, especially in humans. Why? It's because previously they using an animal model. Okay, so as I mentioned just now, we are lack of the similarity of the genetic factors, so that's why it can lead towards the failure of the particular drug as well. Okay, and then last but not least, also we are looking at the ethical concern as well regarding to the animal. So it become an ethical concern as well, especially for using the animal, because variations in the genetic backgrounds and we know that environmental conditions among us can lead to inconsistent result as well. So that's why I was saying that each of these particular animal studies, they have a limitation as well. So then the second challenge that we are facing currently is because of the drug screening. Okay, so what happened is that drug screening is a quite important step, as I said just now, before a pharmaceutical company can make it as marketable. They have to undergo some of the development process as well, whereby they enables the researcher to evaluate the efficiency and the safety of the potential therapy before we want to go for advanced or before we want to go for the clinical trial as well. So in the traditional methods, we always use 2D cell culture. Okay, we use a 2D cell culture and then we use the animal model as well. whereby this model, as I mentioned, these two models basically have a limitation. What kind of limitation? They have a limitation in predicting the human's response accuracy as well. So this whereby we want to introduce the organoid, whereby they can offer a transformative benefit for the drug screening. Okay, so the reasons why first we can see is the enhance of the physiological relevance as well. So the organoid basically they do mimic the 3D structure and the cellular diversities in the human tissue as well. Especially when we want to replicate the organ-specific functions, whereby closely but more than the 2D cell lines. Okay, later I will tell you what is the difference between the 2D and the 3D cell lines. So, for example, if let's say a liver organoid, they can even metabolize the drug similar towards the human's liver. Okay, whereby they're making the toxicity screening is more accurate. Second, because we wanted to look at the high throughput screening. So organoid basically they can generate in a large quantity, okay, and they can be standardized towards the drug testing as well. So when we are doing organoid, basically we can do it by batch, okay. I still remember back then when I'm doing this organoid, I can even make a very big barrels of the organoid as well. So they can be generated in a large quantity. So because of this, we call it as a scalability. They're able to be scaled up, okay, in a bigger amounts, whereby they allow the researcher to screen hundreds of the drug candidates concurrently as well. Okay, that's means in one time, I can screen all the particular medications or the drugs that is available, okay, by using the same batch of the particular organoid as well. So part of it, we also have tumor organoid, whereby they can be quickly evaluate if, let's say, we want to look at the chemotherapeutic response as well. Okay. Then C, we can see personalized medicine. So personalized medicine, basically, the patient's derived organoid. We do have patient-derived organoid. That means we can take the patients, okay, if let's say they're having a cancer, in particular cancer, lung cancer, for example, we can take the particular bloods and then we can derive it as a organoid as well. For organoid, especially when they are related or relevance with the inherited disease, they are very good model. Because why? If let's say the particular individual have the mutations on the particular genes, when we are taking the bloods and then we make it as an organoid, it will have the same mutation as well. So that's why they can be work as a personalized medicine, whereby we can do a specific individual testing on the medication. Okay, you can combine with the NGS as well, and then you can do your own testing as well. So that's why I say that organoid is perfect personalized medicines, whereby we can take a patient-derived organoid and then they can give us opportunity to test the drugs on the patient-specific model. That's means if let's say you are rich enough, you can even take the bloods and then produce it, become the organoid, and then you can test with any of the test medications once to see if let's say they're having a reaction as well. That's what we call as a personalized medicines. Okay, so for example, if let's say you're having a tumor, people having a tumor organoid, from a patient biopsy, whereby they can help to identify which of the chemotherapy regimen is more effective, and then we can optimize some of the treatment's outcome as well. Okay, so last but not least, of course, as I mentioned just now previously, it's also because of the ethical and the cost advancement as well. Because comparing by using animal, we can reduce the reliable on animal testing, and organoid basically they address the ethical concerns and a lower preclinical research costs as well. Okay, because I believe that most of the drug medication company, when they're trying to do the experiments, they will try to reduce the cost as well. So by using animal is quite costly. Okay, so we can have alternative kind of like method is by using the organoids. Okay, so over here what we can see is the needs for the human specific models. So need of the human specific model over here we can see they do address some of the translations gap as well. Okay, so over here we can see the differences if let's say we use the animal models and then we use the 2D sculpture, or we use using the 3D organoid method as well. First, if let's say you're using animal models, the genetic compatibility is lower. Okay, as I mentioned just now, that is the limitations of using animal model. But if let's say you're using 3D organoid, you can see the genetic compatibility is higher. Because why? Because we are using the human specific. If let's say the individual having a particular disease mutation, we can withdraw the bloods and then I can make it as an organoid as well, and then I can run the experiments. That's why we call it as a genetic compatibility is higher. Or we can talk about the disease complexity. If let's say they're having a retina disease on the eye disease as well, okay, because it's quite difficult to mimic in the animal model. So for animal, it's quite low. For 2D cultures, sometimes it's very difficult for us to have it, but 3D organoid is possible, okay, because we derive it and then we having microenvironments to mimic the human diseases as well. Regarding to the ethical concerns, because we are using cell, okay, so the ethical concern is low compared to using the animal model. So over here, I also make a process as well, whereby you can see the comparison between the traditional process and the organoid process as well. Okay, that's why I call it as a proposed process, whereby this traditional process, basically they are reliables on the animal model, frequently will lead to a critical success but fail in the clinical trial. Okay, it's quite difficult because of the poor translations to the humans from the animal to the human model. So our proposed kind of like process, okay, by using, okay, the human specific organoid, we can improve the predictive accuracy, and it can lead towards a higher clinical trial success rate as well. So the key innovations that we're having over here is that we can use the human specific models, okay, in the biomedical research, whereby it can reshape our ability to study the particular disease, or we want to develop some of the therapies as well. Okay, so traditional model we do have, for example, like animal studies and 2D culture as well. Okay, we want to explore some of the disease mechanism. However, as I mentioned just now, some of the model, they often fail to accurately mimic the complexity of the human biology. Okay, so the mismatch, basically there are significant implication whereby they also can lead towards, for example, let's say you want to look at the cancer, you want to look at the diabetics, or you want to look at the neurological disease as well. That's the reasons why we need a human specific model. Okay, first, they are accurate representations of the human biology. Second, they are bridging between the translations gap, the one that I was saying just now. And third, they are more towards the modality of the disease complexity as well. Okay, we can customize the particular disease accordingly as well. So that is the beauty of using this particular cell. And as I mentioned, I always say that when we talk about the organoid, they are the stem cell breakthrough. Okay, so here I'm going to introduce one of the most common use currently as that we approach by using the 3D organoids. Okay, so actually, what is 3D organoid? At least some of you guys have heard of stem cell. Okay, in stem cell we can have 2D, we can have a 3D stem cell. Okay, when we talk about 3D, we call it as organoid. Okay, so over here, organoid basically they have been introduced quite early as well in 2010 and earlier than that as well. Okay, to study some of the humans' biology and disease. So as I mentioned just now, organoid usually we call it as a 3D dimensional as well, because this structure we can grow it or we can cultivate by using in vitro model of the stem cell, whereby they can have the same architecture and the functionality with the real organ as well. That means if let's say I take in a stem cell, I can make it as a cardiovascular disease, or I can make it as a pancreatic, or I can make it as a liver as well. Okay, then they will have a multi-layer. What make it 2D and 3D different is that 2D basically they have only one single cell, a similar cell. But in 3D, you will have a multi different layers of cell. That means they have a combination of cell. Okay, not one single cell, but they are combining. Okay, that's why they call it a 3D. They're having a different types of cell in one particular organoids. Okay, that is the beauty of using the organoid. So when we talk about the organoid, basically they can be cultivated in different methods. We can use stem cell. So organoid basically they begins with either embryonic stem cell, we call it as a ESC, or we can use induced pluripotent stem cell, iPSC. In my methods, I usually use iPSC. Okay, I Because one is that iPSC having a low ethical problems compared to the embryonic stem cell. So that's why I prefer to use the induced pluripotency stem cell as well. So for the differential, we can use mediums, inductions. Okay, they have a different protocol as well. But the most importantly, when you want to grow an organoid, we can use a special growth factor as well. So we can do growth factors and then what kind of like nutritions and the signaling molecule as well to derive the particular cell into a specific organ, specific lineage. That's mean we want to know if let's say they are ectoderm, endoderm, so we can derive it particularly towards endoderm or extoderm. Okay, and then in this environment also we can create what we call as a 3D culture system. So unlike 2D culture, organoid basically they are grown in a 3D matrix. Okay, we call it as a 3D matrix. For example, you can find a words we call as a matrix gel. So this matrix gel basically they provide a support for the cell to self-organize, become an organ-like structure. Okay, so this type is very important because they want to mimic the complex interactions that can be seen in a real tissue as well. So followed by maturations. What makes it different 2D and 3D is because of the maturation period as well. Okay, so it can grow over the day to week as well. Okay, in my cases, I have grown an organoid for 150 days just to get an organoid as well. But you can improvise the protocol, so you can make it faster as well. Okay, over here I give two examples of the organoid, whereby you can see there's a brain organoid, okay, and the kidney organoid as well. On the left side is more towards the coloring. We're using the immunofluorescence, okay. So, like brains, we have Fox G1s and then we have TUJ1 as well. So TUJ1 is basically it's more towards specific towards the neuron. So you can see the expressions of the markers in the particular organoid as well. So that's why we want to have the, we call it as a characterizations. Okay, we want to characterize if let's say the particular organoid contains of the different tissues or different cells that we wanted to look at. Okay, so that's why organoid basically they can mimic towards the particular organ, not cell, but towards the organ. Okay, because when we talk about organ, they are combination of different cell becoming a tissue as well. So that's the beauty of by using the organoid. Over here you can see the process of the in vitro. I give you the outlines on when does it begins, right? So in early foundation, since 1907, I guess, we already started to begin the journey of the regeneration medication as well. Okay, up to 1987, then we start to have the breast epithelia into a 3D duct, and then we start to begin the stem cell innovation. If let's say you're looking at here, starting from 1998, okay, that is when the begins of the stem cell, we call it as embryonic stem cell. So that is a very high breakthrough during the moments. And in 2006, we started to have the human iPSC as well. Okay, so later on you can check what is the human iPSC. Basically, we can take the matured cell to become a immature cell, and then we can derive it, become a different types of tissue as well. Okay, so that is the revolutions of the regenerative medications, whereby we able to use as a patient's specific model. Okay, and then starting from the organoid breakthrough, the organoid start to pick up during 2008 up to now. Okay, so begin after 2008, you can see they start to develop the cerebral cortex organoid, and to currently the latest one, we already have a testis organoid as well. Okay, my model, when I'm doing studies back then, I'm always focusing on the retinal organoid as well. So we already started to use the retinal organoid to do some of the disease modeling and then testing on the particular medication as well. Okay, so over here we can see the applications of organoid. If let's say you see at the bottom B parts, as I mentioned just now, organoid basically they are more invisible in humans area. For example, like in biomedical research, the first one we can use it as a precision medicines. Okay, because organoid they allow the drug testing on the patient-derived tissue, whereby we can tailor the therapies according to the individual. Okay, second is more towards the immune microenvironments. What does it mean? Is because this model, the organoid, basically they can help us to explore the interaction between the immune system and the tissue as well. So we can study on the immune response. Okay, this is what I'm always using when I induce some of the treatments or disease modeling. Then I will wanted to know what is the immune have been respond as well. So we can even provide some of the immunotherapy research as well. Okay, third is the organ development. So organoid they provide a window into the developmental biology, whereby we allow them to studies on this organogenesis in real time. That means how does it develop, which come first. So that is the things that the organoid allow us to make a studies as well. Okay. Number 4, we can make it as a patient's organoid biobank as well. So we can call it as a repositories some of the patient-derived organoid, whereby we can accelerate the research of the genetic disease and the therapy screening as well. Okay, so part of it they can also become an embryonic developments, or we want to look at the neuroimmune study as well, because the organoid basically they mimic the early embryonic stages. They also enable the studies on how does immune system interact with the nervous system as well. So over here, we can see how does they derive the organoid. So organoid, as I said, the source it can be by different types of like stem cell. First, it started with the blastocytes. Okay, so blastocyte basically from the embryonic stem cell, or you can derive it by using a reprogrammed fibroblast. Like me myself, my study back then is focusing more on the fibroblasts. Cell reprogramming, that's when we use the Yamanaka factors, okay? Because iPSC basically we conduct by using the Yamanaka factors. So in this, we can reprogram the fibroblast into a pluripotent state. So this method basically they able to allow the organoid research by providing more patient-specific model, okay? Without any ethical concerns, because we don't use the embryonic stem cell, okay? Or you can also use the adult stem cell as well. So we can isolate some of the tissue from the intestines, the liver, and the kidney as well, whereby this multipotent cell will retain the ability to self-renew. Okay, because some of these cells they're able to self-renew, for example, like liver. So we can have a more organ-specific cell as well. Okay. Then we also have a different germs layer specification. When you want to derive an organoid, a stem cell, it's very important for you to know your organ is belong to which part of the germs layer. Is it endoderm? Is it mesoderm? Or is it ectoderm as well? Okay. So endoderm basically they form some of the organoid, for example, like intestines, the lungs, the liver as well. Okay. For mesoderm, basically they give a rise to the structure, for example, like a kidney, blood vessel, and some of the cardiac organoid as well. Okay. While ectoderms, they are basically lead to a formation, for example, like the brains and the retina organoid as well. Okay, so when you want to derive the organoid, it's very important for you to know which germs are they derived from, because each of the different germs have different growth factors. So just now I did mention about 2D, right? Okay, for those people who are not familiar with the stem cell, we always have a monolayer cell. Okay, we call it as a 2D cell. That's why they call it a monolayer cell. So monolayer, the other name for it, we call it as a 2D cell. Basically, they are single cell. Okay, as I mentioned just now, they are more towards the single cell types. So for spheroids, okay, if let's say you ever heard of the spheroid basically they are derived from the same cell but have a multiple layer. Okay, so usually there are multiple types of like different type of cell, but almost similar as well. Okay, but organoid, they have at least one epithelial and one mesenchymal cell type as well. So they are more towards combinations in organoid. For 2D cell, basically they are more flattened. Okay, because they only have one single cell, that's why they are more flat. But because spheroids, they have a multiple types of the cell, so they having this kind of like architecture more towards the natural cell morphology. Same as organoid as well, they are round in shape as well. Okay. But monolayer in 2D, they're able to be replicates the tissue organs, but not but it's very low towards the drug specificity test as well. Okay, so that is the advantage and disadvantage of using the 2D stem cell versus the particular organoid as well. Okay, so over here you can see I gave some of the example as well, like HeLa cell. People who are working with cancer, we know that we can use the HeLa cell, but basically it's just a monolayer cell, 2D cell. Okay, well, if let's say we are talking about organoid, so basically you can do a mini guts, mini lungs, mini heart, mini brains, or mini eyeball as well. Okay, that is the beauty of using the organoids. I think just now along the way I also mentioned about the special, the unique features of the particular organoid. So over here I just going to have a very brief introductions. We have a self-organizations. So stem cell basically within the organoid they have an innate ability whereby they are self-organized into a distinct kind of like layer and the structure as well. They do mimic the real human's organ. Okay, because if let's say the human's organ have this particular cell, different layer of cell, they do have a different layer of cell, and then they have also the ability to driven the cell to inherit the programming and interactions with the environment as well. Okay, for example, we can look at the brain organoid. So they are developed in the cortical layer, so they are resembled in those humans brain as well, whereby they enables the studies of the complex neurological response and some of the synaptic connectivity as well.
Excuse me,
Okay.
Mr.
Yep.
Henke. I think it is very interesting, but time is up. So I think that
Okay.
we will have the question and session, answer question and answer session. Then I will give the maybe some time for them to ask the question. I think that it is very interesting about topics about the organoids. Then there will be some questions from the audience. For the audience, I think that when you have some questions about these topics, please raise your hand. Any questions? Yes, I think that also there are some questions that organized by okay, if you would like to ask a question, please raise your hand, please.
Sorry, I think I saw one of the fatigue Sauki is raising the hand.
Hello, excuse me, sir.
Okay.
Oh, hi.
Thank you. Before I want to introduce myself, my name is Muhammad Sauki. You can call me Sauki. And I'm from the program studying of nursing at the Healthy Polytechnic in Borneo. And I want to give you a question, sir. How to ensure that the use of 3D cell culture, the model of technology complies with the principle of research ethics?
Okay. Can I capture the last words? The research what? Sorry. Can I get the last word? The research what
Can
just
you
now?
repeat the questions?
Yeah. I didn't capture the last words.
Fatih? Can you repeat the question, please?
I'm sorry.
Oh.
How to ensure that the use of 3D cell culture model of technology complies with the principles of research ethic?
Oh, okay. Okay, thank you so much. Okay, now I get it.
Thank you,
okay,
sir.
Okay, welcome. So, as I mentioned just now, that's very good. Okay, because when we talk about the research ethic, basically, our main concern, especially when you're using the humans sample, right? So, back then, it quite an issue when we are talking about the embryonic stem cell. But as I mentioned just now, depends on what kind of cell you are using to derive the particular organoid. If let's say you're using iPSC, so the issue isn't big for the human ethical. Okay, of course you have to go through some of the normal kind of like ethical process, but the process isn't as difficult as what we are applying for the embryonic stem cell. So if let's really depends on what kind of stem cell you are using. Okay, because to derive this particular organoid, you can have different type of cell. You can either use the embryonic stem cell, you can either use iPSC stem cell, or you can even use the primary cell as well. So ethical issue wise, I would say is that for organoid is not really having that big issue compared to by using the animal models. The nice things about using this organoid is because it's human based, patient based, and then ethical issue they are more lower compared to using the animal model. Because why? Because this is a cell derived. They are not using animal model. We don't have to sacrifice the particular animal to get the cell. We can derive the cell in the plates. We can just take a petri dish and then you can grow your cell. So they don't have any ethical issue compared to using the animal or using the humans primary cell culture. So that is the beauty of using this particular organoid because you can just derive taking a blood. So a normal process of ethical, human ethical, you can just like getting the ethics and then you can derive the bloods. Once you have the bloods, you can derive the particular cell by using the factors. So if let's say you're talking about the ethicals, we don't face any much of the issue regarding to the ethics because personally when I'm running the organoid as well, to get approval from the hospital is quite easy because I just need to get the blood samples and then I show them the procedures of doing the organoid. Basically, there are no killings of the animal involved and I can just take a petri dish, grow inside the lab. So it's quite convenient regarding towards the ethical issue. Yeah, thank you so much.
Thank you very much. Fatih, what do you think? What do you think about the answer? I think that Mr. Henke already answered very well. What do you think? You are muted.
Thank you, sir. This is a good answer. Thank you so much.
Okay, welcome.
All right, thank you very much. Okay, it comes to the questions that is organized by the committee here. There are some questions from our audience that categorized by the committee. The committee, please display the questions. Okay, here we are. There are two questions. Mr. Henke, please answer this question. Time is yours. Sorry, Mr. Henke, you are muted.
So just now I have to stop the sharing so then I can look at the. How can organoid be used to develop more personal and effective therapies? Okay, so I can answer the first one first. So how can organoid basically develop more personalized medication? As I mentioned just now, the beauty of using the organoid is that if let's say I have these cancer patients, okay, osimertinib resistant, people having a small lung cell cancer on osimertinib. That's mean because we know that osimertinib basically they are using for the treatments of the cancer cell for the small lung cancer. But if let's say the patient having a medications resistance towards osimertinib, so we can take the bloods and then I can derive it as organoids. Okay, then I can even do a testing in a different medication as well. That's why I say by using this organoid, they are more personalized. Okay, or if let's say they're having a inherited disease, I don't have to induce the particular disease towards the animal. I can just take the patient's blood and then I can derive it into the stem cell and organoid as well. And then I can check what kind of medication have the effective dosage for the particular disease. So that's why I say organoid, they are personalized medicines. And I can say the effective of this particular therapy is very good. One of the things is that in my study back then, I also used the organoids and then I make it as NGS as well. We can even send it to the NGS and then you can look at the profilings between undergo treatments and wild types of the profiling as well. So that's why I say is that organoids, they can become a very personalized, especially if let's say we talk about very rare conditions of disease. Because if let's say we are talking about animal model, we cannot mimic the disease in the animal. We cannot mimic the particular disease on the 2D cell culture. But in 3D organoid, we can use it. Why? It's because we use the stem cell. We can just take the bloods of the individual, we make it as a stem cell, and then we derive into organoid. Okay, that's why I say it's very personalized. And part of it, if let's say you want to check a paper on organoid is also one of the most earlier transplantation. Okay, we can do organ transplantation. In Japan, they are the first organoid transplantations on the retina, on the eye disease. Okay, so I think started in 2017, if let's say I'm not mistaken. Okay, in the Rincon research lab, they did a studies on the transplantations on eyes. Okay, they take the organoids of the retinal pigment epithelium. Okay, and then they transplant it into the humans. So they success to have the visualized later on. So that is what we call as a personalized medications, okay, by using the organoid. So they become the test, they can also become the treatment as well. Isn't it nice, right? So the second one, can this organoid help to understand the mechanism of insulin resistance and beta cell dysfunction types in the type 2 diabetics? Yes, of course they can. As I mentioned just now, part of using this organoid, you can make it as a disease modeling, you can make it as a treatment as well. The beauty of it is that because we do know that some of the insulin resistant because of the mutation of a cell or because of the silencing of a cell. Can you do it on an organoid? Yes, you can do it on an organoid. Okay, we can combine some of the molecular techniques like CRISPR-Cas9. Okay, if let's say you are familiar with the CRISPR-Cas9, we can even use a CRISPR-Cas9. We can do a gene editing in the organoids. Okay, I have one paper back then. We are using the CRISPR-Cas9s to do a mutations. Okay, we can study on the insulin resistance as well. Okay, and then we can look at the cell dysfunctions, and then we can even do the treatment as well. So by using the organoid, if let's say you don't have the patients that have this particular disease, you can take a wild types, a normal organoid, and then you can use CRISPR-Cas9. You can induce the particular disease as well. So we actually I don't have the times, but actually I have a slide on people do a kidney organoid as well. Okay, and they even mimics the blood vessel mechanism as well when they're having a diabetics or they're having a kidney. Okay, so we do have this organoid on the kidney as well. So they did the studies on the insulin resistance as well. Okay, and if let's say I'm not mistaken, also, in my slide, if let's say I was be given, I can show you the clinical trials that have been conducted by using the organoid as well. Okay, because currently, some of the organoids they also undergo clinical trial as well. So, for example, like liver, kidney, also they did as well. Okay, so we do have some of the organoid that have been undergo clinical trial. You can search it in the clinical trial website as well. So we do using organoid to understand the mechanism and the treatments of the diabetic as well. So that's it.
Thank you very much, Mr. Henke. You have answered the question very well, yeah? And thank you very much for presentation. Now we come to an end of this presentation. Thank you very much for your kind attention and joining this international conference. And then as our appreciation to your presentation here, we are making or giving you an electric certificate. Please, the committee, please display the electric certificate for our keynote speaker. Here we are, Mr. Henke. Thank you very much for your presentation. I'm sure that we have learned a lot from your experience and your research. Thank you very much.
Okay, thank you. Thank you so much.
Right. Okay, it was Mr. Henke from Malaysia. Then it comes to our next keynote speaker, and our next keynote speaker is Miss Dr. Nursari Abdul Sukur, Magister of Midwifery. Hello, Miss Dr. Nursari, are you here? Are you here in the Zoom?
Yes. Yeah, I'm here.
Hello, good afternoon, Miss Nursari.
Good afternoon, Mr.
How are you today? How are you this afternoon?
I'm fine.
Very nice to have you here in this international conference. Then your title that is about literacy of anti-cancer substances in breast milk. Is that right?
That's right.
Okay. I think it's going to be a very interesting field. Then we hope that we can get new knowledge from your research. Then please, it is time for you to present your materials. Time is yours, Miss.
Okay. I will share my file. Okay.
Okay.
Yeah. Is visible? Is it visible?
Yes,
My
it's visible. Yep.
Yeah. Okay. Thank you. Do I go straight away? Do I go straight away, Mr. Harry? Away presentation. Okay.
Yes. Okay. Okay. Please, Miss. Yeah.
Thank you. Okay, ladies and gentlemen, and I share presentation international conference in Poltekkes Kemenkes Kalimantan Timur. And I have thema literacy of anti-cancer substance in breast milk on the feeding status of mothers. Background this introduction, WHO recommendation most effective ways to ensure child health and survival is to provide breast milk and breastfeeding coverage. Indonesia so encourage data nationally in 20 and 23 with a target 73 uh, uh, uh,
Sorry, we have some internet connection disturbance. Miss Nursari.
Okay.
Okay, right. Okay, please continue your presentation.
Okay. I continue my presentation. This is nutrition, macro and micro, has prebiotic, HMO, has antibody substance, has anti-cancer substance, bonding, economical and practice in for breast milk. This is can literacy of anti-cancer substance in breast milk be a strategy to increase breastfeeding coverage in my result? Next. Yeah. The region my result inhabited for by diet traits, this meal has a complex composition contain nutrition, immunity, bonding, more practical and economical, and currently also proven to have anti-cancer substance known as Hamlet. Hamlet is human of lactalbumin made lethal of tumor cells. The cancer is one the disease feared by the public, so the literacy of anti-cancer substance is very important to study whether it will affect the behavior of mothers to continue breastfeeding for the baby. Anti-cancer for breast milk now Hamlet is human of lactalbumin made lethal to human. Tumor cell is a protein lipid complex that kills tumor and immature cell, but leaves healthy, differentiated cell intact. The complex is formed from alpha-lactalbumin and oleic acid. Two composition in breast milk. This is now alpha-lactalbumin and oleic acid in half. Both which are component oleic acid, an important component in breast milk that is very abundant. Hamlet is the result of research from Lund University from Stephen Bock. This is Hamlet. Hamlet has several effects, including Hamlet induced tumor cell death similar to apoptosis. Hamlet doesn't damage full differentiated cell, not damage. Hamlet can attack multiple cell targets, including the EGFR signaling pathway. Hamlet can active mitochondria-dependent apoptosis. Hamlet may interfere with mitochondrial function and yeah, to conversation in this meal, Hamlet now alpha-lactalbumin and oleic acid. Alpha-lactalbumin is the dominant whey protein found in breast milk. Composition 25 until 20, 23 until 30% of the total breast will milk protein and contain amino acid for result musket 20 and 20. Alpha-lactalbumin start production from gestational age 80 weeks, 18 weeks. The weight variety of breast lesion benign and malignant none have found to contain alpha-lactalbumin with the exception of fibroadenoma from patients who are pregnant or breastfeeding patients. The result musket and oleic acid. Oleic acid content breast milk model weight makes up about 72% and the total fatty acid in breast milk, which consistent in oleic acid, palmitic acid, and linoleic acid, and total saturated fatty acid represented 42 half 7%, and the total fatty acid, the monounsaturated fatty acid content is 33 half 5%. If it which 84% is oleic acid. Breast milk production during prolonged lactation 1 year is very rich in oleic acid, fatty acid. The longer breastfeeding, the more oleic acid content. Oleic acid breast milk sample of lactation for women from Grenada using gas chromatography coupled with mass spectrometry result. Oleic acid is the most dominant monounsaturated fatty acid. 41 93%. More dominant 41 it's 937. Then the content of other fatty acids such as fartinic acid 27 X3% and linoleic acid hydrochloric acid and doxorubicinic acid or DHA and representative result Sanchez et al. 2021. Data the difference between different countries, between region with some country have preferred to effect business compensation variety. Oleic acid. The oleic acid content this milk the models make up about 72% of the total fatty acid. This milk consistent oleic acid and the mono oleic acid is chemical compound is the consistent component of fat has distinctive physical and chemical property that are different from other compounds. This is benefit of oleic acid and alpha-lactalbumin. Oleic acid one the effective fatty acid, the prevention of cardiovascular disease, Alzheimer's disease, cancer, colon cancer, skin cancer, prostate, breast cancer, uterine and ovarian cancer, diabetes, inflammatory and autoimmune disease such as rheumatic arthritis, osteoporosis, and neurodegenerative disease such as Down syndrome. Treatment with cancer cell with oleic acid suppress the HER2 oncogen which expressed in approximately 20% of breast carcinoma. Moreover, the ability of oleic acid to act synergistically with the monoclonal antibody trastuzumab, which is as a cancer therapy drug by targeting P185. HER2, Rizal Helios Wilton et al. 2000 et al. 2013. Despite a genetic history, breast cancer breastfeeding has been shown to reduce the risk cancer in women with history of breastfeeding. Although the specific cause is unknown, previous studies have also shown so the breastfeeding reduce the risk breast cancer. The longer breastfeeding, the lower the risk the breast cancer and also reduce the risk of the other reproductive cancer because the main component of breast milk are postulated in several research results. The alpha-lactalbumin and oleic acid are anti-cancer substance. Alpha-lactalbumin level are 37% high in mature breast milk than in colostrum and increase during breastfeeding even as total protein concentration decrease. And conclusion, the Hamlet research team believes Hamlet products a reaction with protein lipid once it's entered the gut called alpha-lactalbumin with the begin to target cancer cell. In a matter of few days, the cancer cell are attacked, killed, and secrete short urine. And two, literacy had an effect of breastfeeding status with some breastfeeding mothers and previously breastfeed and formula feed but return to full breastfeeding after the intervention. Yeah, this is my result. I already have to model anti-cancer substance in breast milk literacy model. This is I can not I can I will literacy for mothers in antenatal care until before breastfeeding for saat dia melahirkan ya for giving birth I can counseling for literacy that for literacy have the anti-cancer substance breast milk literacy. Okay, thank you, Mr. Alex. I can finish.
Okay.
I will finish.
Right. Thank you very much, Miss Nursari. It was very interesting presentation. You have already discussed about the anti-cancer. All right. On this breastfeeding. Yeah. So it is time now to have the question and answer sessions, and then I think that there are some questions from the audience. For the respective audience, please raise your hand. Ms. Nursari, so I think that there are also some questions from the audience, and then this is already categorized by the committee. Please answer this question. There are two questions here.
Okay, Mr. Hal. Okay, Mr. Halid.
Yes. Okay, please go on.
Yes, any question? Yeah.
Yep.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and greeting to Ms. Dr. Nursari Abdul Syukur. Let me introduce myself. I am Iman Ardiansa, the student of Health Polytechnic, Institute of Health East Kalimantan. And my question for Ms. Dr. Sari Nur Abdul Syukur is what is the mechanism of anti-cancer substance in breast milk and what factor can improve the baby's immune system? Thank you.
Okay, Ms. Nursari, can you get the questions?
Yeah. Okay. Yeah. And question for one almost is more almost all model is a question.
There was a question from one of our audience. Can you repeat the questions?
One question. This is.
What was the question,
Sir.
Mr.
Sir. Mr. Hal.
Yes.
Sir,
there is someone raising his hand. Okay, please state your questions.
Not one yet.
Coba diulangi pertanyaannya.
Not one. Not Imam Ardiansa. Not Imam Ardiansa. Question for once before Imam Ardiansa. Okay, share in PowerPoint.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Iman Ardiansa dari mahasiswa Politeknik Kesehatan Kalimantan Timur. Izin bertanya Ibu, bagaimana mekanisme zat anti kanker dalam ASI dan apa saja faktor yang dapat meningkatkan sistem imun bayi? Terima kasih.
Ya, oke, thanks. Pertanyaan yang pertama adalah yang tadi kita tanya, apakah bagaimana ASI begitu ya mengenal zat anti kanker. Saya mencoba menjawab. Almost all modern don't know him anti-cancer for breast milk because if they knew him, the world definitely give him. give him literacy as anti-cancer, not familiar from midwife, from medicine, because literasi zat anti kanker belum ada di di setiap kampanye ASI. Baru ada jika kita mempelajari tentang ASI ini. This is mechanism form ASI, literasi zat anti kanker. Zat anti kanker is Hamlet disease, maksudnya kebetulan saja diperiksa, tidak sengaja diperiksa, ditemukan waktu itu oleh Profesor Stephen Borg bahwa ternyata ada diteteskan ASI pada pada kanker, ternyata itu bisa menyembuhkan luka kanker tersebut. Nah, untuk mekanismenya sendiri, this is yang saya jelaskan di presentasi saya tadi, bahwa breast milk tadi terbentuk pada human alpha yang dikenal because now Hamlet human alpha lactalbuminate lethal 2 tumor cell is a protein lipid complex that kills tumor and immature cell but leaves healthy differentiated cell intact. The complex is from alpha lactalbumin and both of which alpha lactalbumin and oleic acid is component breast milk is very abundant. Hamlet is the result of research from London University by Professor Stanborg. Nah, the mekanisme Hamlet disease, the production Hamlet is production for pregnant, mother pregnant, and for lactation. Not the Hamlet, not production in for woman, but tetapi just production for antenatal, for pregnant and for lactation, atau for postpartum or breastfeeding. Hamlet disease production for 18 for 18 week and semakin banyak diproduksi jika diberikan ASI itu pada masa menyusui. Ya, oleic acid breast milk production during a prolonged lactation lebih dari 1 tahun, maka mekanismenya semakin akan diproduksi. Dan di mana kita dapat mengetahui produksi ASI banyak, semakin banyak menyusui, maka semakin semakin banyak keluar ASI itu sendiri. Dan kemudian juga apakah kita bisa mendapatkan selain di bahan makanan, ya, selama menyusui ibu hamil, selama menyusui ibu postpartum, breastfeeding, and pregnant, oleic acid in tumbuhan itu dapat ditemukan pada sayur-sayur hijau seperti seledri, sayur hijau, tetapi lebih banyak diproduksi kalau kita konsumsi itu pada santan, ya, kelapa. Lebih banyak produksi zat anti kanker tersebut. Bisa juga didapatkan di kacang almond, di kentang, tapi lebih banyak produksinya di santan kelapa. Kalau seperti protein atau intinya protein yang kandungan pada hewan itu banyak pada daging, ayam, kemudian ikan dan putih telur diproduksinya. Nah, bagaimana anti imunnya? Nah, tapi itu oleic acid dan alpha lactalbumin bukanlah anti imun, tetapi dia anti kanker. Dan anti imun di dalam tubuh ASI sendiri ada sendiri dia anti imunnya. Jadi sangat berbeda anti imunnya dengan anti kanker. Anti kanker itu diproduksi memang fungsinya untuk mencegah terjadinya kanker. Kanker apa saja pada bayi, kanker lambung, kanker dan hampir semua kanker bisa disembuh, bisa dicegah dengan pemberian ASI. Jika anti kanker sendiri hanya ada diproduksi pada ibu hamil dan ibu menyusui. Selama tidak pernah hamil, tidak menyusui, maka wanita tidak akan pernah memiliki zat anti kanker tersebut. Dan itu hanya dimiliki pada perempuan, tidak ada pada laki-laki. Sedangkan kalau perempuan tidak pernah hamil, tidak pernah menyusui, maka juga itu tidak akan keluar produksi tersebut. Jadi produksi itu akan terjadi pada minggu ke-18 masa kehamilan. Baru terbentuk zat anti kanker, alfa-laktabulin dan oleic acid. Dan juga tambahan saya yang terakhir ini, kalau misalnya yang bertanya, ibu-ibu yang sering memompa ASI dengan menyusui itu sangat berbeda. Jadi pada saat memompa ASI, maka zat anti kanker, alfa-laktabulin dan oleic acid tidak akan keluar, tetapi hanya keluar pada saat hisapan langsung bayi saat menyusui. Kenapa? Karena hisapan bayi ada beberapa rangsangan hisapan tadi dari hormon prolaktinnya, dari hormon kontraksi oksitosin ibunya, itu memicu untuk keluarnya zat anti kanker tersebut, alfa-laktabulin dan oleic acid. Jadi sarankan pada ibu-ibu yang menyusui tidak memberikan ASI, tidak mengeluarkan ASINya dengan cara dipompa, tetapi lebih baik berikan hisapan langsung pada bayinya. Oke, thank you.
Thank you.
Thank
you
you,
very
Mr.
much.
Khalid.
Yeah, thank you very much. What do you think, Imam Jensa? You understand about the answer from Ibu Nursari? Okay. Anyway, we will continue to the next questions that was organized by the committee. Please display the questions. Okay, there are two questions. Ibu Nursari, I think that these questions are from the audience that organized by the committee. Please answer the questions. Thank you.
Yeah, okay, thank you. Ya, pertanyaannya, answer one question. Almost everyone doesn't know is that anti-cancer bismil because anti-cancer in Indonesia and beberapa more result in Indonesia not specific ASI, spesifik penelitian tentang ASI. Yeah. In Indonesia, not research on bismil for specific anti-cancer because almost people tidak tahu ya, don't know is zat anti kanker because not familiar Hamlet in Indonesia. Not STEM ya.
Okay, it seems that Miss Nursari has the internet connection disturbance. So the two questions here. Number one, how far Indonesians community know about the existence of anti-cancer in the breastfeeding. Number two, how effective are the anti-cancer agents in breast milk in preventing or treating cancer in infants? And what type of cancer are more susceptible to their effects? While waiting for Ms. Nursari, I think that she has already answered the questions number one.
Ya,
He said
question
that
number one sudah saya jawab tadi
right.
bahwa hampir almost hampir semua orang ya, almost everyone doesn't know zat anti kanker because anti kanker is not familiar in Indonesia. Riset tentang zat anti kanker pun tidak banyak orang meneliti. Bagaimana apakah how effective are the anti cancer agent in breast milk treating cancer in Indonesia. Anti cancer belum berani digunakan sebagai pengobatan, tetapi di beberapa negara di luar mengolah pengobatan ini hampir mirip dengan komposisi ASI, tetapi komposisi ASI itu sendiri belum bisa dia menyamai ASI yang diciptakan oleh Allah Subhanahu wa Ta'ala. Dan juga beberapa tipe kanker yang sudah diobati ASI sangat banyak, ya, hampir. Penelitian menurut Batelho, ya coba saya ini kan tadi ya, penelitian the genetic history breast cancer breastfeeding has been shown to reduce the risk cancer in women with a history breastfeeding, also the specific cause in unknown. Previous study have also Batelho and results show that breastfeeding reduce the risk of breast cancer. The longer breastfeeding, the lower the risk of breast cancer, and also reduce the risk of other reproductive cancer, because the main component of breast milk are postulated in several research results that alpha-lactalbumin and oleic acid anti-cancer substance. Alpha-lactalbumin level are 37% high in mature breast milk than in colostrum, and increase during breastfeeding even as total protein concentration decrease. And benefit anti-cancer, beberapa cancer yang dapat diatasi oleh cancer, disease uterine colon cancer, skin cancer, prostate, breast cancer, uterine and ovarian cancer, and beberapa neurodegenerative disease such as Down syndrome. And for baby in model, for result mencegah kanker lambung pada bayi. Okay, Mr. Halid.
Okay, right. Thank you very much, Ms. Nursari. So you have already answered the questions about the mechanisms of literacy of anti-cancer substance in breast milk. And as you said just now, you explained that in Indonesia there are not many people familiar with this anti-cancer substance in breast milk. Okay, right. So so it is now we come to an end of our presentation. Then we are going to give you as our appreciation, we will give you a certificate, what we call an electric certificate. Please display the electric certificate.
Thank you, Mr. Khalid.
Okay, right. Okay, then thank you very much, Ms. Nursari. We hope that you can also join in our international conference for the next coming year. Then, well, audience, thank you very much for joining us for this international conference. Then it is time for me to end this conference, and then I will return this floor to the MC. Thank you very much, Hira.
Thank you, Mr.
Thank you
Khalid.
very much, Ms. Nursari. Hira, time is yours.
Yes. Thank you so much to Mr. Kholik for moderating our second session of panel presentation today. Our next agenda is the door prize for the most active participant. To our most active participant is Miss Kristinawati BR Halolo, Aziza Giafani Norsi, Desti Auranisa, and Irham Nur Yasin. For the names that has been listed, please contact the committee. Next is for the best oral presentation. The first one would be Dr. Joko Sapto Pramono, SKP, MPHM, with a total score of 56. Miss Kurniawati Dwi Utami, MPH, with a total score of 55. And Nurse Wafik Aurelia Novani, STR with a total score of 50. For the names that has been mentioned, please contact the committee. Next, for the best poster goes to Miss Firliani with a total score of 41. To Ms. Firliani, please contact the committee. Finally, ladies and gentlemen, we have now come to an end of our international conference. I hope you find the presentations of this conference to be informative and engaging. I would like to express my sincere gratitude to our esteemed speakers for sharing their valuable insights with us today. Thank you also to our organizing committee, volunteers, and all of you in the audience for your participation. I believe that this seminar has been a great success, and I look forward to seeing you all on our next event. As your Master of Ceremony today, from my deepest heart, I do apologize in case there were some of my mistakes and flaws in guiding this international conference. Billahi taufiq walidayah, wassalamualaikum warahmatullahi wabarakatuh.